this morning I told our Congress President that everything went so well, including the live cases. All of them were successful. Congratulations. The topics were very brilliant, and on the top of it, the discussion. As you told me this morning, a meeting without discussion is just a meeting. And some US meeting where we go, there is just the presentation, and then we go out. Here in Europe, we like to discuss, and it's very good. You have to keep this program for next year. Now we end with the peripheral vascular intervention. And I think we start with our beloved president, Ivo Petrov.
Thank you, Jack, for the introduction. Thank you, everybody, for joining us so early in the morning, Sunday morning. But let's say science is important. So I will start with a topic that used to be controversial during the last 5 years, but it's becoming not so controversial thanks to the advancement in the techniques and the technology. We know very well that from multiple trials that for arterial hypertension, that is one of the biggest killer nowadays. The lifelong polypharmacy definitely is failing. There are many reasons, but the adherence to therapy is very low in most of the trial. Even within the trials, the adherence to therapy is not more than 50% of the patients, and this is leading to huge gap in the control of the hypertension. In fact, Stefano Taddei did a very nice investigation showing that put together of uncontrolled and resistant hypertension, in fact, more than 70% of the patients are not controlled. So we have a huge gap to reach in hypertension control. The first interventional approach is the idea for an interventional approach to treat hypertension is going back to the 1948, in which in this first publication, in fact, the gangliotomy, the surgical gangliotomy was performed, and on the abdominal and thoracic level, and the hypertension was immediately controlled. Yeah. You see, immediately after the gangliotomy. Unfortunately, this surgical procedure that was extremely efficient with sympathectomy, this Splanchnicus sympathectomy, was extremely efficient to control the hypertension, but unfortunately it was related to significant peri-surgical mortality and complications. Later, the catheter-based denervation in animal experimental trials showed the same, absolutely the same efficiency like the surgical splanchnicectomy. And in fact, this push up the advancement in different catheter-based techniques on the level of the renal sympathectomy, carotid stimulation, and also other devices. To be fair, nowadays we had the biggest data set for renal denervation, and about the renal, both afferent and efferent sympathetic nerves, denervation on the level of the renal artery is very efficient, because it resulted that the sympathetic nerves on around the renal artery are like gathering the sympathetic signals from all the zone. So it means when we are performing sympathectomy on the level of the renal arteries, in fact, we are blocking a huge mechanism of both efferent and afferent stimulation. Regarding the trials, we know very well that the Simplicity hypertension 3 trial was not negative, but was neutral. So we couldn't, with this sham control randomized trial, we couldn't show bigger result with sympathetic denervation, catheter-based sympathetic denervation, compared to the sham procedure. But in fact, we have learned a lot from this trial. So this neutral trial was very important for us. We have understood first that the operator has to be experienced. Unfortunately, in Simplicity 3 trial, 70% of the operators had less than 5 renal denervation procedures before being included into the trial. So they were not experienced. And this led that more than 60% of the patients received between 0 and 2 denervation points. In fact, they were not treated. And we have learned by the Simplicity 3 trial that there is an incremental effect of the number of the points that denervated, so ablated. So it's important to make more points, and not only more points, it's what I'm saying here, that the number of denervation points is very important. But it resulted that also the density of the nerves is also differential. So the biggest density is distally, and in Simplicity 3 trial, the denervation was performed only in the proximal segments, not the distal. So it's important to make a distal denervation as well. And also by circumferential observation, it resulted that it's better to go circumferentially, not only one side. And it's very, very interesting into the post-hoc analysis to see that more points we do, more circumferential denervation we do, the bigger and more distally denervations, the bigger is the effect. This is the so-called, we called it Y pattern. So to treat not only the main vessel, but also the big branches. What means big branches in the context of the new spiral catheter? Every branch that is more than 3 millimeters can be ablated with the new catheter. These are our results. This is the we did a trial, comparative trial between the Y pattern and the simple main artery ablation, and it resulted that both systolic and over the night hypertension, average hypertension is better controlled in the Y pattern. And this is a simple case, a 53-year-old male with extremely bad control, extremely bad control of the hypertension on 6 medications. And during the 24-hour hypertension control, he had values up to 220 of systole. And in this gentleman, as you see, the catheter is in the branch, and we did all the branches, and at least 12 points of ablation per artery, at least 12 points. And you remember that there were between 0 and 1 points of some patients during the trial. So this was the old version. With the old version, we were following also not only the visual notches, but also the decrease into the impedance. So in order to be sure that these points are denervated. And this is the result in this particular patient. So not only the control is better, but the peaks of the hypertension disappeared. And in our daily practice, in many cases, we see exactly that the peaks of the systolic hypertension disappear. This is very important by prognostic point of view. You probably remember that the majority of the acute events are happening during the night and the morning, when we have, because of the adrenergic system stimulation on wakening up, we have the peak of systolic pressure and more events. And in fact, this strategy is applied with the new spiral version of the a radiofrequent ablation, so circumferential, 4 points circumferentially, and this is in fact how to perform the procedure. It's relatively easy, but in fact in hypertensive patient it's not so easy because of the tortuosity of the aorta and the angle of arising of the renal artery. Because of that, we are using, in our hospital, we are using upper approach, brachial or renal, because it's much easier to selectively cannulate the renal artery that is going downslope, and to get supra-selectively into the renal artery in order to have predictive result. So after the cannulation of the renal artery, we are going, the new version is on wire. This is very important because with a simple coronary, 0.14 wire, we selectively go in all the branches and we put the spiral catheter in all the branches that are more than 3 millimeters in diameter. And on such a way, we are performing a really good ablation of all the territory of the sympathetic nerve into the renal artery. And it's also very important to emphasize the anesthetic. So we do all the patients under conscious sedation. It's a must. And as a trick, we put lidocaine, local anesthetic, even within the renal artery in order to preclude the pain within the renal artery, and it works very well. So it's very nice. And on such a way, I mentioned already that at least 12 points per artery, so at least 24 points ablated per patient. And in fact, this is how the trials, in fact, are performed. And these 5 trials, 3 with radiofrequency ablation and 2 with ultrasound, have shown very good result. And on such a way, these very well-controlled trials, we have in fact 2 groups that are formatted, sham group and denervated group, with both techniques, radiofrequency and ultrasound. And the comparison between this group is tremendously in favor of the renal denervation. So there is a statistical significance both for the sympathetic and for the systolic and the diastolic pressure. And this was confirmed also in several registries, like the Japanese registry, the Global Simplicity registry. So this was confirmed by the daily life practices as well. And it's very important, this is the so-called therapy that is always on. So it doesn't depend on the willingness of the patient to take the medication or not to take medication, it's always on. And the other very important detail is that the morning hours control of the hypertension, it's definitely with huge statistical significance in favor of the renal denervation. It's very important to emphasize that it's durable, and it's based also on some data that Stefan, our friend Stefan Tunef, will show us this afternoon, more data regarding the basic science behind the renal denervation. And this is, and also it's very important that there is no any signal regarding the safety. So in most of the trial, the complication rate is around 0. So 0, 0.1, 0.2, very low complication rate. Our proper complication rate of big complications is 0. Of course, no mortality, no surgical intervention additionally. We had only 2 dissections in the beginning. Because the previous version, not the spiral, the simplistic catheter, with the flex catheter was a little more bulky, and we had 2 dissections, only one of them was stented. This was everything in our practice. After this meta-analysis of 5 very well-controlled sham trials, many consensus documents were published, including the European consensus. In fact, now we are on the phase after the enthusiasm, the disappointment. Now we are on the curve of the reality. And the reality is showing us that if done properly with experienced operators, the renal denervation procedure is efficient to control the hypertension in resistant to treatment patients. And this is the European document. And I'm absolutely sure this was discussed several days ago during the TCT. That is a high time to go into the real practice for the renal denervation for particular group of patients. But this particular group, I'm absolutely sure, will be expanded over the group of resistant hypertension. Here are going to be included patients with extremely high values of the arterial pressure, patients, diabetic patients with tachycardia, patients with extremely high cardiovascular risk, in which the hypertension control is very important in order to improve the prognosis. And during the TCT, there was a very interesting and very positive surprise. The surprise was the 3 years follow-up of the neutral Simplicity 3 trial. What is the surprise? That on the 3 years control, it resulted that the medication burden was lower spontaneously. The classes of medication remained the same, but the number of the pills was reduced in the treated group compared to the sham control. And despite the reduction of the number of medications, the systolic and diastolic control of the hypertension was better into the treated group. And the most convincing for me is the crossover. So the patients that were not treated during the index procedure, after the 6 months, they were allowed to cross over to treatment. And it resulted that there is a repetition of the same result into the crossover group. So this is the treated group. You see extremely better control to the sham. And this is the crossover group. So this non-treated in the beginning group, after going to the crossover, so receiving the treatment, they have exactly repetition of the same result like the treated. So more than obviously, it's a consistent result during the time, and it's very important to know that. So thank you very much for your attention.
Thank you very much, Ivo. I have a question of timing regarding this technology. Can you explain to us why we had a break of 5 or 6 years regarding the beginning of the theoretical experiences? It was 5 or 6 years ago. Then a stop. All the company went out the project, and now you are back in business. What happened during this gap? It was strange for us.
In fact, there are two companies, of course, radio frequency ablation Medtronic catheter and the ultrasound based. So there are two methods of ablation, and I cannot remember the name of the ultrasound company, but in fact they have also very similar hypertension solo and radiance solo trials. They are showing very similar result. So more than obvious, in case there is a good ablation of the renal nerves, there is a good result. And after having during the time, we have second generation of both technologies, so it's important to go up with the technological advancement. And the operators into the trials were much more experienced. So these two factors were very important to improve the results into the trials. And I think that this data gathering is helping us to have the reality in this procedure.
Present.
A quick question, Ivo.
Yes.
In vascular surgery, we're very familiar with sympathectomy. And either you can operatively go in and feel and see the ganglion and remove it,
Yeah,
to create an effect, or you can use chemical sympathectomy where you don't see it. And in that circumstance, there is a variation of anatomy, and sometimes you don't always get a response that you wanted to. And I'm wondering if, for you, you get some patients where you're disappointed because the anatomy of the sympathetic chain and nerves is variable, and maybe one day it might be more possible to more accurately get to them. But is that something you notice, that you are disappointed occasionally with some of them?
Great point. There are many trials, many small trials, trying to examine the point, what is the situation with the sympathetic tonus of a particular point before being denervated. So there are several small trials trying to show impedance and sympathetic activity of a particular point before being denervated. Wow. And this is probably will be the future in order to have more predictive result. Good. And thank you for mentioning the sympathectomy during surgery, because Juan Carlos Parodi has a very interesting trial during AAA operation. He divided this, 90% of these patients are hypertensive, no doubt. And he divided a group of patients during AAA operation with sympathectomy and group of patients without sympathectomy, and he showed significant difference between the groups in favor of sympathectomy surgically. So it's confirming once again the value of this idea.
Yeah. Terrific.
Thank you.
Thank you very much. Well done, Ivo. The next presentation is on visceral artery interventions, and we're going to hear from Dr. Janenvinska.
Thank you. Thank you. The echo Doppler diagnostic of visceral arteries is normal Doppler finding of visceral arteries, proximal abdominal aorta, and inferior vena cava in cardiovascular disease. Stenosis and occlusion of visceral arteries, arterial aneurysm, arterial pseudoaneurysm, arterial dissections, compression syndrome of visceral arteries, and arteriovenous fistulas. The visceral arteries can be improved at 75 to 25 degrees by moving the transducer distally and tightening it cranially. This is the normal sonography of celiac trunk with PSV 113 and EDV 30 centimeter in second. Normal spectral Doppler of the superior mesenteric artery before meal and after meal, and the results are relevant when the examination is being made before meal. Normal Doppler sonography of the inferior mesenteric artery with longitudinal view, spectral Doppler of normal inferior mesenteric artery, conditions leading to difficult visualization of the visceral arteries are obesitas, dyspnea, shadows of arterial calcifications, and elongations, and arrhythmias. Stenosis of celiac trunk may be asymptomatic thanks to the collaterals created by superior mesenteric artery or the congenital anastomosis of the visceral circulations. Stenosis of celiac trunk can be formed by atherosclerotic plaques, aortoarteritis, compression syndrome from malignant and benignant formations, and Dunbar syndrome. This is the different types of stenosis of celiac trunk with atherosclerosis, fibromuscular dysplasia, and Mal's syndrome. This is the atherosclerotic stenosis of celiac trunk with stenosis more than 50%, with PSV 276 and TDV 137 centimeter in second. This is a stenosis of celiac trunk with post-stenotic dilatations and stenosis more than 70% with PSV more than 318 centimeter in second. This is a critical stenosis with PSV 466 and EDV 220 centimeters in second. Stenosis of mesenteric artery. The stenosis is with a ratio woman to man 3:1, with symptoms pain after eating, weight loss, bloating, diarrhea, and gastroparesis. The stenosis of mesenteric artery are often asymptomatic, and significant stenosis are found in 14 to 24% of patients after abdominal angiography. Progression of symptoms of symptomatic intestinal ischemia is about 15%. This is a stenosis of the superior mesenteric artery with more than 70% stenosis, with PSV more than 500 centimeters in second. Occlusion of superior mesenteric artery with occlusion of proximal segment is this. This is a stenosis of mesenteric inferior artery, more than 70%. The visceral or mesenteric ischemia are acute or chronic. Acute ischemia caused by most often embolism, thrombotic occlusion, and most commonly affects superior mesenteric artery, osteoproximal stenosis or occlusion, previous symptoms of chronic myocardial infarction, other atherosclerotic manifestations. Powerful collaterals in the mesenteric circulation, celiac truncal lower mesenteric artery, reduce the risk of intestinal infarction. Immediately life-saving is revascularization, and complications are peritonitis and septic shock. Early signs and symptoms of acute mesenteric ischemia is 80% of cases included severe abdominal pain, nausea and vomiting, melena, history of chronic atrial fibrillation and cardiovascular disease, and peripheral atherosclerosis. The treatment of acute mesenteric ischemia of superior mesenteric artery is in patients with acute thrombotic occlusion. Endovascular therapy should be concerted first-line therapy for revascularization, and in patients with acute embolic occlusion of the superior mesenteric artery, both endovascular and open surgery therapy should be considered. Chronic ischemia is stenosis or chronic occlusion of celiac trunk and mesenteric artery, is atherosclerosis of the aortoiliac segment in 20%, vasculitis and aortoarteritis in young patients, fibromuscular dysplasia and compression syndrome, and AAA. Paraclinic studies are anemia, leukopenia, electrolyte abnormalities, hypoalbuminemia secondary to malnutrition, and symptoms of chronic mesenteric ischemia are abdominal pain after eating, weight loss of appetite, fear of eating or changing eating habits due to pain, nausea and vomiting, constipation or diarrhea, and history of cardiovascular disease. The treatment are endovascular treatment and stent implantation, air or intraarterial fibrinolysis, thrombectomy, and bypass surgery, and therapy with anticoagulant therapy and antiplatelet therapy. The protocol for visceral interventions are 6 French right brachial approach, 6 French right Judkins guiding catheter, 0.014 coronary wires for the predilatations coronary balloons, and balloon expandable peripheral stent. The endovascular treatment of visceral ischemia acute and chronic in cardiovascular center city clinic for a period of 5 years are 185 on celiac trunk is 96, superior mesenteric artery are 83, and inferior mesenteric artery 6. Primary patency for 1 year is 18%, reintervention in 19% or 10.3%. Secondary patency are 19%. The remaining 10%, the control examination has now been carried out or should be after 1 year. The clinical case is female in 37 years old with aortoarteritis, diabetes type 1, dyslipidemia, arterial hypertension, smoker. Present in clinic with abdominal pain, heaviness, reduction of body weight 20 kilogram in 7 months, nausea, diarrhea, and pelvic claudication in 20 meters walking distance. The ultrasound diagnostic are with occlusion and critical stenosis. Occlusion is in left and right subclavian arteries, left and right superior femoral artery, superior mesenteric artery, and inferior mesenteric artery. Critical stenosis are left and right renal artery, celiac trunk, and distal abdominal aorta. This is the CT aortography. From the selective coronary angiographic, the result is left main stenosis and high-grade stenosis of LID. High-degree stenosis of celiac trunk before and after implantations, the stent implantations Herculic. This is a final visceral angiography. Critical stenosis of left renal artery before and after implantation of stent. Stenosis of right renal artery before and after implantation. At the next stage, coronary revascularization was performed and peripheral revascularization is planned. The conclusion is diagnostic and treatment of chronic and acute mesenteric ischemia, prevent dangerous life-threatening conditions. The highly specialized diagnostic method echo Doppler and CT angiography are affordable and height effective, and the effectiveness of endovascular treatment is life-saving with low procedural risk and good long-term result. Thank you.
Fantastic. That's a huge experience.
Yes.
I think compared to most centres around Europe, that's a huge experience. And
yes.
I would hope that you would put this together in a major publication, because certainly I do think it's a situation that we tend to undertreat because we're very concerned about harming
yes.
the blood supply to the intestine. You can do without your inferior mesenteric artery, but my goodness, you can't do without your superior mesenteric artery.
Yes.
Any questions, or was that really very, very clear? Good.
For me, it's really difficult to indicate the treatment because it's difficult to know if the symptoms are related with the lesions or no. And the evaluation by echo Doppler, angio, and so on, it is not easy. It's variable. Mm-hmm. You can have a Doppler velocity of 200 today and 300 tomorrow, mm-hmm. and it's variable. Which is the role of CT and CT angiography in the diagnosis? Do you think that are more important than the other method?
Yes, for endovascular treatment is important. For know where is the significant stenosis and treatment in this part of stenosis.
Thank you very much. Good. Any question in the room? No. So I think we have a live case going on. Is it possible to be in contact with them? 1 second. Thank you, madam. Are they ready? Or yeah. So this is a city clinic, and they are going on. I think it's
for live case presentation.
Live case number 1.
Yes. The live case is male in 65 years old, clinical presentation with pelvic and femoral claudication, both sides at 200 meters. History of coronary artery disease after myocardial infarction and primary percutant coronary intervention with the death of 3 of LID and left circumflex artery after. Risk factor of atherosclerosis, smoker, male, years, dyslipidemia, and arterial hypertension. The arterial ultrasound and ABE, the patients are with aneurysm of abdominal aorta in infrarenal segment with maximal diameter 54 millimeter and dissection with thrombotic stenosis of the true lumen. Common iliac artery in both sides is with stenosis and dilatation to 18 millimeters, 70% stenosis of left renal artery, and ABA in right is 0.55, in left one is 0.6. This is a result of Doppler, AAA with desiccation, and left renal artery with PSV 220 and 94 centimeters in second. This is a left common iliac artery with stenosis and right. This is a CT aortography with aneurysm and stenosis of renal artery and distal and stenosis of the true lumen of distal abdominal aorta. Let's show the live case.
Доктор Станков, може да кажете добро утро на публиката. Good morning, everybody.
On screen, tell us what you plan to do.
We plan to do implantation of the stent graft below the renal artery and see the stenosis of the left renal artery, because from the Doppler and the CT, we have the dates for the significant stenosis of the renal artery. We use radial approach for the angio and both femoral artery for the stent graft implantation, using the manta for the main body side approach and angiosil for the contralateral approach.
Good.
Now I prepare the left femoral artery for the main body and manta. I do little
Cut down.
of the skin.
Cut down. I do the translation. How many French is the introducer?
14.
No, it's not.
14 French. We going to sheetless. We
Better.
show yesterday. We always do it sheetless.
Yes. It's
Three, lucid, no.
smoother.
Дай ми долу да гледам.
What type of graft do you plan to implant?
Endurance 2S. Main body from the left side, I told before, and okay. Дай ми сега катетър и традиодачи. Now we change the wire, the Stork wire with the Steve wire, Lunderquist, and going with the main body.
You choose the left side to introduce. The main body.
Yes. For the from the left side, because when I'm planning and measure the aneurysm and the iliac artery, the left iliac artery is better for the bigger sheath and main body.
Okay.
For that, we're going from the left side with the main body.
Okay.
Main body, please. Let's do a angio. You see, we have the pigtail from the radial approach
Yes.
for the angio, and we have control in the whole time of the procedure. It's our protocol for the whole TEVR and NEVR procedure.
Which is the lowest renal artery, left or right?
We see the left renal artery, it's calcificate from the CT, but from the angio, it's not have the stenosis. And the patient is without any uncontrolled hypertension. It's with very good control of the arterial pressure with only 3 pills. And for that, I think that it's not necessary to do anything of the renal artery.
No, okay. Don't touch the artery. Which is the lowest, left or right?
Left.
I think it's right.
Now we're going to do the roadmap.
There's an answer.
Are we ready?
They are similar level.
Пламен, моля те за секунда не дишай. Дишай нормално.
May I ask you something? Can you hear me?
Yes, ask.
You have mentioned that you have used a Manta device on the left side and an angiosil on the right side.
Yes.
So far I know the angiosil is up to 8 French, but you're going to use probably 14 French limb. How are you going to close you?
If you allow me, Theo.
Yeah.
I'm Ivo. Hello
Hi.
again.
Hi,
I'm
hi.
already in the cut lab. If you allow me, on the contralateral side, we are using sheetless technique. So the French size of the contralateral limb is 12 French, and we have more than 500 angiosil 8 French performed for 12 French sheet off label without any problem. So it's quite efficient to use the angiosil up to 12 French, and this is our usual practice during the last 5 years, without any significant complication.
So what's the operator doing now? What is doing? Can you describe the...
Absolutely. Now Dr. Stankov is opening the main body, and he's opening now the free flow, you see, but still the ipsilateral limb is not liberated. So still the position is extremely stable. The stent graft in this situation is very stable because on the level of the renals, the free flow is already open. And on the distal level, it's still connected to the delivery catheter. In usual practice, we stop now and we cannulate the contralateral limb. And after cannulating the contralateral limb, we allow ourselves to liberate the ipsilateral.
This is what we are doing now. So we are, of course, first we are going with a simple Judkins catheter. In case it's not successful, we can proceed with Amplatz or another. You see, the specific case here is that the distal aorta, just before the bifurcation, is relatively small. And you see that the contralateral limb is relatively compressed by the stenosis. I'm trying now to cannulate the contralateral.
Which wire are you using?
The wire, we like very much the floppy Stork wire. Of course, it's possible to use angulated Perumo. There are different options, but the Stork wire is really very, very gentle, and this is one of the advantages. That's an angular.
Don't you think it's the most difficult part of the intervention, this recannulation of the contralateral side?
Many times.
Sometimes it takes some long time.
Yeah, sometimes it's quite difficult. In case it's not successful, we perform from the upper approach, because in 100% of the cases we have radial or brachial access in order to have the possibility to make angio, but not only for angio, for cannulation of the contralateral limb. Sometimes we are coming from above. We are cannulating the contralateral limb, and with a snare, we may externalize the wire, and on such a way, ще направим графия. Okay. First. Okay, I will change now the catheter with a left Amplatz. That is more predictable. Right. Okay, right. By the way, in this situation, Dr. Stankov remind me that it's not left, but it's right. In this situation, it's really right. Amplatz is a very clever decision, because the space is not big enough for the left one. And because of that, we are proceeding now with the right Amplatz. Okay, now we are with the right Amplatz. We are just below the gate of the contralateral. We sometimes we change the projection.
Angle.
Yeah, it's we changed by purpose the projection now.
We could see, Ivo, on the imaging that there is quite a lot of narrowing at the lower aorta, and
exactly.
I think this is your difficulty just now.
Exactly, this is the challenge in this case, that the distal aorta is quite small. It's quite small, it's very compressed, and the limb, the contralateral limb is, the gate is compressed. Let's go from the... Most probably in this situation, we are going...
Might need to come from above.
Yeah, we are to proceed from above. No, it's probably a side. No, it's a side.
Do you want us to let you work and go on with a presentation, or do we stay live?
Let's go live for the access from above, because it will be interesting for the audience to take a look how we are doing the procedure.
All right.
So we are going from the 5 French sheet from above, and okay. Okay. So you see the pigtail entering in the надолу. Махни увлечението. Okay, I will change now for a angulated catheter, right Judkins or vertebral. Дайте един вертебрал. Дайте очи. Ето очи. In the meantime, Zoran has opened the contralateral, the ipsilateral limb to the end and has removed the delivery system nose. And now I'm with the angulated terumo from above, and I will put a long vertebral, 5 French, and we are going to be ready to snare the wire in order to spare time.
Do you always take a brachial approach in
Absolutely.
the same time?
Always.
Always?
Brachial or radial, yeah.
Always.
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 Yeah. We like to have always, in any moment, the possibility to make angio. So it's a very good imaging control.
All right.
And you see, this is the vertebral catheter coming from above. I'm in the contralateral limb already. You probably see that it's even for the angulated terumo is quite challenging to cross the compressed gate. You see?
There is a compression.
It's unbelievable.
Yeah, you did it.
Ivo, does it
yes.
make sense to make a small angioplasty from above?
Absolutely, we have discussed this in advance as an option. But now after crossing and snaring, it will be hopefully much easier. Да имаме готовност за един 7 мм балон. Okay, I crossed you. You saw probably that I crossed already. And we are trying now. Okay, stay there. Дай го още малко нагоре. С някаква ангулация се опита и аз опита да го прибера сега. Давай, сега. Регистрираме го това. Yeah, и we...
You got it.
Yes.
You are around the other guide. Be careful.
Nice, beautiful. Now I can guess it will be a little easier because we are already, you see, we are already down, and we are going to make
True.
You turn around the other guide.
Did you see? Yeah, I'm with the angulated terumo inside the sheet.
Ivo, can you image the bifurcation for us, please, just to see the configuration of the two wires?
I think you turn around.
For example, you can see probably in case we zoom the camera.
Be careful.
In case we can zoom the camera, you are going to see I'm showing here the wire, the tip. Yep. You see, една бяла марля искам. Okay, I'm showing on the white both the tip of the angulated terumo. Okay, here is the tip of the angulated terumo. And the entrance of the angulated terumo, please show my hands here. Okay, okay, a little more, okay. You see, I'm here from the brachial. So this is the proximal part from the brachial, and this is the angulated tip from the femoral. So we have already true and true.
On the fluoroscopy, Evo.
Exactly.
If you
I
can
will
go to
do
the
that.
bifurcation, we would just like to see the configuration
Absolutely.
of the wires.
Absolutely.
We were a
Okay.
little-
We are going to dilate now, like Theo advised us. So we are here from femoral, going to the bifurcation. Very compressed gate, contralateral gate, because of the small aorta. Going up, you see the wire going to the brachial.
Can you give
So
a little
this-
bit of contrast from the right groin, just to see what happens?
Oh, yes, absolutely. We can do that. Prăscă mi contrast. Super.
You don't hear
Okay,
you.
we are going to
Turn
make
around, the second guy.
gentle.
Because you have to be careful not to be around the contralateral wire, because then you're going to have...
It's what we think.
We're noticing that the wires, Evo, are not coming out like
Okay.
a Y shape.
We will see.
We'll see.
Okay.
Yeah.
Let's see.
We
Maybe
need-
not.
It may not matter.
Maybe not.
Yeah. I'm going to remove the vertebral catheter now. We are going to cannulate with the vert from below. Peter от ласто. From below. Ласто, чекай. Peter от ласто, че е по-късо.
Given that circumstance, Jacques, would you consider balloon dilatation to make some space?
No,
if
I
there
do
is-
that at the end,
Do it at the end?
after the
Right.
covering of the bifurcation by the graft. So I do dilatation protected, in a protected manner.
We are going to perform probably very undersized pre-dilation of a 6 millimeter balloon. And yeah, we have now through and through.
We'll see what happens.
I'm crossing now. Okay. You are probably right that we are around the wire. We are around the wire. That is not dramatic because the ipsilateral limb can be much easier crossed. So, не, просто искам катетъра да качим, значи тук дърпаш хубаво и аз дърпам здраво. И I'm proceeding very slowly with the vert and we are already up. Okay, we are up. Now, I'm removing the wire, the terumo, and we are putting now the stiff wire. Okay, so we have secured the contralateral. And okay, the contralateral is very well into the thoracic aorta, and we can put here bigger sheet on the ipsilateral and proceed with the resolution of the twisted wires. Thank you. Thank you for telling us.
It's normal. We support you.
Absolutely. You support us absolutely very well. Okay. Again, the pigtail is on the level of the renal arteries. And now we are putting big sheet on the ipsilateral. Okay. And we are going to cannulate again for untwisting the wires and to facilitate the advancement of the device. Okay, putting the big sheet here is enough. Tribut Fischer's French wood is lens. We are going to put within the big sheet a 6 French sheet in order to avoid bleeding from the big valve. Probably you know this trick, this maneuver, because some big sheets, unfortunately, they tend. I just put a 6 French sheet within the big sheet, and we don't have no one drop of red blood cells. And we are going to proceed now with the right Judkins and a gentle catheter and gentle wire in order to cannulate again, recannulate the ipsilateral limb in order to untwist right Judkins or vertebral. And this stuff. Okay. This is the right amplatz. This is the favorite catheter of Zoran. It's because it's quite well steerable. Okay, we are going to remove the stiff wire, and we take the gentle stork or angulated terum, it doesn't matter. But the stork is very nice because it's really very gentle and it cannot cause any damage anywhere. And I'm going to re-annulate. Yeah, they were twisted, definitely. I have felt it. They were twisted. You see, even the ipsilateral was a little twisted and a little compressed because of this small aorta. So we are proceeding up with the catheter. Great, and we restore now the Lunderquist. And we are going to have 2 Lunderquist in the ipsilateral and contralateral. And by the way, what do you think about making a kissing predilation in order to increase the diameter of the distal aorta and proximal iliac?
In fact, it's up to you.
Okay.
As you
I would
feel.
be favorable to that personally. I think that's a great idea.
I think this is a good idea. Give me please 2 balloons, 8 by 60, for example, also Nashise.
There's quite a lot of common iliac disease as well as narrowing at the lower aorta.
Absolutely. There is a strange combination.
It'll be calcified as well, Ivo, so I think it's a great idea to make your space.
It's a strange combination of aortic aneurysm, limited aortic dissection, and distal aortic stenosis. In fact, it's I will ask my friends here from the technical staff to show you the picture from the reference screen, and you can observe there how compressed is the aorta on the distal part. And this definitely, in order to accommodate the 2 grafts, parallel grafts of the bifurcated body, we need definitely to increase the diameter. And because Jacques mentioned to make a covered predilation, we are going not to make covered predilation, but in fact we are going to make undersized predilation.
Yeah, good idea.
Yeah, just to open a little and to allow accommodation. And because we are using a very low profile balloon, they are 6 French compatible. And as you can observe, we are crossing with both of the balloons through the big sheet in which we have 6 French sheet, and we are crossing again now from the original contralateral 6 French sheet, and we are ready for a kissing balloon maneuver.
Ivo, can I ask you something?
Of course.
What is the diameter of your distal neck?
The diameter of the distal neck.
Where you're performing now the angioplasty.
Exactly.
Probably 12 or 14 millimeter.
It was, I think, 13.
Because the problem is each limb is around 14 millimeter from the endurance to S.
Absolutely.
That
Absolutely
means
right.
my experience is if you are performing an EVAR and you're doing kissing balloon because you have any concern about compression, then perform the EVAR completely and put 2 balloon expandable stents. Otherwise, you may have an occlusion of one of the 2 limbs. Because
absolutely right.
Self-expanding stents, the one is always compressing the other. Nobody knows which one will compress.
Absolutely right. Yes, you're absolutely right. We have calculated all that, and because we saw that there is atherosclerotic disease, and we are almost confident that with the balloon inflation, this atherosclerotic disease will step down. And this will liberate space enough in order to accommodate the original stent grafts. But of course, in some cases with late compression, we have put balloon expandable stents, kissing balloon expandable stents, in order to increase the diameter and to stay for definitive increasing of the diameter of the stent grafts. And I would prefer to make an angio now and to be sure what is the situation. So the pigtail is pigtail. Okay, give me the wire. Yeah.
Stork. I want the head of the pigtail to be just above the rhinos, and because of that I will straighten the pigtail now. On such a way, okay. And we are going to make an angio of the bifurcation that was just kissed. Okay, here is enough, absolutely fine. Ready to inject?
Yes.
Okay, we are going to see now the image.
Perfect, John.
I think it's absolutely enough. Theo, what do you think?
You will see at the end, perform completely the EVAR, and then you have to do different views in order to see if there is any compression, especially regarding the velocity of the flow.
Down и леко дясно. Very good. Айде леко ляво. We are going to perform a little more. More. Okay.
But if you say that the distal neck is 13 millimeter, even if it looks like, I would have concern about the patency of the limbs. Because, as I said, it is 28 millimeter if you add both limbs in a very short and narrow distal neck.
It doesn't look too bad, Ivo, does it now?
I'm absolutely fine.
Yeah.
You probably can see that there is a small contrast on the right side entering the plaque. In fact, this plaque will be post-dilated after putting the, like Jacques mentioned, protected dilation. So we are going to proceed. Yeah. Okay, go. Give me the endurance contralateral first.
We're going to the parallel opening to the stent graft.
Ivor, very nice selection of the case, very educational.
Yeah, there are several small but very important details that are very, very important to be discussed in such cases. And of course, for beginners, in such a situation, it's probably not advisable to start with such a case. But the other thing is that the team has to have everything on the shelf. So, like you mentioned, the team has to have balloon expandable stents, snares, additional stent grafts, and so on, in order to avoid any situation.
Надя, да правим още едно към едно.
Okay, super. And the patient is under conscious sedation, absolutely calm.
Тя е 12
Resilient.
чувството.
You are going to see now, I mentioned already, we are making the implantation sheetless. So we have 14 French on the ipsilateral side that will be closed by manta. And now with a 12 French, you see this is a 12 French, 12 French. And we are going to predilate. At that moment, you are going to see пламене. Това е лекичко отваряне на дупчицата, нормално да усетиш. Окей, това беше. This was the predilation of the site, and now we are going with the contralateral limb sheetless in order to reduce the need for bigger sheet and to have the possibility to close with the angiosul. Пламене пак може да усетиш нещичко, но вече ще е по-малко. Това беше. Okay, super. Okay, it's very important now to take a look.
Дай пас.
To take a look at the limb that we predilated. No resistance, zero resistance. So the idea of predilation was not bad. And we are going to position now the contralateral.
You have not done any measurement. Are you very comfortable with your preoperative measurement for the length?
Yes,
Okay.
yes, we are absolutely. And as you know, we have the angio possibility in any single moment. We are going to perform by the angio, we are going to perform a roadmap, ready for a roadmap. Пламене, моля те, не дишай за секунда. Good. Okay. Both internal iliacs are very well seen. Okay. Не е нужно да го ма.
This is a question. In case of long iliac like this one, are you trying to go very closely to the hypogastric, or you just want to cover 2 centimeters of common iliac?
In fact, we have the possibility not to be so close to the iliac because this is absolutely a healthy zone. So we are going to be at least 2 centimeters below the bifurcation, and it will be absolutely enough to have good closure. Okay. We are proceeding again, contralateral sheetless.
Мъсни го, Перо.
Okay.
Little more up.
A little more up. And also here to be parallel.
Right.
Okay. We can make angio. Пламене, моля те, не дишай. Чудесен си, дишай нормално. I think we are on a healthy zone distally. Proximally we have absolutely sufficient overlapping. What do you think?
It's excellent, excellent, Ivo.
Okay, we are going to proceed with simultaneous opening.
Ела на пуски тук лекичко.
Okay.
Тук.
There is a small ballerina configuration that will stabilize even more. We are proceeding with a simultaneous opening. Давай.
Is there any specific reason for simultaneous opening? Because you're making your life harder?
No, not exactly, because in our practice we are ballooning with the compliant balloon always. Even in simple cases we are ballooning the bifurcation especially.
Okay.
So some operators, in simple cases, and even the company doesn't
I didn't have any resistance. This is important. I didn't have any resistance of removing the nose of the delivery system. So it means that we have relatively good space. So we are putting now the sheets, and after that we are going to perform the reliant balloons kissing post dilation. Okay, this is the 12 French, and we are going to put the 14 French on the ipsilateral. And we are going to proceed with 2 reliant balloons. Okay, putting the 14 French here, and we are ready for the reliance. 2 reliant balloons. Чакай, нека да. Да. Готов ли си? Аз съм готов. Айде голямото. So we are removing the dilators just before putting the reliant balloons in order to avoid long-lasting bleeding by the valve of the sheet. Okay, and now we are already there. Okay, we stay here with the first balloon, not more. The idea of ballooning is not to touch the barbs, of the free flow, in order to avoid damaging of the. It's in fact not dilation; it's a molding with compliant balloons. It's a molding.
It's reliant.
They are compliant balloons. It would be interesting to see the trajectory here. You see, there was no any resistance. This was the compressed gate. And okay, we are now on a good level there. You see that we are covering the markers of the covered part, but we don't reach the zone of the barbs. And this is a gentle dilation of the principal gate. And now, of course, with 1 balloon, and now we are going to proceed with several kissings. Very gentle here, at the entrance of the 2 limbs. Here is very important. Go. Enough. Now we are on the most important level, the anatomical bifurcation. I think it's not bad. We didn't have any resistance.
You are very coordinated together. It's very nice to see.
Yeah.
Good team.
After 12 years of working together, we are definitely very well coordinated. Okay, remove this one first. Okay. Up to the valve in order not to bleed. Okay, and there. Valve. Okay. We are now going to be ready for injections, and as you can see, we emptied the big syringes because the sheets are more or less subocclusive, and in order to have really flow to see the ceiling, we are going to make gentle suction during the injection of contrast. Пламене, моля те, не дишай. Inject. We are suction. Пламене, дишай нормално. Okay, let's see. The renals are there.
Seems good.
I think it's fine. We can measure, by the way, the pressure.
Yeah, good.
We are going to measure the pressure and to compare left and right pressures from the femoral sheets in order to be sure that the grafts are not compressed.
Visually, it's not compressed.
Okay, so you are going to take a look at the hemodynamics now. I will ask our guys to put the hemodynamics on the screen. Yeah. So you can see on the left side, the, let's say, non-compressed side, it's 150, the systole, and now we are going to measure the previously compressed side after some flushing. Okay, flush. And we are measuring the compressed side. Yeah, it's a little higher than the uncompressed. Let's see from the
So,
brachial.
I think that, and a very good remark, Dr. Stankov proposed to measure the brachial. So in fact, it's a aorta.
So what are the values? 150 left and right?
Yes,
Yes.
it's, this is aortic at the level of the renals, 157, 160. Okay, 150, yeah, 155, 157. And there was 157 on the right and 151 on the left. So it's practically equal, aortic and both iliacs.
Good.
Yeah, what do you think? I think we are done.
No endolic, good
No
perfusion.
endolic, yeah.
You can stop.
And the left renal artery looks an awful lot better than we had expected.
Thank you.
It's a miracle.
You see, there is a ballerina, and this is absolutely very good because the system will be really very stable. And I think it's absolutely enough with this situation because the patient, by the way, had claudication. So it means the distal aortic stenosis was significant. And now with this, in fact, we did like an ankle brachial index at that moment. In fact, it's aortic iliac index. It's not ankle brachial. But with this index, he will be absolutely asymptomatic. So we treated both the aneurysm and the claudication condition.
It's a very good result. Tell
Okay,
me,
we are going to proceed. We are going to proceed with the closure devices. We are going angio-seal on the contralateral, and I would like to show. I showed yesterday the manta, and I would like to show, hopefully, positive experience with 12 French because it's off-label. I have to admit it is off-label. We are using.
it's between you and me.
Yeah, it's off-label, but despite it's off-label, we have very big experience. There are, I don't know, probably at least 312 French accesses closed by 8 French angios, and we are going to see what will happen now, because all we know that during live cases there are some surprises.
Everything is more difficult.
So, here is the bleeding moment. Again, inside, bleeding. So we are removing everything in the angio-seal, including the wire. Unlike, I'm putting now the anchor. And like I mentioned yesterday, because the hole is 12 French, so with the pulling maneuver, we have to be very gentle in order not to externalize the anchor. So after having even the small resistance, like in this moment I have small resistance, it means the anchor, the plug, is inside and it's just below the hole on the anterior wall. So with a gentle push, pulling, and now is the moment of the truth. Let's see. You see? This is the result. 8 French angio-seal, just small several drops. Probably 2 minutes of compression, it will be absolutely sufficient. You see? It's fantastic. Okay.
You will be okay.
Absolutely. So,
we're going with the
okay.
Dr. Stankov will do the manta. In the meantime, I'm compressing very gently with 2 fingers, and we are going to make a final angio. In fact, this is one of the advantages to have the above the renal approach, renal radial or brachial approach, because we are going to perform not only final angio of the aneurysm, but also we are going to perform final angio of the closure device site. So it's definitely also important. And in this situation, in case we have any complication, ischemic or bleeding complication, we can put a 6 French long sheet, 90 centimeters or 110, depends on the height of the patient, how tall is the patient, and we can immediately go to the problematic site and resolve the problem. Of course, okay, this is the manta. Both sides are...
Pero колко беше?
Okay, 4 plus 1, 5. So,
Поддържа за секунда.
okay, there. 5 is the level of opening the small lever here and going up a little more perpendicular. Пламена лекичко ще заболи, нормално е, няма страшно. Приключваме, да знаеш. Okay. Up to the first click, we are waiting. First click. So into the window there is a red marker. When we see the red marker, this is the first click. There is a red and green. So it means we have the first click. We wait a little in order the collagen sponge to be activated by the blood. And we are proceeding to the second click, and the window is totally red already. Okay, so, and we can observe with the camera, please, the camera, both sides. You see? Manta side, and the angiocele side, here. Manta and angiocele.
Good.
So, no bleeding. This is the moment to cut the suture. And we are done, and now we are going to check the permeability with an angio. Махай всички уличения, разкрачи леко. Okay, perfect. Още малко.
Още малко, пера.
Okay, 2 см надолу. За да видим бифуркация. Okay. We see on the left side the marker of the manta. Пламене, моля те, не дишай. Пръски. And we are going, this is the moment of the truth. Okay, no bleeding.
Looks good.
Patent.
Yep.
Okay, that's it. We are done.
Well done.
Thank you. Thank you for watching. Thank you for watching. And by the way, we are going to make a very interesting procedure. We are going to be ready probably in 30 minutes to show you the closure of a type 2 endoleak of a huge iliac aneurysm that was treated with a stent graft. We are going to put, it's a big lumbar artery feeding the aneurysm and increasing the diameter of the aneurysm, and we are going to put several coils through the lumbar artery. It will be interesting in the context of the presentation of Dr. Stankov regarding the procedures for endoleaks.
I think we have to go for the break now.
Absolutely. Go for the break, and we are going to be ready. Thank you.
We're
Thank
very
you.
late.
So there's a coffee break now, and then if you can come back as soon as possible, please, just to keep up to time.
20
And we'll
minute
start.
break.
We'll start with Haitham Hamid and his iliac presentation, and then the rest of the session.
It's better to start with him.
I think.
Well, the next talk will be the inner branch technology for the endovascular repair of thoracic aortic aneurysm by Dr. Theodosios Vistas.
Thank you very, very much. Let me see my presentation. Again, congrats for the nice organization and every year. Presentation, please. So, the inner branch technology is, let's say, the new trend in the treatment of thoracoabdominal aortic aneurysms. And today I'm going to talk to you about the first off-the-shelf device. So the two key features why actually we need the inner branch technology is that because the inner branch technology combines the advantages of the outer beaver and the FIVAR. So we have the flexibility of a branch, we have the better sealing and fixation of the bridging stent grafts, and we have the most important thing in the thoracoabdominal aneurysm, the less critical positioning of the branches. On the other hand, in case of, let's say, post-dissection aneurysms, in case of, let's say, very narrow aortas, we need the advantages of the fenestration. This is the device from inside. You see that let's say the length of the branches is inside the branch, and outside it looks like a fenestrated device. It is a polyester fabric with a nitinol stent. This is a really very important, let's say, feature because we are able now to do 4D flow MRIs to see how is the flow inside the branches and the graft. There are two markers. There are two e-markers. This device is coming from the company CryoLife. Now it's called Artivion, and it is a previous Jotec company. This is the reason why you see the well-known e-markers from the Jotec devices. And at the distal part, there is an 8 marker. This is the maximum overlapping, or let's say the minimum overlapping of the thoracoabdominal stent graft with any distal stent graft like a bifurcated endograft. Regarding the branches, this is, let's say, at the beginning a disadvantage for the user because there are a lot of markers but that you have to identify in order to be safe with the cannulation. There is for every branch a ring marker. This is the entry of the branch, and there are 3 tubular markers that these are the exit of the branch, the fenestration. Very nice configuration, well thought, because we have a peak-to-valley configuration for the proximal and the distal part that gives a lot of flexibility, especially if you have aortas that they have elongation, and at the same time we have a peak-to-peak configurations. Peak-to-peak means that the peak of the first stent is again is having the peak of the second stent, and this gives, of course, more columnary support. The position of the inner branches is again well selected according to a lot of CT angios and in order to reach the majority of the origins of the celiac trunk and the other visceral vessels. For the company now we are not measuring in clock positions, but we are measuring in degrees. That means the celiac trunk, the branch for the celiac trunk is at 23 degrees, for the LRA, for the left renal artery at 80 degrees, and so goes on. So nice feature is that we don't have only one device. The competitor is a T-branch device from Cook Medical, where we have only one proximal diameter, only one length, and only one distal diameter. Here we have 38 proximal diameter, but also 33. This is for more pararenal aneurysms or type 4 thoracoabdominals. We have a middle portion diameter that it is stable, 24 millimeter, and distal diameters between 30 and 26 millimeter. The branches have only one length, one diameter, 8 millimeter for CTA, for CT and SMA, a 6 millimeter for right and left renal, and the length is always 20 millimeters. The delivery system is very nice because it is self-explaining what you're going to do. That means you have the drawing branch orientations, you have the secure wire and PI tubes. I'm going to explain to you what does it means. And there is the guide wire flashing port. Each of these buttons, let's say, are presenting a tube that is getting through each branch, and by this way, all of these branches are pre-cannulated. That means if you see the right one is for the right renal artery, the next is for the SMA, the next is for the celiac trunk, and the last one for the left is for the left renal artery. And this is very, as I said, with numbers, wires, and it explains quickly what you should do. The inner branches have a unique technology that it is actually well designed. All 4 inner tunnels present with an enlarged oval-shaped outlets. This gives you the ability to be, let's say, to go very quickly to all directions, but at the same time, in case, for example, of the celiac trunk, you may have a diameter of 10 millimeters. You may need to, let's say, to use a balloon expandable stent of 8 or 9 millimeter, not to destroy the branch. This is a really important. Then we have an asymmetrical compression springs. This is important to maintain the patency of the branches and to avoid longitudinal compression, especially if you have narrow aortas. There is a stability seam. This is important not to lose the branch when you are getting with the sheaths inside, especially if you want to do a transfemoral delivery of the bridging stent graft is of unique importance. And finally, the major issue of migration of the stent grafts at the connection point can be now prevented with the migration reduction system. Now we are talking about precannulated branches. You see how it looks like. There are small precannulation tubes from polyamide. It is dedicated for 018 wires, important non-hydrophilic. And you can see that they are getting inside from the outer part of the branch, inside the branch, and then outside from the top cap. Now, how it looks like, you are opening the precannulation tube and then you are inserting the 018 wire. After the insertion of the 018 wire, you're using, as I said, non-hydrophilic, for example, Optimed ply wire is the best one. And then this wire is getting outside from the proximal part. You are taking it, you are snaring it from the axillary artery, and then after snaring it, you have the unique now ability that you're going directly to the right branch. You don't think of cannulating, of ensuring that you are in the right branch. With this wire, you know exactly, I have used the wire for the right renal artery, I'm going to be with my sheath in the branch of the right renal artery. Then you are not removing the through-and-through wire that you have created. You have now all the stability of the world to cannulate your renal artery. This is really important, especially if you have upwards orientated renal arteries, where you have the difficulties to get inside. And then still the wire is in place. You are going to bring also the bridging stent graft, and you're going to remove the through-and-through wire when you are inside with the bridging stent graft, and you're going to open the bridging stent graft. This is, again, of amazing importance for the stability of your intervention. This is a case report of a 72-year-old male with a previous abdominal aortic repair, pararenal aortic aneurysm. He has an accidental injury of the left ureter and the left renal artery. In those cases where we have this kind of, let's say, high creatinine value and this history, we are doing a renal scintigraphy in order to see what is the function of the kidney that has been injured. You see the 14%. So if we were not able to get into the left renal artery, we don't give a lot of care, because the majority, let's say, the main kidney function is due to the right kidney. This is what we are doing, a 24 French sheath from right. We're using 2 sheaths, one undergrade to the SFA, the other retrograde to the left common femoral artery, in order to have perfusion of the SFA in the right limb, in case that you have limbs that they have small femoral arteries, and not to avoid any ischemia. You're inserting the stent graft inside. You see how it looks like. You can see very nicely the E markers at the very proximal part. The way of the opening is the same like every Yotek procedure. You're just pushing and pulling, and here you can see this is the 2 E markers at that level, and in this position means what is the maximum and the minimum overlapping in case that you have an previous TVAR, and secondly, you know exactly that the E should be on the line of the wire in order to know that you are in an undergrade position with the branches and you are at 12 o'clock more or less. You see it goes very quickly. You don't need to make a lot of corrections. Now it's opening the branch for the celiac trunk. You see see the first marker and then the other three, which is actually the exit of the celiac trunk. Now we're opening the branch for the SMA and then the two branches for the left and the right renal artery. The good thing is that the branches, the exit of the left renal artery, the markers are at the lowest position, not at the same position with the right renal artery, and this is really good in order to be sure that you have not done any false rotation of the lumen. Then we are starting always with the SMA as the first branch. You see we're removing, we're opening the channel, we are flushing it, and then we're inserting the O18 wire, as I said, non-hydrophilic O18 wire, and then we are catching this from above with a snare, and after that we are inserting directly the sheath into the left renal artery. Here again, we have a 12 French sheath, and then through the 12 French sheath and 8 French sheath, we were a little bit lucky and we didn't use snare inside. We were directly in the catheter of the snare. This happens only once in life. And then we had the through and through wire. You see, we're removing then the PI tube in order to avoid any conflict with the sheath that is coming down. And by this way, we are able now to bring the 8 French 90 centimeter sheath. We are actually at the left axillary artery. And then what happens is that we are giving 2 mosquitoes. This is now the through and through wire, and look how easily the sheath is getting quickly through the SMA branch without checking if we are on the right branch. Whatever we have done, we are pretty sure that now we are into the aneurysm through the SMA branch. Then giving the sheath is staying there because you have the through and through wire, and then with a simple vertebral catheter we are inserting a softer Umo wire in order to cannulate the SMA. Then you will change the for a Rosen wire or an Amplatz wire, and then you're gonna be sure that you're gonna bring the stent graft into the artery. Due to the fact that you have the through and through wire, you don't need to go with the sheath inside the artery. This is of amazing importance, especially in the renal arteries. You see here is the VBX stent graft, and then we are opening this quickly and nicely, and at that time we have already removed the through and through wire. Now we are checking that we are in the right position, so the SMA has been already stented. Then second is the right renal artery, where you can appreciate the same procedure. We are removing the wire that it is inside and keeps patent the PI tube, flushing of the tube. Same procedure for the right renal artery. I'm going to show this, and then I'm not going to continue. Here again, this is the right renal artery. There was a very large right renal artery due to the fact that the kidney function was, let's say, was actually slowly performed only from this kidney. And here is the final angiography. Same procedure for celiac trunk and for the left renal artery. Here you can see the left renal artery was very difficult to get inside because of the narrow space, but this is the unique advantage of the inner branches. You can see quickly we can get inside, and we performed the rest of the procedure. So this is the final result, and actually it looks very good, and by this way we have performed then a 40 flow MRI. This is the first worldwide with this procedure when we can appreciate the shear stress of the branches and of the whole procedure. This is something that we're still collecting data to see if this really affects the heart function. Now, post-dissection TAAAs, here again, we were able with a re-entry catheter to penetrate the membrane and to get inside the false lumen, and this is the way that we are getting inside the left renal artery. There is no enough space there, but still with this device you are able to and to treat endovascularly this kind of aneurysms. So in summary, ladies and gentlemen, we are talking about a unique design and ability to cover the majority of TAAA's anatomies. It combines the advantages of both breather and fever, and the important key features are the inner branches, the precannulation of the branches. The branch of the left renal artery is lower than the right renal artery. It gives great variety of diameters, and it is conformable with all the standard Jotec, TIVA, River, and ISB devices. And as I said, important for young and for not experienced users, it is very simple to measure. Thank you very much.
That's fantastic. Please just stay if you can. Any questions from the floor? Because this is obviously a device which is simplifying what can be a very tedious, time-consuming, slow, awkward fiddle. And please tell us a little bit about that, because the time of operation, I know it's early in your experience, but have you noticed a huge change because of that?
Yes. So we have noticed huge changes in three important issues. First of all, on the delivery time. It is an off-the-shelf device, so you don't need to wait for the custom-made device. Second important thing is the time for bringing the sheath into the branch. So we know from the Cook devices that sometimes it takes a lot of time to get inside the branches, especially for the celiac trunk and the SMA, because you have to go on the raw or low position, and you cannot see very well the entry. By this way, you don't need to think about it. You're just thinking how I'm going to cannulate the artery. And the third, and in my opinion, the most important issue is that it gives amazing stability regarding the cannulation of the renal arteries, because if we have a cephalad orientation of the renal arteries, it is always very difficult to have stable position to do all this curve to get deep into the renal artery. With this stable position of the sheath, you have all the pushability to do this.
What is the timing post-operatively of your MRI imaging?
This was around 6 months.
And MRI is a very difficult exam to perform. People claustrophobe or afraid don't like this type of examination. Is it a long-standing examination?
It is around 30 minutes, because actually what it is not a dedicated MRI, it is a cardiac MRI.
Do they accept?
Yeah, they accept it. Because
to stay 30 minutes in the box?
It has to do with how you convince them. If you're doing it in a diplomatic way, yes.
we used to do that. Thank you very much.
You're welcome.
Well done. So the next presentation is coming from the operating room, where Zoran has been working with Ivo on the last case, and is about the management of endoleak. Have we got the connection yet, or would you like us to go?
Otherwise, we go on.
Maybe they're busy, huh?
They are very busy. It's bloody.
Well, why don't, if they're not ready, we could go on with another paper. Would you like us to do that?
Yeah, we let
Ivo,
them work,
Andrea.
and then they go back.
Добре.
They're not ready, are they?
Do you hear me? Hello?
We can hear you.
Great. Okay. We have the idea, in order to be more demonstrative for you, to illustrate the next presentation, next topic about endoleaks. That, in fact, is one of the biggest problems after AAA implantation. And I will have a very, very short presentation, and we are going to illustrate one of the most challenging type 2 endoleaks, so branches that are still feeding the aneurysm. We are going to try to occlude a huge lumbar vessel. What about endoleak? Endoleak is a leakage back of blood into an aneurysm sac after aneurysm repair procedure. It's considered as one of the most common complications or failure of the ever procedure. In fact, this is an endoleak that is artificially created state or disease. I will emphasize, let's say I will put apart the fabric and structural endoleak, because they don't depend on us. The endoleaks that are dependent on the operator are the type
1A, that is proximal leaking, and type 1B, that is distal leaking of blood within the aneurysmal sac. And type 2 endoleak are the endoleaks from different arteries still feeding the sac, or late feeding of the sac. These are lumbars, inferior mesenteric artery. Despite in most of the cases of a AAA, inferior mesenteric artery is occluded since the beginning. But in case these arteries are widely open, like inferior mesenteric, lumbars, internal mammary artery, are very wide open. And in case we see on the CT before the EVAR, we have probably to make initial embolization procedure in order to preclude the possibility of early or late type 2 endoleak. And in fact, these two are the most important endoleaks because they are correctable by the operator on an early or later phase. Imaging. Imaging is crucial. So the CTA is absolutely important, but not only within the arterial phase. We need early arterial and late venous phase with the late phase imaging of the filling of the sac, like shown here. And I have to admit, our imaging operators are really fantastic in detection of endoleaks because of our quite big aortic activity. So what is next step? The next step is following the images to decide what to do. One of the conditions causing endoleak type 1A especially are the so-called chimney technique that I mentioned yesterday, that in case we have to do chimney technique, we have to oversize significantly the main aortic body. So in our, in fact, practice, we oversize at least 20% for one chimney and at least 30% for two chimneys, because we are going to need from the circumference of the main aortic body two invaginations that have to accommodate the chimneys. So this rule is very important to avoid since the beginning type 1 endoleak. What we can do in type 1 endoleak, for type 1 endoleak, I have to emphasize that in fact they say there is an aphorism that say that in type 1 endoleak the patient is not treated. For me, it's even more, it's worse. In fact, with type 1 endoleak, we increase the pressure in the sac without the possibility to the tension to be released, because in case there is no distal endoleak, in fact, the pressure is increased very fast, and it can rupture in several days. So what we can do in type 1A endoleak, we can do balloon post-dilation. It's very efficient. We can put a balloon expandable big palmate stent within the stent graft. We can put proximal endograft extension, and we can apply endo anchors to fix the graft over the aortic wall. And of course, we can do proximal embolizations. For type 1B, distal type 1 endoleak, we can prolong the stent graft, the endograft, the iliac endograft with additional one. In case we cover with the additional endograft, we cover the hypogastric, the internal iliac. We have to plan, in fact, the sandwich technique in which from above we put in chimney into the hypogastric and prolongation of the iliac graft toward the external iliac in order to preclude the endoleak. I will show several cases, quite dramatic, I would say. This one is the first, that is a 65-year-old gentleman with a history of three years after implantation of Endurant for AAA, and history of PCI, coronary disease, and so on. So during the time of the, okay, I'll put the CT. During these 3 years, unfortunately, the sac enlarged and the proximal zone of the aorta, infrarenal aorta, also enlarged. And unfortunately, with this enlargement, in fact, the patient had the configuration of from infrarenal to juxtarenal aneurysm and endoleak at the same time. So in this situation, what we can do, of course, we cannot expand more the endograft because it's a limited diameter, the endograft. It cannot be expanded more. In this new formatted juxtarenal aneurysm, in fact, we performed late chimney. So we put two big grafts with, of course, by brachial, both brachial arteries approach. We put chimney, two renal chimneys with implantation of a big graft. And after doing the chimney technique, we put additional aortic cuff proximally to the previous one. So this is the opening of the two chimneys in the two renal arteries. We utilizing very much the data from the CT in order to precise the angles. For example, in this situation, we are using almost lateral projection in order to spare the superior mesenteric artery. So after putting the chimneys, we in fact making a roadmap, and we are implanting the two chimneys, and we make a triple kissing. So the two balloons into the renal chimneys and one balloon in the proximal aortic cuff in order to have good sealing of the proximal zone. And this is the final result in this particular case. You see the stent graft is over the renals and the chimneys are working very well. The second case is more dramatic. It's a 1B, type 1B, again in a patient with history of AAA ever treated several years ago. He was admitted in a critical condition with very low hemoglobin, anemia, and 407 millimole per liter of creatinine, so renal insufficiency. It was, in fact, a ruptured aneurysm with a huge type 1B. So during the time, unfortunately, the iliac zone of the vessels has extended his diameter, and the retrograde filling of the aneurysms by the 1B endoleak lead to huge extension of the diameter of the aneurysm. And in this situation, we had to be very fast. So the patient was treated. This is the right femoral and brachial approach, and because of the huge tortuosity, you can observe on the right panel how tortuous is the segment, the iliac segment. So there was absolutely intentional through and through maneuver. So this is the wire snaring, and after making a through and through maneuver, there was additional implantation of iliac stent graft. You see how difficult it is to cross the huge tortuosity, and this is the implantation of additional iliac graft that in fact fortunately sealed the zone of the 1B endoleak. And the patient, by the way, the patient is a colleague of ours, one of the most famous implanters for dialysis catheters, and he's in a very good shape now. And this is the final result. So there is no more endoleak. And now we are going to show you live type 2 endoleak by a very interesting, Dr. Janevska will show you several slides. A very interesting iliac aneurysm, big iliac aneurysm that was treated very efficiently several months ago with iliac stent graft implantation. But unfortunately, during the 3-month follow-up CT, we saw that the iliac aneurysm is still active because of the huge lumbar artery feeding the sac. And I will ask Dr. Janevska to show you the case, and we are going to show you the embolization.
live case for today. 69 years old male with successful isolated aneurysm of right common iliac artery from aortic bifurcation to external iliac artery, coiled internal iliac artery for prevention of type 2 endoleak. First month, control CT with preserved result of procedure. Third month, control CT with endoleak type 2 with increased the diameter of aneurysm from 85 to 19 millimeter, secondary endoleak. Ultrasound Doppler with persistent blood flow in the aneurysm sac and progression of the diameter of aneurysm. CT aortography. CT date for endoleak from lumbal artery and internal iliac artery. And let's see, show us the live case.
To this moment, in fact, we have done a rehearsal several days ago, and we have put in fact, Siemens 2 catheter, diagnostic Siemens 2 catheter. It was not possible to use our favorite approach, the brachial one, because of a huge tortuosity of the proximal thoracic aorta. So it was absolutely impossible to go there. And we succeeded to go by the position of a Siemens 2 catheter supraselectively in this enormous lumbar artery that is feeding very efficiently feeding the aneurysmal sac. And I will ask Zoran to stop for a second.
Yes.
In order to show you what were the procedure from the start. So by left femoral approach, we put a contralateral wire, and over the contralateral wire, we put the Siemens 2 catheter supraselectively. Zoran did that job. Yeah, you see already. It's very well seen how big is this feeding artery with several branches, and we decided we have planned, in fact, to occlude both branches of this feeding artery in order not to have the possibility to receive blood from other small arteries, and go further. In fact, Zoran had positioned already 2 coils in one of the branches. Go. More. Next. Yeah, you see the first. In fact, the first two coils. So the first 2 coils are already there. And we are planning now to go into the other small branch in order to put several more. Some comments, proposals?
Can you hear me?
Yeah, we hear you very well.
I see that you used pushable coils in this case.
Yes.
Detachable. Yeah, detachable coils, not pushable.
Do you always try to close this kind of particular endoleaks with coils, or you sometimes, when you see so big lumbar artery, you think of liquid embolic agent, maybe like glue or onyx?
Absolutely, it's absolutely possible. It's doable. It's even possible to put some particles as well. And there is a small problem. The unaffordable price of the onyx. So, but with glue or particles, it's absolutely possible. It's doable. Roadmap, please.
Thank you.
I'm going to do roadmap now, and we are going to proceed to the other branch. Great. Okay. Wire 014. Какви коучи имаме?
Имаме всякакви.
Един наш стична да сложим накрая. Една игличка искам.
It's a big artery.
It's a huge artery.
Yeah.
we are planning to put probably two
Many coils.
in each. Two in each artery, in each branch, and finally to put probably two more in the main feeding vessel, probably with 5 or 6 millimeter diameter.
Was it very difficult, Ivo, to gain access to
It was
this?
It was not easy.
Yeah.
It was not easy. It will be very interesting for you that we are performing an intervention through a diagnostic catheter that is utilized like a guiding catheter. So it's in fact the microcatheter is put through the Y connector that is connected to the diagnostic catheter. So it's, but this was absolutely necessary because the guiding CMOS, because it's quite rigid, couldn't go there because of the tortuosity. And you probably see I'm advancing slowly, very slowly, in order not to prolapse in the other feeding vessel. And after having good position of the wire distal, I will proceed with the microcatheter. It's a let's say, coronary microcatheter. It's a prograde microcatheter. That is
not a coronary, it's peripheral microcatheter.
Yeah, prograde was initially definitely a coronary microcatheter, but because we have a number of coronary microcatheters, we are using in quite good proportion of peripheral interventions. Okay, I'm trying to proceed, but it's also possible in case the microcatheter doesn't want to take the curve, we can put the coils even there at the ostium. Do you agree?
Moving, it's stable.
Okay, I'm trying to position a little better the diagnostic catheter that is utilized like a guiding. And you see it's quite tortuous there. So the angle is quite big. And because of that, the microcatheter doesn't go.
So one of the ways you could have treated this patient, Ivo, at the beginning was to put in an aortoiliac graft, and you must be really, really thrilled to bits that you didn't do that now.
Absolutely. We have done some cases like this, but because in this case, the aneurysm was strictly iliac, and the aorta, in fact, it's absolutely healthy. And because of that, we decided to make a limited stent grafting. And but you are right. You are absolutely right. Probably the best option would have been to embolize this vessel since the beginning. But in fact, we don't know which of the feeding vessels will be the guilty one. So because of that, we didn't. And I'm going to put coils directly there into the main feeding vessels. Probably number of coils. And we are going to proceed with a 4 millimeter one. I'm doing just okay. It's a
good place.
Yeah, very good place, very good position there. Okay. Okay, we are proceeding now with the 4 millimeter detachable coil. And we are going to prepare 5 and 6.
And we have one more solution for this case, to implant the papyrus stent graft in this zone.
Yeah, it's also possible. It's also possible.
Пригответе ми топчета 300
Este buton, șefe. Buton. Okay, the coil is already inside of the microcatheter. It's coming. Coming.
Can you tell us which brand of coil are you using at the moment?
Good.
We are using Concerto. We are using Concerto detachable coils. Okay, we are on the right place. Removing the connecting. We don't use since long time the special device for coil detachment. We do simple manual detachment, so we break the special place of the detachment that is generally cut by the special device, but it's absolutely unnecessary. Okay, we are okay. The coil is already fed. In case you watch my hands, the coil is already fed in the microcatheter, and now I'm pushing up to the okay, pushing a little more. Yeah,
Great job.
that I wanted, with several rapid pushing maneuvers to compact, to make compaction of the coils in order to have bigger probability. So here is enough. And if you watch my hand, in case we can increase, could we? Yeah, zoom the camera. This is the place in which, in fact, this is the place. And okay, here it's probably not very well seen, but more or less here is the site. Here is the site of the detachable, yes, detachable instrument. Exactly, absolutely. Here is the site where the detachable instrument, detaching instrument has to break, and we do that manually, like that. And we are ready. And we are removing the thread that is in fact connecting the coil to the main body of the pushing system. And after removing the thread, the coil is already disconnected, and I'm removing now slowly, and you see the coil is there. So it's stable. We can make an injection now. Of course, all we know that the thrombosis is not immediate.
Yes, it might be worth warning the audience not to expect complete thrombosis.
Exactly, absolutely right. And we are going to make a small injection through the microcatheter in order to take a look what is happening. A little slowing down of the flow, but we need more. Let's go. We are going to put some particles in order to stop we are going to make the so-called sandwich therapy. So we are going to put particles, and behind the particles one more coil on such a way. Yeah, we have already the particles here. One three-way stopcock, please. And okay, good.
How do you choose the size of the particles in this particular case?
It's a very good question. In fact, it's quite much dependent on the microcatheter that you use. So in this situation, we can use up to 300 microns, because bigger particles will not go through, or it will be quite difficult to go through. And
or sometimes it can even close, thrombose the microcatheter if it's a PVA particle.
Absolutely, yes, absolutely right. And of course, in this situation, as a bailout, it's possible to put much bigger particles through the main catheter, because the main catheter is super selectively into the feeding vessel. But the more distal we are, the better the result is. So we are performing now. Yeah, this is the particle infusion. And we are going to prepare one more detachable coil. And hopefully we are going to be done. Okay?
That is just advice.
One more 6x20, so it's quite long enough, I would say, in order to have good zone of compaction. I mean length, good length of the zone of compaction in order to have more predictable thrombosis. I think that things are going quite well, because I see there is a stagnation already. And you see?
Yeah, great.
Definitely there is a stagnation of the contrast. Yeah, for sure.
So the combination is a very good combination.
Yeah, we are going to put the coil behind, and the sandwich will play the role that we expect. Absolutely. Very nice stagnation. So there is a...
Is it easy to use glue? Can you find Lipiodol in Bulgaria easily?
Not so easy, but yeah, it's possible. In fact, because there are no many procedures with glue, there is almost no import. And in this case, we have a special protocol of the ethics committee and to provide the glue in the hospital. So it's let's say case by case. But otherwise, you are absolutely right. It would be very nice to do that. And okay, I will recanalize now the lumen of the microcatheter with saline and the wire, and we are going to proceed with the coil behind. Okay, some more saline in order to have good washing. Yeah, very good stagnation there. Okay, we washed it, and I will put the 014 wire in order to be absolutely sure that it's a patent microcatheter. It's going very smoothly, so it means there are no more residual particles. As you mentioned, even the microcatheter can thrombose, or can have such a stagnation of the particles that is absolutely not important to go with anything. So we are proceeding now with the coil, and fortunately, hopefully, we are going to be push. Okay, we are feeding now the coil within the microcatheter. Zoran is pushing the back part all the way down. Okay, it's already inside the microcatheter, and we are going to proceed now with the coiling. I will remove a little of the curvature there to have more predictable movement of the coil, and it's coming. Very interesting. You see that the stagnation there, the thrombosis that in fact started doesn't allow to the code to go further. That is a very good sign. It means that in the sandwich, we have already a zone of thrombosis. And I'm going to break now to liberate the coil. It was a quite good compaction. Okay, I'm removing the pushable part, and now we are going to make a picture. Go. Okay, super. I'm going to make a picture from the microcatheter. Ne dici, Neoko? Very nice.
Wow.
Great job.
Yeah, wow.
Finish.
That's it. We are done.
Well done,
Thank
Ivo.
you.
Well
Great
done.
result.
It's very
Thank you, guys. Thank you.
Yeah.
See you soon in the room.
I just also French.
It's very appropriate that the next presentation is going to be on the treatment of isolated iliac artery aneurysms. And Haitham Hamid, if you could please come to give your presentation now. Haitham?
He's sleeping. He's not ready. Yeah, he is.
So Haitham is a vascular surgeon in the UK who does both open and endovascular surgery.
Can you help him?
So I'm Haitham Hamid. I'm one of the consultant vascular surgeons in northeast of England. So the reason behind this presentation, the reason behind this presentation, around 2 years ago, I was working for Donald Reid in Scotland. The pathology we see there in aortic aneurysms is mainly related, the difficult cases were mainly related to the neck. And him and we try to convince the MDT that the endovascular approach is probably or usually the best approach to deal with that. And have to say, sometimes we win, sometimes we fail. Then I moved to England and I see a different pathology there. And I saw the pathology there where you have very long necks, 3 and 4 centimeters, where you could basically land an EVAR blindly. But we have more and more isolated iliac aneurysms, which were quite unusual. So I don't have any conflicts of interest. Not sure why it's not moving. Let's see. No, it's duplicate, should be.
Okay.
Okay, should you just do it from... Okay. So definition and epidemiology is basically 15 to 18 millimeters of the common iliac and 8 millimeters of the internal iliacs are considered aneurysmal. Basically, they are rare pathologies. They are part of the aortoiliac sometimes, but they could come with their own. And as always in life, women are doing better than us. Reber made this classification, and basically it's an anatomical classification where it is based on the origin or the arteries involved in the iliac system. And the ESVS recommend treating it at 3.5 centimeter. However, that is not based on any RCTs or big studies. We know for sure they rarely rupture below 5 centimeters. And so in high-risk patients, it's completely appropriate to consider treatment from 4 centimeters or above. Always in vascular, either endovascular, open, or hyper approach. Again, the European guidelines prefer endovascular approach in iliac aneurysms. And that's basically for the concept of pelvic preservation, pelvic circulation preservation. Not going to talk about open, it's boring, lots of complications, and prolonged hospital stay for the patients. So we'll go to the endovascular approach. People again try to design a planning guidelines or staging for the endovascular approach. You got this classification here, and then again, MELS based on the landing zones. They've here made a classification back in 2011. However, all these classifications and more, they are not giving you the answer that you wanted, and they were pre the bifurcating devices era. What I personally do, I look at the planning, my planning on the internal iliac and plan whether I'm going to preserve it, partially preserve it or exclude, and I look at my proximal sealing zone, and I try to localize my sealing zone on the iliac as much as I can. And basically because I want to preserve the lumbars and I want to preserve the IMA for the pelvic circulation. This, most of us have seen this, the EVAR with IB or IBD. They have good results so far with almost 0% pothoclaudication. But we're seeing more and more standalone IBE or IBD devices. This is a paper from Dioria where the standalone gold graft has shown very good results. Although the limitation of gold device is that it has only one size, which is 23 millimeters. However, again, E-iliac from Yotek or Artivian now has got similar results, and they got a variety of 14 to 18 millimeters. Both has got criteria for their landing zone, obviously. People also use sandwich or double barrel technique, which has comparable results, as well as fenestrated, physician-modified fenestrated iliac limbs. There are things that we could use if you have a narrow aorta. We could reverse an EVAR limb and use a double barrel technique on that, but rarely use that nowadays because the EVAR profiles have went down, and you could certainly find a 20 millimeter EVAR graft on the market. If you're struggling with with EVAR, if you're landing in the infrarenal aorta with a short distance between the renals and the internal iliac artery, or if you performed an EVAR before, certainly the Mayo up and over technique is quite helpful, or you could come from the arm. I certainly personally prefer to go with the up and over technique, where you could dock an 8 French sheath and get the sheath above the flow divider, then go down to the internal iliac. When we discuss the partial internal pelvic circulation, you could limit your EVA stenting or repair to the internal iliac artery. In this case, for example, I had a dissection distally, so I had to extend my landing zone distally. And certainly this, when you measure this, is above more than 15 centimeters extend, and I was skeptical at the time, saying this is an expensive embolization plug, but certainly 6 months later, it's still running. Or you could use it as a part of the EVAR IBD or branching system, where you embolize one of the branchings and extend your sealing to the bigger branch, which is mostly the posterior branch of the internal iliac artery. Again, I don't like excluding it with embolization only, because this is one of my first cases when I started, which shows good results at the end, but in retrospect, you could have saved at least one of these iliac branches. If you want to exclude with origin coverage only, you could use a bell-bottom or scare technology, or even a reverse-bottom, bell-bottom and reverse technology to get the flare part of the limb and limit your seal only in the common iliac instead of going up to the infrarenal aorta. Also, still, the best, or I feel the good results that I get when I combine the embolization and the internal iliac coverage, either as part of an EVAR or again standalone. Like in this case, we just land an EVAR limb, and Professor Petrov showed a nice case where with the limb only you could seal the iliac aneurysms. If you need a bigger size of the proximal landing zone, certainly the cross-bifurcation access provide you that, and had been described with almost all the devices on the market. But you have a limited extension zone if you need. Certainly in this case, because of the quite tortuous external iliac artery, I had to extend my seal distally. And I find the Gore internal iliac limbs, because of their reverse limb position, quite useful, where you could go distal with any size from 8 to 12 millimeters. If I'm struggling with the landing zone proximally in the common iliac, I usually use the reverse limb to seal it, and again was described with extracorporeal or without extracorporeal limb deployment. In this case, I've taken the tip or the nose of the device of the Gore limb out. I reverse the limb, and this is, and then you cut the dilator of the sheath and try to advance your graft to the iliac, and it gives you a nice position. And in this video, once you're happy, then you pull the thread through the sheath and it gets deployed, part of it inside your sheath. You basically pull your sheath while advancing the dilator, and you could get a nice deployment there, and certainly perfect deployment on the CT afterwards. There are many other techniques, but for sake of time, like using a chimney EVAR, a chimney stent from other external iliac. Certainly, you could, day by day, you could we could find more and more techniques. You look at it because basically we don't have a strong planning or platform or guidance that tells us what to do exactly on those cases. I'm going to touch quickly on the hybrid approach. We rarely use it. These planning were from years ago. But certainly the hybrid approach could be useful in cases like this. When I got this patient with a myocardial aneurysm, he was certainly not fit. He got chronic lymphocytic leukemia, so he wasn't fit for an open repair. His HB was 7. And the hematologist, when we discussed with him, he felt if we put a PTFE limb and leave him on long-term antibiotics, that will jeopardize with him of getting treatment for his CLL. So luckily for me, I work with this guy, his Klaus Overbeck, and he's a pioneer of using vein-covered stenting in myocardial aneurysm. And basically we use a superficial femoral vein on a stent, and it takes us to design the stent around 3-4 hours, and you land it on the common iliac to seal the aneurysms. And you get perfect results in sealing with them without the effect of having foreign body or foreign graft on a long term. Again, going into this classification we discussed at the beginning, they're not giving us the perfect answer. And basically because we don't have RCTs, we don't have big results to find an answer for us. And certainly in the UK, for example, our national data are combining the isolated iliac aneurysms with the aortoiliac area, which I think is wrong. It's not like a similar pathology. It could be treated as almost a different pathology like popliteal aneurysms. So when I look to this classification, yes, I look at my planning sheets and you could find these, you could slot them in the classification, but no, the answer is no for these and for these. So still, we don't have an answer for how, or a strict answer to treat isolated iliac aneurysms. So in conclusion, we need at least registries or big studies to get, if not RCTs, and always we love new abbreviations in the UK, so EVR has to be a different concept than EVAR. And as much as possible, try to preserve iliac circulation, and we need a new guidance and classification, and I'm proposing an RSI staging, which give you a guidance for these cases. Thank you very much, and I have to say, Mr. Reid, I've corrected. Since I moved, I'm now a believer that endovascular is always a solution, even if someone smashes your screen in theater.
Well done.
Besides being a very good surgeon, I imagine you're a very good artist. Your drawing are very
I try my
elegant.
best, yeah.
It seems like he's had a lifetime experience of iliac artery aneurysms in the 2 years you've been there. So,
How old are you?
Me, 40.
Sorry?
Mid-40.
Sorry?
How old are you?
Me, 38.
You are beginning of your career, and it's going well. Thank you.
No problem. Thank you very much.
My understanding is you're also publishing this in the Bulgarian journal, aren't you? So that's
yes, we're
very
working
good of you.
towards that. Yeah.
Any questions from the audience? It's a very, very specialised topic, and maybe he's now the tertiary referral person, Vasil. Thank you very much indeed.
Thank you.
Who's the next presentation, Jack? Can we...
It's just in.
Have I got a piece of paper? Have you?
We should, who should speak now?
I have it, I have it.
Bizdas,
It is...
Stankov, Goreshki,
It's
Youssef,
Alexander
or
Goreshki,
Vasiles.
please.
Are they present?
Is Alexander Goreshki ready?
Who want to speak?
Can you hear me now?
Yes, we can. We can't
Okay,
see
so
it.
great. It's thank you very much for giving me the opportunity to attend this meeting. Unfortunately, I was not able to come in person in Sofia, mainly from personal reasons. I'm an interventional radiologist, and today I'm going to speak about the endovascular treatment options for visceral artery aneurysms. So I cannot move my slides.
Nice to meet you. You are on the Zoom?
Yes. Why I cannot move my slides?
They will move them for you.
I don't know why. Let me check with Dimitar.
Please stop presenting and start presenting again.
Okay. Stop share.
Ah, very nice painting behind you.
Yeah, thank you, but unfortunately, I cannot see the exit minimize video. So I want to share screen again, and hopefully it's gonna work now. Share.
Yeah, slideshow. Goes to slideshow.
No, now it's okay.
Okay.
So let me do a little bit faster. Visceral aneurysms are a very rare condition, up to 0.2%. They are mainly diagnosed nowadays incidentally by imaging for other purposes like CT or MRI, mainly on the abdomen and pelvis. Treatment options can vary between true and false aneurysm, and it's not always easy to make the clear difference between these two. Of course, nowadays endovascular approach is becoming a main option for the treatment. This is a recent publication about the distribution of published cases per location which were treated. You can appreciate from here that only the renal artery aneurysms were more treated by surgery, but in the publications. All other visceral arteries were treated by endovascular means mainly. The true difference between aneurysms and pseudoaneurysms is the one that pseudoaneurysms do not include all the three layers of the arterial wall, and they'll mainly result from inflammation, infection, or some iatrogenic injury, post-surgical mainly. I would start with the splenic artery aneurysm, which is the main involved visceral artery aneurysm with about 60% of all other aneurysms. It can be associated with other aortic or other side aneurysms, and if it ruptures, which is about 22%, the mortality rate can go up to 70%. They are usually asymptomatic, and as I mentioned before, they are incidentally discovered on imaging. There are some recent guidelines from the Society of Vascular Surgery which suggest that we can treat, or we should treat, splenic artery aneurysms, which when they grow up to 2 centimeters, and in North American Society guidelines up to 3 centimeters. Also, treatment is scheduled when the diameter of the aneurysm can grow 3 times, can exceed 3 times the diameter of the target artery, or if the annual growth is more than 0.5 centimeters or 5 millimeters annually. Of course, if there is a symptomatic splenic artery aneurysm, we should treat it, and splenic artery pseudoaneurysms are more fragile. Of course, when an aneurysm or pseudoaneurysm ruptures in an emergency treatment setting, we need to treat this aneurysm. There are several options for treatment: endovascular, surgical, and percutaneous approach. What about the endovascular treatment options? We have several available tools like coil embolization, which is almost always feasible, is the standard technique. Then we have the modern techniques like stent and balloon-assisted coil embolization, which are the same technique but modified from the neurovascular strategy. Then we can use the liquid embolic agents like adhesive or non-adhesive plugs, microplugs, and nowadays very famous covered stents. From time to time, when there is a complex aneurysm with a lot of side branches, we can even use the neuroflow diverters in order to treat this aneurysm successfully. So let's see, if the aneurysm is a saccular one with a narrow neck, the main treatment option is filling the pack with coils. We can also use a covered stent graft across the aneurysm neck, and we can completely switch it from circulation. If the aneurysm has a wide neck and is a saccular one, then we go to the more complex technique with the stent or balloon-assisted coiling, or also we can use the covered stent technique. For fusiform aneurysms, we can close the whole artery, so we need first to close the back door, then the main body of the aneurysm, and then the front door of the artery. And in these particular cases, we can combine several embolic agents like coils, liquids, etc., etc. Let's start with the splenic artery aneurysm and some cases. In this particular case, we had the emergency setting of a ruptured post-traumatic splenic artery pseudoaneurysm. You can appreciate how in the arterial phase there is the typical extravasation of contrast, and the form of this aneurysm is not circle. So we can from this side we can see that it's a pseudoaneurysm, and it needs to be treated in emergency settings. In this case, we went distally with a microcatheter and we closed the back door of the artery, the neck of the aneurysm, and the front door. So we occluded the main target artery without any risk of complications in terms of splenic ischemia because of the collateral vessel formation, mainly through the short gastric arteries. Another case, saccular aneurysm with a wide neck. We went in the celiac trunk with a long sheath, and we placed a stent across the aneurysm neck. It's an open cell peripheral stent. Then we went through the struts of the stent with a microcatheter and do some coiling. And this is the final result with a patent splenic artery and the thrombosed aneurysm sac. This is another case of a fusiform aneurysm with a wide neck. We went distally with a microcatheter. We placed some coils, like in the case that we saw previously for embolization of the endoleak. But then again, as we know, it's very difficult to occlude the whole artery with coils. So in this case, we proceeded with additional application of liquid embolic agents. In this particular case, is squid, is something like onyx. So we trapped the liquid embolic agents inside the coils, and we proceeded with complete occlusion of the splenic artery without any ischemic changes. What about hepatic artery aneurysms? It's a very rare aneurysm. If we speak about the three aneurysms, it's from etiology, it can be connected with fibromuscular dysplasia, lupus, polyarteritis nodosa, Wegener's disease, and some other disease. On the other hand, hepatic artery pseudoaneurysms are the most common visceral pseudoaneurysm, mainly because of they are iatrogenic, post-surgical, because of the big surgery of the pancreatic region and the liver. Then they can be post-traumatic, post-pancreatitic, and they are mainly symptomatic. In this particular case, you can appreciate a large pseudoaneurysm right in the region of the surgical clips. It was a case after Whipple's surgery. And in the late phase, this pseudoaneurysm is bleeding directly into the duodenum, so this patient had presented with hemophilia. Another case, post-pancreatic resection. This is asymptomatic patient. We saw an aneurysm of the common hepatic artery. In this case, we placed the long sheath in the proper hepatic artery, crossed the aneurysm with a wire, and placed a covered stent and exclude the whole aneurysm from circulation. This was a big graft, 4.5 millimeters in diameter, and a six months follow-up CT scan. We can see a patent stent and a distal hepatic artery with smaller caliber than before. Another case, People surgery, redo surgery. Actually, it was a symptomatic bleeding case, another saccular pseudoaneurysm of the common hepatic artery. We placed a covered stent across the neck, and you can appreciate the diameter of the stent was a little bit bigger, in this case 8 millimeter, but after 1 month on the follow-up, there was a complete occlusion of the stent. In these cases, it is very doubtful in order to use or not to use dual antiplatelet therapy because patient is actively bleeding, and what can happen is early thrombosis of the stent, but in this case, there was no consequences on the hepatic parenchyma nor the transaminase activity. What about preserving the hepatic artery? Should we or should we not? Yes, we should attempt if possible, but there are some risk factors which can comply to liver insufficiency after occlusion of the hepatic artery, which mainly is related to portal vein stenosis or thrombosis or even no flow in the hepatic artery. This is a pseudoaneurysm, distal pseudoaneurysm in the right hepatic artery after biopsy. We went distally with microcatheter and embolized it with coils, and after the control angiogram, there was no filling of the aneurysmal sac. Hepatic artery aneurysms are very rare and mostly asymptomatic. True aneurysms should be treated if they are larger than 2 centimeters, and the incidence of full aneurysms depends on the local profile of the hospital. What about the renal artery? Renal artery aneurysms is a rare disease. They are increasingly diagnosed with non-invasive imaging and more frequent in female than in male. Then they can be divided in real renal artery aneurysms and pseudoaneurysms, which are mainly iatrogenic. Symptoms occur very rarely in less than 50% of patients, and they then can be consistent with renovascular hypertension, hematuria, abdominal pain, or some renal function impairment. There is this old classification from Runbeck, type 1, 2, and 3 renal aneurysms, and the guidelines from the Society of Vascular Surgery, in my opinion, I don't agree with this because they are also pushing the surgical approach for treatment of aneurysm. Yes, of course, there is a chance, but in my institution, to be honest, now we switch almost completely to endovascular treatment options of renal artery aneurysms. Treatment options are more or less the same like the splenic and hepatic artery, endovascular techniques with coiling, balloon or stent-assisted coiling, covered stents, and let's see some cases. This is a distal. This is a proximal, actually, renal artery aneurysm that was treated in another institution with a stent-assisted coiling. And you can see because the stent was not a covered stent, they placed coils through the strut. There is a clear recanalization in this point, you can see. And the patient came to our institution. We just placed a covered stent across the aneurysm sac, and on the control scan, it was completely out of the circulation. This is an aneurysm of the renal artery at the hilum. It is a clear sac packing with coils. So just coiling simple, we exclude this aneurysm from circulation. This is the so-called remodeling technique with balloon assisted. If there is an aneurysm very close to the hilum or a distal aneurysm, you can go with 2 approaches. So first we place a microcatheter inside the sac of the aneurysm, and then from the other approach we inflate a balloon. This is also good for aneurysms with wide neck in order coils not to get outside the aneurysm into the circulation. So you fill with coils with the balloon inflated, and this is the final result, complete exclusion from circulation. This is the so-called combined technique. In this particular case, 2 aneurysms, 1 distal, 1 proximal. We did coiling of the distal one and the stent-assisted coiling on the proximal one. And this is one of my last slides. So the flow diverters, these are modern multiple monolayer stents, or can be multi-layer. They are mainly used for intracranial aneurysms, but can be used also in complex visceral aneurysms. The advantage is they reduce the flow velocities in the aneurysm. You do not have to coil the aneurysm. You just wait for it to thrombose. But the drawbacks, so it can be a delayed occlusion, and the price, of course. This is another particular case with a renal artery, multiple renal artery pseudoaneurysms due to a large angiomyolipoma in the lower pole. So you can, in this case, we use the liquid embolic agents like glue. it can be also helpful sometimes. So take-home points: visceral artery aneurysms and pseudoaneurysms are often asymptomatic and incidentally detected. Nowadays, endovascular management, which is less burdened by morbidity and mortality, is generally preferred. CT angiography is essential for pre-procedural planning and strategy, and we can use different embolic agents. We need to have a full toolbox in order to treat this kind of conditions. And thank you very much for the attention.
Thank you. Thank you. Thank you very
Do you
much.
have some questions?
Yes, thank you very much for your presentation. I understand that an isolated aneurysm in a big vessel, it's quite easy to treat. The question is, for instance, in the renal arteries, the distal aneurysm inside the arborization, terminal arborization of the artery. Did you have case where a nephrectomy was absolutely necessary, like in your last slide?
We tend to have these distal aneurysms, as you mentioned, but they are mostly traumatic in our scenario. Why? Because after percutaneous nephrolithotripsy, from time to time, we have this pseudoaneurysm which are bleeding. And I remember my very last case was a couple of months before. It was a patient who was post-traumatic. He fell from 3rd floor, I believe. And he had this bleeding pseudoaneurysm in the distal lower pole. So we tend to go distally with a microcatheter and we occlude the whole arcuate artery, if it's possible. So we intentionally create some small infarction of the kidney. But if it doesn't go, of course, this patient can finish with partial nephrectomy or even with total nephrectomy.
Anyway,
we had some cases.
Anyway, we were impressed by your very nice series. Congratulations, and we will take your example in our next cases. Thank you very much. We have to go on. Thank you.
Thank you. Bye-bye.
So the next presentation is by Marwan Youssef.
Youssef is here.
Good.
Ready
and
to
he's
speak.
going to be discussing the initial experience using in situ fenestration in the aortic arch pathologies. And my understanding is you're from Hamburg, is that correct?
That's right.
Great.
Dear colleagues, thank you very much to having me and Sofia and this very nice meeting. Actually, my presentation is more suitable to the aortic arch session, but I'm sure that you would enjoy it. Here are my disclosures. Talking today with you about the life tech Cura system combination with in situ fenestration system. You have some beneficial technical features with low profile TIVA system, robust introduction of the sheath. So it's very beneficial to the difficult kinked and tortuous anatomy of the thoracoabdominal aorta. The device would be provided with adjustable perforating needle device, also this movable or guidable sheath to adapt to the different anatomies of the proximal left subclavian artery. So we are talking about off-the-shelf system, which is very beneficial for the urgent or emergent cases, like I will show you in the next slides. So you can create wide range of the arch anatomies, and you have easy implantation with the system. Due to our initial experience, you can tolerate a lot of rotation dispositions in the opposite of the fenestrate or branch device, where you have to put your fenestration just against of the ostia of the supra-aortic vessel. So you can also, with the system, save some money regarding to the custom-made devices, and also, most important, save a lot of time for your patients. Like you see here in this two example, you can combine this in situ fenestration with other complicated thoracoabdominal multi-branch or visceral debranching of the rest of your aortic patients. And I brought some cases for you from my center. He's a young patient with post-dissection thoracoabdominal Crawford 2 aneurysms, treated by a staged approach with in situ fenestration and also visceral debranching. You can see you don't have a proximal landing zone distal to the LSA and very kinked thoracoabdominal aneurysm, and also post-dissection chronic aneurysm. So this was the first procedure with in situ fenestration. You can see we came through the LSA and we positioned the Ancura system in the distal aortic arch. You can see here the perforating on my side, maybe this. So you going to inflate your balloons here, and after inflating, you go through with the needle, perforating the stent graft and introducing the fine 18 wire and inflating the balloon pre-dilatation with balloon, and then to put your bridging stent as branch to the left subclavian artery. So later on, we go there and perform debranching of the visceral renal visceral segment and replacement of the infrarenal aorta, which is not such routine procedure in my institution because we do prefer the total endo solutions. So here are the final results after debranching and completion of the TVAR of the rest of aorta, and very nice result. So far, we have 1 year follow-up for this case. Other case from the praxis, also symptomatic giant thoracoabdominal Crawford 1 aneurysm with 10 centimeter diameter. You can see here the proximal landing zone distal to the left subclavian artery. It's about 45 millimeters, so you don't have a proximal landing zone proximally distal to the subclavian artery. And you can see here the difficult double kinking of the distal descending aorta or the thoracoabdominal junction. So we go there and perform urgent in situ fenestration, like you can see, and put branch for the left subclavian artery, and here are the final results of this patient. We do have here, like you see, type 1B endoleak, so we go after this and perform some TVAR extension. So, ladies and gentlemen, due to our initial experience, we treated so far 18 patients. The patient had suboptimal or even without proximal landing zone distal to the LSA or the distal arch. The initial experience was quite positive with almost total technical and clinical success. In one case, we failed to perforate the system, so we put chimney to the left subclavian artery, and one patient suffered from TIAS, however, without any further neurological disabilities. So far, the follow-up was median about 7 months, maximum to 14 months. We had no endoleak so far, no branch fractures or damage of the stent textile. So I would like to add that we cooperate with several of university clinics, clinic or hospitals like Clinic of Munich to we initiate a multi-center study, prospective study of this procedure. So far, ladies and gentlemen, we have a positive clinical and technical experience with the system. The system is feasible. It's a very good option to treat the acute situation, urgent and emergent situation. Multi-center study, like I said, is very necessary to get some robust mid and long-term data. Thank you very much.
Thank you, Varvan. It's a very good evolution of the branch technology in TVAR, EVAR, and I'm sure you will be successful in the future. Do you work with Dr. Kolbel, Thilo Kolbel in Hamburg?
Yeah, yes, we are very good friends.
You are friends or competitors?
We are competitors and friends together.
Okay, that's the best position. So, do you have limitation and contraindication for your type of graft?
So it's a very good question. It's a very quite new technology. So what we don't know about the system, how the performance of textile after perforation of the grafts. I talk about 5 and 10 years. So, and the question would be also how big have to be the stent graft if you have very big diameter of the proximal subclavian artery. So far, I went up to 18 millimeter with case. We didn't observe any endoleak and damage of the stents, and that's why we have to be very careful, especially using these new techniques.
Van, go on working, and we expect next year, for instance, presentation of your series. We are moving on the Leriche syndrome, a beautiful case, probably from Dobrin Vasilyev. Leriche syndrome, so difficult case in our experience. Thank you.
So, the organizers, Dirivo, thank you for inviting me on this meeting. I will be a little bit more scientific without too much insane cases which I demonstrated last year. And this year will be a little bit more scientific. So the Leriche syndrome is named based on the observation of René Leriche about the occlusion of infrarenal aorta, including the iliac arteries in most of the cases. And this syndrome actually covers several types of aortoiliac occlusive disease, which are type C and D according to the TASC classification, and they involve the infrarenal aorta and proximal common iliac arteries. And the classical treatment of Leriche syndrome is bypass surgery with aortobifemoral aortobifemoral bypass, or axillofemoral bypass, or crossover with one side aortoiliac or aortofemoral bypass. But as the results from surgery are not very impressive, with the high mortality rates. That means in hospital mortality. There were a lot of complications and high frequency of readmission. So the endovascular treatment was proposed as alternative of surgery, and this is the biggest early meta-analysis of first 16 studies done up to the 2010 and 11, and it demonstrated high technical success for recanalization of distal aorta, around 93% technical success with the high primary patency rated 12 months of almost 90%. And this is one of the reports where the authors, this is actually one of the largest reports which compares surgery and endovascular treatment, which clearly demonstrate that the complications are much lower with endovascular treatment with the comparable frequency of mortality rates, and moreover the cost of endovascular treatment is lower. And at that time, it was proposed that the endovascular treatment is primarily intended for older with multiple comorbid conditions and for urgent treatment of aortic infrarenal occlusive disease. This is one of the most recent publications which from Asia, and it demonstrated relatively good midterm outcomes with the primary patency rate around 60% and secondary patency rates around 80% at 5 years, which is quite good. And moreover, this study demonstrated for the first time that probably the self-expandable stents are not good for treatment of this condition. And after that, the COBEST study was published, which demonstrated the superiority of Advanta stent graft balloon expandable stent over self-expandable and standard balloon expandable bare metal stents. And that was regarding the primary patency rates and also for the secondary patency rates. And it was in this study demonstrated that the patients receiving cover stent required fewer revascularization procedures, and also that this do not translate in lowering the rate of major amputation, which was quite a little bit disappointing. In the recent years, there are several comparison between the endovascular and surgical treatments, and in the last published report again from Asia, from almost 400 patients, it was demonstrated that endovascular treatment is equal according to the primary and secondary patency rates with the lower complication rates, probably with decrease in mortality, especially the early mortality. There were a lot of advancement in this area during the last years, and transbrachial and transfemoral or transradial, transfemoral or distal tibial approaches, combination of that were proposed, and it was demonstrated that combination between transbrachial and transfemoral approaches is safe and effective. We made a common registry with Ivo a few years ago, and we included 54 patients with Leriche syndrome, and we have now 7-year follow-up of this cohort with relatively old age, mainly males. And it was really amazing for me that only 17% had the diabetes mellitus. This is the statistics which I made yesterday evening. We have at the 5 years as a median follow-up, 33% of dead rate. It was interesting that no matter did we have unilateral or bilateral success in recanalization of the aorta, that was not influencing the outcome of the patients. The diabetics had a dramatically bad prognosis in our cohort, and also the patients who have UNS at the presentation. And I will show you one follow-up case that was a 79-year-old female diabetic which admitted in our clinic in 2009 with Leriche syndrome. I recognized this lady, several stents were implanted, there were a good result, and a few months ago she appeared again. Actually, during these 3 or 4 years, I don't have any information about her status, and she appeared with this picture of occlusion of all stents from the renal arteries till the common femoral arteries. The recanalization procedure was performed, and we succeeded to recanalize the circulation to the left leg, and a lot of balloon inflations were performed with this result. And after larger balloon, this is 9 millimeter balloon, that was the result, but as you maybe observed, there is a haziness at the ostium of the left renal artery, so it was necessary to implant additional stent, and this is the final result for this lady. And in conclusion, I could say that in the modern time, the totally endovascular treatment of peripheral renal aortic disease is feasible with a high success rate. Radial brachial plus femoral tibial combined approach improves procedure safety. Use of stent grafts improves the long-term results. However, in general, this prognosis for these patients is poor. And in my personal view, a regular, maybe CT at least once per year could probably improve the prognosis of this patient. Thank you.
Thank you, Dobrin. We really like your talk. It's very important to see what happened in both situations. I would like to add something. There is a big difference between the chronic flourish, an old flourish, and an acute flourish. Old flourish, there is a collateral circulation from the lumbar, from the mesenteric, and which are taking part of the revascularization. And when you treat an old relish, a chronic relish, you can have either with a autobifemoral graft or recanalization. You have a still syndrome by the collateral which stay open. This is a risk to treat an old relish. I would like to add the acute flourish. Acute flourish is a terrible situation. Acute flourish, as a surgeon, you lost all your patients. You lost all your patients in the past. So acute flourish, you have to put them on the table and recanalize endo, and you save the patient because they are in a very bad situation, renal, ischemic, and so on. And you put stent graft directly. This is the only chance to save them and not do Fogarty because you put debris everywhere. So it's a very good topic you did. Be careful to the chronic flourish, which can reocclude the same day. Thank you.
It's true.
Thank you, Dobry. You did great job. We have commented that instead of publishing separately the results, it's better to put together in one database. And I have small but very important and positive news regarding this topic. We are going to build our national endovascular registry. I would like to thank Medtronic for helping us in that. And finally, after years of discussion and, let's say, requirements, we are going to have our national registry. So this is very nice. And this will allow to do more jobs like yours. So to put together the data from different centers. And like a mathematician guy like you, and with this result, we can be more exposed, because now a big part of the endovascular centers in Bulgaria work almost like on a secret. They don't publish, they don't expose results, they don't go to conferences, and it has to be stopped. So we need more data and more writing papers in order to be clear that we are in quite a good shape. There are centers like yours in a quite good shape with very good results. Regarding just a short comment from our practice. Of course, to make new carina with the utilization of non-covered stents, so to put an aortic stent non-covered, and to put 2 non-covered stents within the aortic stent with a new carina is an option. In most of the cases, we do like that. But unfortunately, like Jacques mentioned, the chronically rich patients are also very challenging because there are a lot of calcifications and so on. And we had more than one case in which we had absolutely non-intentionally, but mandatory to use stent grafts. So we have several trials comparing bare stents to stent grafts. But in our experience, we had to implant additional stent grafts as a bailout because of mainly rupture and because of the huge calcification in this region. And it's probably the best way is to plan since the the beginning, to plan stent grafting. And probably not only Advanta, there are also other stent grafts, not only the Advanta are the possibilities. So probably this is the best way to treat the exact patient. And the CT will tell us in which is absolutely mandatory to, since the beginning, to start with stent graft strategy, or in which is possible to use bare stents.
You keep the floor to tell us what is the program now. I think
the program is to have a lunch. Live case. So after the live case, immediately after the live case, Dobry, thank you very much. It's fantastic.
Further down. Okay, perfect. Okay, again. Open a little bit the window. Okay, show me more from the foot. Perfect. Okay, do it.
Theo, can you hear us?
Yes, I can hear you. Can you hear me?
Yeah. Can you tell us more about this case?
Yes. So do you want to present a little bit the case?
Yeah, sure.
Okay, perfect.
We have a very interesting 64-year-old male patient who has diabetes for many years. Now he's complaining of very short claudication in his left lower extremity, and he has unhealing ulcers on the first and the fifth toe. Several months ago, he went through a PTA of the superficial femoral artery with 5 millimeter DCB, followed by dilatation of the anterior tibial artery with 2.5 millimeters balloon. And now, due to the fact that his wounds are not healing properly, he's here again.
So what we see here is, let's see the angio. Can you show the first run that we have done? So we have done an undergrade puncture of the common femoral artery. Please show the first angio. Go back. Here you are. So we see here we are in the SFA, a lot of calcification without, however, any kind of high-grade stenosis. We see some...
Unfortunately, we don't see anything now.
Can you please show the picture of the angio?
Yeah, this is...
I'm waiting. I can see what you see now. I will wait until you see it.
We see now.
You see now? Perfect.
Yeah,
okay, you see that there is no disease on the SFA, or let's say there is no hemodynamic stenosis. There is a lot of calcification, but no stenosis at all. And then we have some filiform stenosis of the posterior tibial artery. We cannot really assess from this run what happens below the knee. So what we decided to do is to change for a 4 French 100 centimeter seat. We will see if this maybe is too long, but we want not to be inside the radiation. So from this way, we're working now from the left side, from the right side. And then we went with a seat deep up to the P3 segment. Can you show now the next angio? Next one. So here you can see there is a lot of disease in the posterior tibial artery. The fibular artery is a good one. Some filiform stenosis in the, there is a lot of disease in the anterior tibial artery. The fibular artery is good. The posterior tibial artery at the first proximal and the middle part is fine. It is too thin, but it actually is fine. Let's go next one. Then we took another angio to see what happens at the level of the forefoot. The posterior tibial artery closes, and with collaterals, it's coming very distally down. And we see a little bit of dorsal pedal artery that it goes at the very distal part of the forefoot. So our strategy at the moment is to go with the O14 wire into the anterior tibial artery to try to reach the dorsal pedal artery. We will see how simple it is, because If you see the preoperative CT scan, there is a lot of calcification. So this is where we are now. Do you have any comment on this?
Theo, we see that there is also a distal occlusion of the posterior tibia, not only the anterior. So
exactly.
You probably have two targets.
We will see if we need two targets because it seems that the arch at the forefoot is patent, more or less. So in this case, we may not need to go in the posterior tibial artery. We will see what happens. Maybe if we don't be able to, if we're not able to open the dorsal pedal artery, then we have to focus on the posterior tibial artery. So can I have the vertebral artery?
Could you share with us what is the wire that we are utilizing now?
Yes, this is an Advantage 014 wire. Is a wire that in the proximal is a hybrid wire. In the proximal part, this is like a terum or hydrophilic wire, and the distal and the majority or the biggest length consists of very stiff, like a Landerquist wire. So in those cases where it is very difficult to go through calcification, it is ideal. Please make a magnification of that level. Keep the wire.
Theo,
Yes.
what shall we do with the support? A balloon or a special catheter?
I will try to do it with a Cornelian 014 just to be sure that we have enough support. Please make a magnification. Zoom in, please.
Is it a Biotronic microcatheter?
Exactly. And then go, please, a little bit low. So this is the other. Okay, that is good. That is good. Go a little bit more. So important is to see what happens with your wire. So here we are inside, nicely inside the anterior tibial artery. I have a little bit of resistance. Can you move the vertebra?
It's very nice wire to form the buckle.
Exactly.
In fact, it's like the Super J, but it's not 035, it's 014, and in fact, it's our favorite wire in the below the knee as well.
I totally agree. Sometimes you may need to change for Asahi wires if you have really very difficult, let me do something. If you have very difficult, let's say, ways to go through difficult anatomies, but in the majority of the cases, you are fine with this wire. Please allow in order to see better the anterior tibial artery. We have to do it a little bit to see a little bit better. Yes, that is good. So important thing is go a little bit up. Up, very good. Now, please, the Cornelian. So important is always imaging. So you don't try to do below the knee. Sorry. Don't try to do below the knee interventions without seeing the whole vessel and the way it goes. Here, for example, you have to open a little bit the bones, the fibula and the tibia, in order to see exactly the road where you have to go. We see from the angio, you cannot see in your screens now, but we see that this is the level where actually it occludes. So don't try to do it without support because you may get into a dissection. So now we are bringing inside the Cornelian catheter. The Cornelian catheter is a very nice catheter from Biotronic. There are a lot of support catheters. There are people that they are using balloons instead of catheters. Here, due to the fact that we don't have, let's say, just a stenosis, we have a total occlusion, I will need a little bit more support. When can I have a more magnification, zoom in? Now, keep the wire, please, perfect. So I'm getting closer. Now, the nice thing is that we have used a 4 French sheath. So with the 4 French sheath, we have the ability to get a little bit inside the anterior tibial artery. Go a little bit higher, please. In order to have more higher. In order to have support here, we will see if it goes inside. It is a little bit difficult because we are with an 014 wire. We will see. Yes. This is a nice thing with this catheter that you can go really deep inside, and this gives you in that difficult arteries enough pushability to do whatever you want. So perfect. Torquer, do we have a Torquer? Yes.
On the way.
Yes, sir. Okay, let's go back. So let's see what happens here now. goes down. So now what you're doing is you just pushing with the tip of the wire, always keeping it straight. Sorry, try to avoid. Do you have a zoom in more or not? This is very good. Now you have to see always, here you are, I cannot go further down. Now is where I need a little bit of my support. Perfect. Now, important is torquer here in order to have a better rotation of the wire. You see how better it goes now by just using the torquer. Always rotate to the one direction and then just changing to the other direction, and then we'll go forward, further down, one direction always, then the other direction. If nothing happens, then just push your support catheter. Here we are very closely, so we need a little bit of more support. Here I have done a loop. It is not good, or try to avoid it, but sometimes it's not to avoid it. So here you are. I'm just pushing further. I don't know if I'm in a branch. We will see. It goes better. So you see, I'm just having the proximal tip of the wire, and that's I'm putting the support, pushing the support catheter. The support catheter, of course, performs a great job. Important, of course, for this is that we are with the sieve inside the artery. Now I would love to do an angio. Just a moment, leave it as it is. I will do it from the sieve, if it's possible. Okay, make an angio. It's outside? Nothing happened? Okay, so it cannot get inside. Okay, let's see what happens here.
Your sheet is in the anterior tibial.
It's the anterior, yes. Okay, I will pull it a little bit back. Okay. I will pull a little bit back. Show me a little bit where is the sieve. So go back, higher. Higher. Okay, we're higher a little bit. We are outside again, that's good. I'm going a little bit closer. Okay, let's do again an angio, go down. Go down. No, not zoom in and go down, please, to the forefoot. Okay, perfect. Okay, let's do an angio. Ready? Perfect. So we are relatively close. We always, when you are walking in the forefoot, you have to do it in two views. So this is the one view. We're going to make another view. Please bring it to a row in order to see better the arteries. I'm going to bring it a little bit here inside. Okay, go a little bit down. Okay, perfect. Now let's make an angio again. Ready? It's good. So here you are. You see the dorsal pedal artery at the very distal part of the picture. There is a lot of calcification, so this is going to be a little bit hard to get inside, but we will try our best. So in any case, we are in the right direction. So now it is time for the advantage to walk together with the support catheter. So I'm gonna use it here. Perfect, thank you very much. So here is the advantage. It's going to the pulse direction. Maybe have a little bit injury of the vessel. So here you are. This is the most difficult part here now. Okay, let's go back again. We're gonna make a loop. Sometimes it helps better.
Great.
Here you are. So with the loop, you are in a little bit subintimal space, so you are winning the right direction. You see the calcification at that level.
Yeah, you have a calcific roadmap.
Yeah, so I'm gonna bring a little bit the leg here. Okay, go. Perfect. Go back. Nice. We don't have more magnification, huh? It's okay. I'm gonna get inside. Perfect, thank you very much. So it is not simple, there is a lot of calcification inside, you see.
Theo, it is wise to use a CTO wire here?
It is. So we can, I will try always to find a small channel before I use the CTO wire, because I would use a CTO wire if we are in the subintimal space. So I will try to avoid, in order to be sure that I have penetrated the proximal part. So in order to penetrate, maybe it makes sense to use a CTO wire, but I will try a little bit to work on this. Give me some seconds. So
probably Gaia or Gladius.
Yes, that is a good idea. Halbert or Gladius. Can we have an Asahi Gladius 014?
Yeah, you have there both
Yeah.
Gladius and.
If we have Halbert,
Gaia.
it's much better to have Halbert, but otherwise Gladius.
Yeah.
So I'm going a little bit down.
I hope you feel like at home in my cat lab.
It's everything really great here. Okay, here it's good. We went a little
Yeah,
bit.
this is good point to attack.
Yeah.
Yeah.
Yes. Okay, here
Exactly.
you are. Okay. So we have to move slowly.
It's a typical stepwise approach. I'm explaining here the audience. So it's advance a little the wire, advance a little the microcutter, and again, advance a little the wire, advance a little the microcutter. It's like gaining territory in the war.
Yes, that's it.
Great.
Perfect. So this is
Fantastic.
now we are pretty good, I think. Now it goes very nicely through the arts. I want to keep it in a loop. Now the point is the difficult thing will be to go with the balloon through. I don't want to check that. Let's try to check, but I don't think that we will be able to get inside. I will try my best.
Yeah.
Okay, we are perfect. Here you are.
Do you want to change the wire?
We need a little bit. No, leave it as it is. The point I want to make an angio to see where we are. Okay, I'm removing this. So give me contrast from here with the small searing. Show me the whole forefoot, the tooth, perfect. So let's see where we are now. Yes, thank you.
You have there whisper extra support behind you, 300.
Sorry, I didn't understand.
You have whisper extra support in case
Yes.
you need more supportive wire, you have there.
Okay, yeah, that's good. Of course, for you as a cardiologist, this is something that it is your daily practice in the coronaries. Now we as the vascular surgeons, we're learning from you. So I have to say, it is a recommendation from my side because I have learned together with a cardiologist, and this is important for the vascular surgeons to follow sometimes the coronary angios from the cardiologist, to learn from them, because you have already developed nice things that for below the knee arteries are really nice. So where we are now, we are good. We are in one of the branches. The wire, please. The Gladius is good. Let's change a little bit. So now please open a 100 millimeter balloon. So I'm going to do now where we know that we are in the right artery. I'm going to open it with a 3 millimeter balloon. Do you agree with this? Would you use a smaller one? What is your suggestion? Are you aggressive?
I would start with 2.5.
Do we have a 2.5?
I can guess yes. You can check there. We have a very nice conical balloon, very long.
The Amphibian, the 2.5, 210?
Yes, exactly.
Okay.
Yeah.
The point is a little bit that this is not at the moment the ideal one because it is not good to cross the whole of CTO. I would start with a 2.5 smaller if we have not that so long, so 100 or 120 if we had.
Absolutely.
But let me try with a 3 millimeter, and then I will go with the Amphibian one just to. The Amphibian, the long Amphibian is an amazing balloon in order to do the final vessel prep. But the 210 loses a little bit on crossability. We need a little bit more.
To follow the anatomy, let's say that.
Yes. Do you have it? No. You have the wire? No, I don't have the wire. I will try very carefully. I have it now. Okay. So give me the 3/100, and then we will see. 1.5? It is too small. It is too small. We want to go a little bit higher. So now we're going to use the vessel prep. So it is important to discuss what it is actually the best. We know from the SFA that always we need a good vessel preparation. We have very nice tools like shockwave, like atherectomy devices, chocolate balloon, scoring balloon, and all this stuff. At the moment, regarding the below the knee arteries, we are not really well informed from the evidence what is the best option. At the moment, the only thing that we are doing is just ballooning and then deciding to perform stenting with a balloon expandable stent or not. The use of DCB here, I question it a lot because at the moment, if you see the CT scan, it is only calcified vessels. You don't see the calcifications very well. Maybe you saw it at the dorsal pedal artery. But I don't think that here DCB makes any sense. What do you think?
You're absolutely right. In so-called CT lesions, it's in most of the cases it's useless to put a DCB because the calcium doesn't resorb. There is no calcium resorption of the in fact of the cytostatic.
Yeah. Go the wire, leave the wire a little bit. The wire, okay, perfect. Leave it to me. Leave the wire. Okay, thank you. Just not to lose it from there, and I will try to keep it.
You probably need the full support by the sheet, by the.
Yes, I will try to go to see how deep the balloon. Now the balloon is getting inside. Now we're going up. Show me up a little bit.
The so-called telescoping technique.
Exactly. Go higher, higher. Higher, 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 more high. Go up to the knee. Here you are, more further.
Pero покажи му дезилето къде.
Perfect, that's good. So now I will try to get with my safe inside, just to have enough pushability. Because if you leave in these cases the sheath, okay, go down. If you leave the sheath in P3 segment, sometimes you're making loops with these balloons further down. You're making loops with these balloons, and then the loops are getting into the tibiofemoral trunk, and you're losing pushability. So here it's much better now. So keep the wire.
Very important comment. Absolutely right.
Go down, please. Okay, that's good. Yeah. A little bit higher, just to see the distal part of the balloon. Perfect. Okay, keep the wire, Nikolai. So, okay, okay.
We hear it's painful.
For me, not for the patient. So, nice, nice, very nice. Wow, amazing crossability from the balloon. This is a, what kind of balloon? Is a biotronic one, huh? Wow, cool. Very good.
Yeah.
So,
you and the patient are lucky.
Yeah. That's good. So we can inform the patient that maybe he has a little bit of pain if you want.
What is the name of this? What is the name of this miraculous balloon?
This miraculous balloon is, how do we call it?
Paseo 14?
Show me the package.
Paseo?
Paseo 14?
Paseo, it's Paseo, is it right? Yeah, this is a Paseo 14.
Paseo 14.
The Paseo 14 has a wire alongside the sheath. So this gives you this kind of stability and pushability. You see here the stenosis.
Yeah,
I'm going slowly.
This is the distal cap, in fact.
Yes, exactly, exactly. So I'm going slowly. So we have done a very nice paper together with friends from US, Mustafa and Dr. Saab. And we have seen that what we see in the angio is actually always the wrong diameter. So you see here that it is diameter probably is 2.5, 2 millimeters. But when we have done IVUS in those patients, the diameter was always higher. And so in my opinion, we have to be a little bit more aggressive with the selection of the diameter in the below the knee artery. So here, everybody would say, okay, go a little bit with 1.5, 2 millimeter, but believe me, it is always bigger than you think, especially if you have calcified vessels.
Yeah, this is the experience of a surgeon.
Exactly.
So, absolutely, it's very, very important for us to have your opinion.
This is the one thing, and this is probably the reason, go a little bit higher. This is probably the reason, higher. Perfect, okay, a little bit back. So this is the reason, what is this? Okay, this is probably, can you keep it here? So this is the reason why probably the impact deep trial with a DCB failed to prove, let's say, superiority for the DCBs, because if you see that they have done the majority of the cases, the lesions were at the proximal part of the tibial arteries, and despite this fact, they have used as a mean diameter for the balloon around 2.5. That is actually, as a friend of mine always says, if there is no touch, there is no drag, and exactly this is the point.
Yeah, was no contact between the surface of the balloon and the artery to receive the medication.
So just to know, we are at the moment within 18 atmospheres to open the vessel. This is exactly shows how severely calcified the artery is. And by this way, always do not be afraid to go up to 18 or even 20 atmospheres if there is a lot of calcium. This will break the calcium. So I open it. We want just to see. We want to see what happens after the first angioplasty. We're probably going to make a longer one with a tapered balloon. Now go a little bit higher. Here you are, a little bit higher. So always go at the level where the proximal part is, and then you're going back in order to have all the vessel well inflated. Okay, Nikolai, you can start. Here you go. Yeah, sorry. Yeah, okay. Thank you. So let's see it. Let's see where is the proximal part. Go a little bit higher. Yeah, perfect. Okay, let's do this. So important is also to discuss a little bit about the need of primary stenting and where go a little bit down to see what happens in the lesion down. Okay, it opened nicely. So how long are you inflating? 1 minute, 2 minutes, and how aggressive you are with the implantation of balloon expanding drug-eluting stents. So I'm trying to stay a little bit in those vessels because the recoil, we know from a study published from Mariana Brotman that if you stay around 20 minutes and you see after 20 minutes what happens with a vessel, you have a massive recoil in almost 20-25% of the cases. So you need to stay a little bit with a balloon to avoid this kind of recoil.
For how much? 2 minutes?
I'm staying 1 minute because let's say I'm staying for the first balloon 1 minute just to open to see what I have created, if I have destroyed everything or if I've done a good job. And then with the final balloon, when we're going to do the vessel prep, I'm staying for around 2 minutes.
Yeah, this is very similar to our practice. We do the same, at least 1 minute.
Yeah.
And between one.
Go
and
higher.
two.
Go higher, higher. Okay, that's good. So we are almost done. I'm going to do also here a little bit of angio. Okay, do it here. Benjamin angioplasty. Okay, do it, sorry. And then we're going to remove the balloon. Here you had a little bit of stenosis. Okay, we treat it as well. And now we will decide if we're going to leave it as it is. Which tooth are affected? 5, the 5th and the 4th?
The 1st and the 5th.
The 1st and the 5th.
Yes.
Okay, that's not helping. Okay, good. Open it, just to see now. Okay, go down to see the wire. Maybe we have lost it. Go further down, further down. No, it looks good. A little bit more down.
Great, you are very precise.
Okay, perfect. Now, please remove it. I can take it here. Okay, here you are. Just a moment. So I'm checking where the wire is getting straight. So sometimes, not sometimes, when you have difficulties to, this was not the case here, but when you have difficulties to deliver the balloon through a very calcified lesion, what really happens, and I'm going to show it in the presentation that I have later on, what really happens is the pierce technique, where you're getting with a needle outside from the skin and you are removing it. And you are really destroying the artery from outside. By this way, you are fragmenting the calcification and you can then deliver your balloon. So let's make an angio from above. Zoom out, please. Very nice.
Nice.
There you are. Okay. Open a little bit. Perfect. Okay. I remove it from here. Okay. Nice. Let's go a little bit down. Nice. Okay. Let's do the angio. It looks good. Somehow it seems that it has a little bit of dissection there. That's the reason why we have this slow flow exactly at that level. This is where we probably went subintimally. Go down. Okay. Give me something a little bit to flash.
The sheet is probably subocclusive, and because of that you have stagnation.
Yes, absolutely. I don't remove it yet. I will remove it soon, and we'll try to flash a little bit. Okay, show me. Okay, it's better. Now you see the artery is open up really to that level, so I'm not going to use another contrast. Show me. Okay, perfect. Okay, give a little bit. Give it. It's no problem. Give it. Yes. Okay. So we have to work a little bit there. So now we're going to bring the balloon. We're going to remove the sheath back to the P3 segment, and then we're going to do the angioplasty. Okay, give us 3, 2.5, 210 amphiron if you have. Any question until now?
What is your next strategy? One more ballooning, and after
Yes,
that?
now I'm going to use the tapered one. I'm going to pull back a little bit the sheath, and then I will see what happens. I hope not to be, I hope to avoid any stenting, but if this is necessary, we have to do it. This is a classical, let's say, picture of artery that we were subintimally with a lot of classification. You see this kind of recoil, yes, and you see how it looks like the flow. Sometimes, this is a very important suggestion from my side, sometimes you have the artery, you have to leave the artery a little bit to breathe. Because they are reacting in such a way, and if you give a little bit of nitro and coming back in few minutes, then you see that everything is much better. So we will see now after the first angioplasty how it looks like, and then we will decide accordingly.
Absolutely
if you
great.
want to go for any presentation, it will be fine.
In fact, most probably we are going for a lunch.
Yes, okay, perfect.
Because there is a lunchtime, and immediately after the lunch, we are going to take a look at your probably final result. In fact,
Yes,
I would do absolutely the same, probably conical balloon inflation, nitro,
That's what we're doing,
removing the sheet proximally into the distal popliteal in order to liberate the flow, and making an injection in order to decide what to do next.
Yes,
I would
perfect.
like to ask you probably one of the final questions before leaving you to work alone. Up to which distal part of the tibial vessels you implant stents, even on the foot level, or?
I'm trying to avoid in the foot level.
Okay,
I
so
don't
you,
like it. I don't
you
like
try
them at all.
to stay on tibial level.
Exactly.
I see.
Exactly. So, okay. Then I wish you to have a good lunch. We will stay here and we will walk, and then we will come back with the result, okay?
Great. Thank you very much for a very interesting case. See you, in a minute.
Thank you, sir. Bye-bye. Okay.
We are ready to start. Are you ready? In fact, it's a big pleasure starting this session to announce the results of the poster competition yesterday, because I had definitely conflict of interest for 90% of the posters. And the main, let's say, decision was done by the other two members of the commission, of the jury, Professor Velchev and Professor Staneva. And to be absolutely fair, there was quite a significant discussion how to position first, second, and third position as an award. But nevertheless, yeah, the results are ready. So I'm starting from the third. On a third place is the poster related to renal denervation. In fact, our next session will start with renal denervation data. And the poster was presented by Dr. Stojkova, Živka. I think she's not here. So somebody, probably Dr. Polomsky, please come. You are part of the team, so congratulations. Okay, the second one, I know that the awardee is not here because he's on duty in my hospital now, but his poster was very interesting. It's regarding a hybrid endovascular electrophysiological procedure. The septal alcoholic ablation of the so-called vein of Marshall, that is helping to make a decrease of the probability of tachyarrhythmia, in fact atrial flutter by the left atrium, with this scar that is in fact the result of the ablation, alcohol ablation of the vein of Marshall. The probability of the tachycardia stopping is increasing, and it's quite an innovative procedure that is routinely done in some French electrophysiology departments, but for Bulgaria it's definitely innovative. So the second one is going to Dr. Marinov, who is Petyo. You will be again the person that will receive. I will take all You can send the pictures to your family in order they to see how much awarded are.
After that, with Photoshop, they'll manage to.
And now we are coming to the first place. The first place is for a very talented and perspective student of medicine, and this is Dr. Janevska Elena. So, Dr. Janevska, congratulations. It was about quite an innovative method. Congratulations. Very innovative method for screening of vascular pathology. This is the thermography in complex of artificial intelligence. So, yeah, this is. It was my pleasure. Thank you so much. Please, for the next BEC meeting, please be more active. We are going to have a much bigger room. I know some secrets by the reconstruction of the hotel. So the room that they are preparing is 3 times bigger compared to this one, and it's will be suitable for the next Congress that will be very much bigger. Okay, we are ready now probably to see the results of the live case. Theo, Professor Bizdas, do you hear us?
He's coming to us now. And Dr. Velchev will show us the results.
Dr. Velchev, do you hear us?
Yes, I hear you perfectly.
Great.
Professor Business is going your way, so he asked me to present our final result. We followed the initial strategy and performed.
He just coming. Theo, welcome. You will comment now the pictures that Dr. Vocev will show us. We still don't see you, and after taking a look at the pictures, yeah, we are waiting.
Let's see the
Something
next one.
appeared. Yeah, we have the screen here, but still the audience. Okay, I understand. Yeah, we can reveal that it looks really great together with Dr. Nicole.
We have the pictures.
Yes, absolutely. Okay, we see the proximal and middle part of all the three tibial arteries. Could you show the next, the foot?
So what we have seen is that we have a continuous flow without dissection. And then what we have checked, due to the fact that the lesion was at the first and the fifth two, we made the next projection where you see that we have branches going to both twos. So we decided, in order to avoid to destroy the good collateral of the posterior tibial artery, to stop it there. And then if we don't have the improvement, I believe that we're going to have a very nice improvement of the twos.
Theo, if you allow me to comment, this is fantastic result, definitely. And we see that the wire is still into the distal part of the anterotibial artery. In our experience, we know that after removing the wire, the big part of the spasm is going, yes, and the final result is in fact much better compared to the intermediate result.
Yes.
So
we gave a little bit nitro, so we removed the seat. You see the seat is at the P3. We give a little bit of nitro. Can you show the final angio? And then, as I said, always we take now this review. You see a very nice flow in the dorsal pedal artery, and you see that there are branches. Now it's in magnification, I don't know why, but you can see from this angio that there are branches on both twos. So by this way, I think that is enough. If still we have problem with the healing, we can try to do the posterior tibial artery.
Congratulations, indeed. It's fantastic result, no doubt. This, the prognosis of this foot is definitely absolutely beneficial. Okay, thank you once again. Great job.
Thank you.
Great operator, great job. Fantastic. Okay, we continue now with the next presentation. It's regarding the basic science behind the renal denervation. And it's my huge pleasure to invite Stefan Tunev, our compatriot, who is working in the Medtronic on the extremely high level of science in this field. Thank you for coming. We appreciate.
Well, thank you very much, Professor Petro, for kindly inviting me to this forum here. Came all the way from San Francisco. And I also like to thank my colleagues from Medtronic for hosting me. I had a really good time with you guys to learn about this market. My disclaimer is that I'm a pathologist, so I'm hoping with my talk to take you back to the first and second year of medical school and kind of brush upon some of those concepts and show you some real science where medicine begins. And I spent 19 years looking at the pathologies of different medical devices in the cardiovascular field, so that's who I am. So with that, we're going to talk about renal denervation and advance this way. Okay. Do I see the slides? Oh, I see them here. Okay. So just to kind of get it very fresh in your mind, what does the sympathetic system do in the kidneys? And if you look at the chart here on the left side, we have direct and indirect functions of the sympathetic system. Of course, the indirect are systemic with hemodynamic changes. But more interestingly, if you look at the right side of the chart, the direct sympathetic effects, we have effects on the renal artery, which is constriction, we have effects on renin production system, which is the juxtaglomerular cells. They produce more renin. And we have direct effect on the proximal tubules, stimulating them to retain sodium, thus increasing the blood pressure. There are some minor effects here, but I highlighted those 3 in red because these are the major effects of the sympathetic system in the kidney. On the right side, you can visualize the glomerulus and the afferent, the efferent arteriole going in and out. And you can see the macula densa in the distal tubule, and the 2 little nerves there, the sympathetic nerve endings, is exactly where those nerves end in the kidney cortex, stimulating the cells in the afferent arteriole to produce renin. That's basically the physiology in a nutshell, and the illustration where these nerves end in the kidney. Now, with the next thing is when we went to renal denervation as a therapy, the first thing the business had to learn, and I was instrumental in that, to learn the anatomy. And we started with doing histological sections of cadavers to study this field. And one of the first questions that we had is there a space for ablation, which is kind of nobody thinks about nowadays, but the retroperitoneal space was unknown to interventional cardiologists, and the space provided there is defined by the retroperitoneal fat. And that's going to become important later in the slides. But as you can see here in the histology, you have proximal, mid, distal, and branches sections of human renal artery. The renal artery is designated with RA. The vena cava is VC. This is the right side. And then in red, you have ganglia. And in green, you have nerves, the structures there. You can see that all these structures are confined within a lot of fat, ample fat. And that fat, that adipose tissue, gives us the substrate for us to go and do very effective ablation and spare other organs. Because if you don't have the fat, you will be very more closer to pancreas, for example, or duodenum in this area. So what can we learn from these images? What it tells you is that if you look at the proximal segment of the renal artery, you see the nerves are all over the place, and you see ganglia. If you go in the middle segment, you see the nerves getting very close to the renal artery in that vicinity, and the ganglia are still present in the mid portion of the renal artery. When you go to the distal portion, there's no more ganglia. All the nerves are extremely close to the renal artery, and in the branches, of course, they follow the same pattern, and they basically follow the course of the renal artery towards the kidney. One important thing to notice in these slides we learned also very early on, 10 years ago, is that the nerves are exclusively associated with the renal artery. There is this, if you remember from embryology, the vein, the nerve, and the artery, there was a triad that was developed embryologically, but the sympathetic nerves always follow the artery because they end with the artery, so they have to follow that path. The repercussions of that is that we don't have nerves situated behind the vein. If you look at that section there, all the nerves are around the artery, and the vein can be there, but they're not behind the vein in the human species. So I have data around that basically had to prove that. Okay, on the picture on top, this is a study by, I think you showed that earlier, by Dr. Garcia Truchart in Spain, where he had very, very talented graduate medical students that spent months and months and months dissecting the fat away in cadavers, dissecting the fat away to expose these renal nerves, and to show us the basket formation, the plexus around the renal artery, and to show us the late arriving nerves and the ganglia there and how they basically form in a human. So all this work was done in conjunctions of developing the devices, and the engineers had to understand the substrate, where they're going into and what they're about to do. Okay, so I showed you a pretty picture, and that's not how the world is. And so here's a patient that has a very early branching, almost like a duplication of the main, has an accessory and has a very big ganglia, and some of the nerves are going tangentially. They're coming in the middle of the course of the renal artery. This is typical. The lessons here are you have to denervate the accessories, absolutely. Every single accessory is richly innervated. You have to get in there. And then the one that is here, the bifurcation, the top one, is no longer a landmark because it's such an early bifurcation. If you think distal is before that bifurcation, you're not distal. Distal is actually somewhere towards the kidney. So what I like to tell physicians is to try to also judge that space not only just by the bifurcation as a landmark, but to judge it as the distance between the aorta and the kidney, take that space, divide it into thirds, and you can decide what distal constitutes, so you're in the most distal part. It's a little trick in the angiography. Okay, so again, comment on pretty pictures. Us pathologists, we like to go and publish things and say things like representative image. And when they tell a representative image, the little secret is that we show you the best image. And I was showing you that first image on the left side that's very clean, and there's only fat and the renal artery and the nerves and the vein, nothing else. But most cadavers don't look like that. This was one cadaver I picked to teach people around. Most cadavers look like the person on the right side, where we have lymph nodes, lots and lots of small vessels. The nerves are all over the place. When we have disease, if you can look at the renal artery, and there you have basically the beginning of atherosclerosis, and the renal artery is slightly thicker, so you have a little bit more space to overcome with your therapy. So with that comes a problem. How do you design a therapy to go outside of the vessel, seek out the nerves, and destroy them without you knowing where the nerves are, right? So remember I talked about the fat. So what we ended up doing here in this device is to design a specific flavor of RF energy that basically ablates the fat and spares all other organs. Every single organ is richly supplied by blood. In the case of the ureter, it's urine, and those organs are spared by this particular flavor of RF, but the fat is not. And if you create random lesions throughout the course of the renal artery, ablating the fat in a 360 fashion, you would also ablate the majority of the nerves. And the point there was the more lesions you do, the higher the drop of the blood pressure is. That's the reason. So I'm switching here to experimental studies in pigs. These are pigs that are ablated by renal denervation systems. On top, the red portion on top is the psoas muscle, renal artery in the middle. In black, you have the outline of the lesion. So the lesion looks very irregular because it's a current. It follows the path of least resistance, heats up the fat, and ablates the fat. But inside the fat, you can see here in the top left, there is nerves. They're outlined in red. And they kind of swell in this particular picture. This is a 7-day study, and they're devoid of axons. So again, pathologist showing you a pretty picture, there's nothing else. But what happens when you have lymph nodes? What happens when you have veins? So this particular flavor of RF, the tuning, it's tuned such a way that when it meets a tissue with high flow, like a vein, the lesion doesn't go on through. Basically, it stops right there. So you can see on the top right, we have a very small lesion. There's one nerve in there, one nerve outside, and the vein is there, kind of compressed, but the lesion doesn't cross the vein, doesn't ablate the vein, doesn't cause any problems with the vein. Same thing with lymph node. The lower left image, it stops at the lymph node, it stops at the other artery, which I think is the psoas major artery. And then in this particular lesion, we don't even see any nerves in there, but again, the point there that this is a safe therapy. That's how it was. And my favorite picture is the bottom right, where you have the lesion choosing the path to follow the fat in between the vein and the ureter on the top right, and basically ablating the fat, but sparing those structures and effectively denervating the nerves included in the fat. So in a way, we joke about at Medtronic that this is our secret sauce. This is how we make our Coca-Cola. And now I'm educating all the physicians how the RF works in the space of renal denervation in the retroperitoneal fat. That's basically the secret. So now you know. This is data that I have to show to the FDA to tell them that this therapy is safe, and basically saying what's the injury of the ureter, necrosis, kidney, lymph nodes, other organs compared to nerves. And as you can see here, the nerves are mostly affected, the other organs are not. This in a scale of 0 to 3, 3 being obliterated, 0 none, 1 is mild. So all of the other ones are basically beyond mild affected. Now, I'm going to talk about nerve atrophy in 2 slides, I think. Okay, here's the interesting stuff. So I was asked, how do you know this works? I was lucky enough to be on the committee that purchased the company Arden, and I had to go and make a recommendation if this therapy is real or they're making it up. And that's how we know it's real, right? You call a pathologist, look at the stuff. You have a normal nerve on top, intact sympathetic nerve, very round, plump. It has bundles and streams of supporting cells, Schwann cells, and inside the Schwann cells you have axons. Very kind of a light pink, very thin capsule, small vessels in there, nothing around the nerve. Basically, there's no fibrosis. That's how we describe a normal sympathetic nerve. When you go in day 7, you have shrinkage of the nerve. The nerve now is hypereosinophilic. It's darker in color because it has a lot of macrophages in there, and the Schwann cells are reacting as well. You have swelling, you have fibrosis, the beginning of fibrosis. Day 28, now it's a mess. That's not nerve anymore. At day 28, I can tell you that this nerve doesn't conduct any signals because mostly what you have is frustrated Schwann cells consuming dead cellular debris, reorganize the nerve into basically a scar tissue. And day 60, if you follow that progression, now we have a shrunken nerve with sharp edges. Inside, there is no interlacing bundles and streams of Schwann cells with axons, but you have Schwann cells that are basically macrophages by phenotype, and the outside is fibrosed. So that's the end result of renal denervation. And that's how we know that these nerves basically degrade and become a scar where you treat in the treatment area. So that's the morphology. When we look at the one level up, we start asking questions, can we actually probe for axons? Axons are the extensions of the ganglia that reside in the neurons in the ganglia. So we have a special stain here, an immunohistochemical stain. These are the same kind of techniques that you use to detect cancer or basically classify cancer, same technique. That stains axons. In a naive animal on the left side, you see the entire nerve is brown because the majority of the nerve mass is axons. In a treated animal, you still see a nerve. It's outlined in green, but there is no stain. You can see Schwann cells, but you don't see axons. The axons are dead. They're getting consumed. So that's on the level of the renal nerve. If you go in the level of the kidney cortex, where these nerves end, you can actually see in the naive animal around every single arteriole in the kidney cortex, you see small axons. These are brown little structures in there that are easily picked up. I even have an AI system that goes and quantitates the density of these things and tells you how many axons are present in the kidney cortex per square millimeter. If you look at in the treated animal, they're not there. And if you go and look at treated animal at day 180, 6 months, they're not there either. They don't come back. So it's durable in that regard. So this is kind of how we pathologists decide to basically make a judgment of this thing. Is it working? Is it not working? And then to take it on another level, on a physiological level, now we take the kidney cortex and give it to the chemists, and they tell us what the norepinephrine content is, what is produced by these nerves. And there is a strong correlation between the TH stain, the special stain that I just showed you, and the content of norepinephrine, telling you that, yeah, it makes sense. If you have nerves, you have norepinephrine. If you don't have nerves, there is no norepinephrine, to the point that our studies are showing us that 1 square micron of nerve, which is 1 axon, produces 1 picogram of norepinephrine, which is basically physiology 101. It's amazing to get that from 2 different assays together. And for the fun part on the right side, this is the famous IVY study that you mentioned this morning, Dr. Petrov, and it stands for IV. This is something that came from my lab, and I'm especially proud of it. I think this study saved the entire therapy and brought it back to life. It's IV because IV and Y, but IV in English also means IV, the plant IV, and the Ivy League universities, so we think it's an Ivy League study. That's the internal inside joke on this particular study. But if you do the Y, you can see here a tremendous drop of norepinephrine. You can also see that it's extremely consistent. There's no outliers. So all of these kidneys have gotten complete denervation. So that's kind of the point here, that if you denervate properly and thoroughly, you'll get a very good result. Okay, now, something very interesting that's happening here, 2 different things I'm going to show you. Again, normal nerve on the left side here, plump, round, no fibrosis, interlacing bundles and streams of Schwann cells with axons. If you look at the ablation site on the top row on the right side, you see at day 7 the inflammation, and you see how the nerve is basically effaced. The nerve structures don't exist, and if you look at it then day 180, which is 6 months, that nerve doesn't come back in morphology. It's still effaced, it's very fibrotic. But if you look at downstream, so if you follow that nerve, you ablate next to the main renal artery, if you look next to the kidney, all the nerves shrink. They basically collapse, and I call that atrophy, distal atrophy, because basically the axons, the bulk of their mass disappears, so they come down to the size of Schwann cell cytoplasm, which is small. So this shrinkage can be quantified, and it's a really good indication for us in experimental medicine is a successful ablation. So downstream atrophy, nerve atrophy, has become an extremely good predictor in animal studies of successful denervation. So that's one interesting thing to know, that these nerves atrophied and they don't come back. I'm going to take that picture on the top right and give you another interesting observation here, that when I first saw this is I think 60 days study. This is the same picture stained by a different stain to show you the cellular bodies. And they basically, what's happening here is the Schwann cells are leaving the nerve bundle, and they're spreading outside in a very kind of a papillary projections in a very haphazard, unorganized way, trying to regenerate, but it's not functional. This function, if you take this picture and show it to any pathologist and say, what is this? They have diagnosis. We have diagnosis for this. This is called amputation neuroma. This is exactly what you see at any amputation sites. It's a haphazard attempt of the small nerves to regenerate. We have shown that with the help of other pathologists, they published that this happens only at the site of ablation. It doesn't result in any functional restoration, and it doesn't extend distally. But it's also another indication of how the nervous system is reacting to this basically insult, with the ablative insult. So for me to see that we have something that I associate with amputation sites was another marker of confidence for me in this therapy as a pathologist. Okay. And now, this is all nice for a person like me to look at slides and extract concepts and look what cells do, but the reality is that this helps patients. And the most important thing about renal denervation that Professor Petrov emphasized this morning, that this therapy is always on. And it's on at 2 a.m. in the morning, where you have your patient most prone to have a heart attack or a stroke. And basically, that's the protective always-on effect. Illustrated, I think this is HTN on METS trial. But if you look at every single trial that we've done, the same pattern appears, that we have segmentation of the baseline and the treated vessels. So to me, renal denervation works. Renal denervation is durable, and I look forward to have more clinical data on the long term, which is the most exciting thing, how the long term basically deepens the effect and allows that effect to become even more stable and a better clinical outcome. So I think that's my presentation. These are some conclusions that I just summarized, and thank you for your attention. I'd like to take questions if anyone wants to engage in a pathology conversation. Thank you.
I wanted to ask you,
Yeah.
do you have some notion regarding the ultrasound-based degeneration of the nerves and so on?
Yeah.
Did you take a look at such data? Is it similar or?
Yeah. So yes, I have taken a look, both internally and publication-wise, whatever is published. The company is called Recor. I think you didn't remember it this morning. Owned by Otsuka Medical. And both ultrasound and RF, radio frequency, induce nerve degeneration by high temperature, by thermal damage. And so the effect is basically nerve dying because it's cooked. And when you cook something, by whatever method you cook it, it's going to have the exact same morphology as this. Now, their lesions are different. They do one lesion that's like a donut shape, and it's one area that they're going after a different application, we try to do many lesions along the renal artery and increase our chance to ablate as many nerves as possible for that. But the morphology of any high temperature induced ablation in these nerves is going to be the same. There are other modalities that we didn't talk about, but simply there's a company that does it by injecting alcohol. And alcohol causes a completely different morphology. It's basically a toxic neuropathy, local, a lot of inflammation, a lot of scarring with that alcohol, but it's also very effective if you're comfortable with injecting needles through the renal artery. And there's a fourth modality that's out there that's plausible. It's cryo. So you can freeze the entire renal artery, you can freeze the renal nerves, and they die with a different mechanism, and they look different. That's mostly coagulative necrosis. So the nerve gets completely effaced from cells and regenerates back with a scar. So I can tell them apart. If you show me a slide, I can tell you what is what. But I think for the clinical terminology, probably doesn't matter that much. So we have different options, I think, for that.
Thank you. Theo, Professor Business.
First of all, thank you for this really beautiful presentation. I finally understand how it works. My question is, we know from the ablation that the cardiologists are doing in the heart for arrhythmia, that they are doing some kind of mapping of the nerves. Are you going to create something similar in order to have more safe and focused ablation?
Yeah. So I think there was a similar question. Thank you very much to bring that aspect to the therapy, because that's an unanswered need. And I think there was a very similar question this morning to you, right, with that mapping, and you said there are effects. In fact, we also tried it. When you do it, we put a probe in there and stimulate and try to get these signals. It's like a jungle of noise. So the muscles have their noise. It's very difficult to pinpoint what is actually coming from the nerves. So we haven't found yet an engineering solution to that problem to map it out. The heart is easy because over there you have the benefit of ablating bulk tissue that's immediately adjacent to your catheter probe or whatever you're putting in there, whereas here we do a distal ablation of something I don't even see. In the early days, I was advising the engineers how to basically lower the threshold for safety here, but I remember telling them it's very difficult. This is Confucius from China. It's very difficult to find a black cat in a dark room, especially when the cat's not there. So it's a different problem, and one day we'll solve it.
Okay. And the second question is, I have been involved a few years ago with the pacemaker on the carotid arteries, where we have done a surgical cut down. The question is, it maybe it's a silly question, but why are we not doing the same thing in the common carotid artery?
Well, I think there was some early, there was the ROC system and that system. Yes. Yeah, so the early trials that they did in a few humans, they did not show very good results. There were some side effects. I forgot which of those therapies had really problems with sleep apnea, deepening sleep apnea. And so you start messing up with the CO2 levels in the blood, and that wasn't very good.
Okay.
But I'm going to add to your question, and this is what I tell my business, is that in our body, every single organ has sympathetic innervation, and every single disease is affected by sympathetic and parasympathetic signaling. So we have a tremendous opportunity to have renal denervation being the first ever therapy towards a denervation, basically therapy of many, many different diseases. So we should continue the partnership and think about more therapies.
In fact, this is the reason to have now initial data from many trials regarding sleep apnea, regarding rhythm disorders, reducing probability of recurrent rhythm disorders after the ablation. So more than obvious, this pathologic mechanism of hypersympathetic tone is typical not only for the hypertension, but also with many other diseases, including diabetes. So I think the horizon for investigation and development is quite bigger than arterial hypertension.
Exactly, and I think the business has appetite for that.
Okay, great.
Right. I want to add something in my cadaver studies that I've done throughout the years. I learned something really interesting, is that if you start classifying human cadavers in age, you're going to find that older people have more sympathetic nerves than younger people. And I think we're looking at a phenomenon called nerve plasticity that is age dependent and probably some pathology dependent. But maybe, I don't have data for that, just hypothesis, but maybe what we're doing here is not ablation, but we're normalizing the sympathetic, we're modulating the sympathetic tone or normalizing that signal in the body versus us removing something. So we have to study that more to figure that out. Thank you.
Great, thank you. Thank you once again for the fantastic presentation. And let's go back to the program. I would like to ask Dr. Business, Professor Lundero, Professor Nikolov, please take your seats. Take your seats on the moderators. And I think the first presentation is by Professor Nikolov regarding the open versus endovascular first approach. New? Okay, you know.
What's new?
Professor Chervenkov, thank you for joining us.
Dr. Dobrichkov, what's new in peripheral vascular interventions?
Okay.
It's a session.
Това е втората сесия.
Yeah. Honorable Chairman, dear colleagues, thank you for the invitation and the opportunity to be here today. Just a second, because I cannot see my slides here.
12:10, където пише.
Okay, yeah, usually I have problems with the start of the presentations. So today I will try to make as short as possible overview of the latest endovascular devices and implants. I have actually nothing to disclose, so the only purpose of that presentation is only information and update. Thankfully, the stone age of the vascular surgery is over, and in the 21st century, literally every week new devices are launched on the market, which improves the endovascular therapy. So let's first start with very short overview of the top introducers and closure devices, because this is the alpha and omega of each endovascular procedure. So the Prelude IDEO by Merit is an interesting sheet which has a flat bare braiding technology, which makes the wall of the introducer a bit thinner, with thinner profile. So the outer diameter of it remains the same, while the inner diameter is larger. And also it increased the kink resistance and compression resistance. Another very interesting device is the CO score sheet, because it transforms every plain balloon into scoring platform. So it's basically a sheet ending with that cutted shape, and when the physician inserts the plain balloon and inflates it, it causes controlled microincisions like every other cutting balloon, and after deflation of the balloon, the sheet goes back to the initial shape and size. It could be used for all kind of peripheral arterial interventions, and also for compromised arteriovenous accesses. So 2 days ago, Professor Nikolov told us a lot about the closure devices, especially for the suture base. So there are a few updates in the Pro style by Abbott, comparing with the previous device, ProGlide. Maybe one of the most interesting is that snared knot pusher, which makes the tightening of the sutures a bit easier. So let's go very fast to the catheters. First, unfortunately, of that catheter, it's really interesting. 3-4 by Cook. I couldn't download the video from the Cook website, so you can try to shoot the QR code and see the video on your phones how it works. So it combines. It could be used both for support and diagnostics. Actually, it's indicated for venous procedures to pass by chronic venous occlusions, but also it could be off-label used for chronic arterial occlusions in the aortoiliac region. So it contains with 4 French catheter and 5 French sheet going over O35 wire, 2 lengths of the catheters, and according to the tip of the catheter and the sheet, there are 4 configurations of the tip. So the principle is going something like a periscope technique, going first approaching with the wire, after that going over with the catheter, advancing with the sheet. This is the main idea of that. So most of us know about the go back by upstream. Actually, about a month ago, it was sold to Bentley, so now the new name is called BEC. It's the same time crossing directional and re-entry catheter in one device, and at the end it has directionally controlled needle which could be deployed 3, 7, and 11 millimeters. For example, for heavily calcified or with hard fibrotic cap from the beginning of the lesion, the needle could be advanced, could be deployed without a wire, just to make a puncture in the lesion. And as you can see on the video, in case when the wire goes in a different direction, it could be redirected just with steering the control of the device. There are 2 shaft lengths, 80 centimeters and 120 centimeters, and because that device could be used, it could be used both for below the knee and above the knee procedures. There are 2 sizes of the catheters, 2.9 French, which goes over O14 wire, and 4 French, which goes over O18 wire. And yeah, I think I said almost all about it. So the limb flow is very interesting device for deep venous arterialization. So the DVA is a buyout method for limb salvage when there is no arterial flow. And when performing, that procedure could be performed, of course, open, but when performed percutaneously, it minimizes the trauma and the possible amputation risk. So first, with ultrasound guided, the vein is cannulated and the venous catheter is advanced up to the puncture site below the knee, and antegradally the arterial catheter is advanced antegradally again below the knee. Yeah, that video will take a bit long. So from the venous part, that snare-like net is open, and a puncture needle from the arterial catheter comes from the artery to the vein, very similar to the re-entry devices. A wire is deployed, and after that the snaring is possible. The procedure is followed by dilation between the artery and the vein. Then comes the second, then comes the second venous catheter, which is valvulotome, actually to destroy the valves. And yeah, a bit slow. And the vein is covered with the self-expanding stent, which is yes, a stent graft. Yes, sorry, which is part of the whole system, and prolongated with the other stent graft to the artery. So basically, that is the procedure. So let's go next to the flex vessel prep system. It's quite easy to use system. With 2 millimeter automatic tip going through the lesion, and after that, with opening the treatment element, 3 knives, micro knives, causing micro incisions while pulling back the tip of the catheter. It works basically like scoring balloons, but before ballooning. So in the last few years, there is nothing that interesting with the guided wire, so I'm going to skip that part and go back to the thrombectomy systems. Let's start with the Jet-I by Abbott. It's a quite new device. Actually, it's not very popular among Europe. It's widely used in the US, and only a few centers in Germany and France use it. So it could be used both for arterial and venous fresh thrombus removal. And it uses high pressure saline jet to fragment the clot within the catheter while reducing the catheter clots. So that minimizes the risk of distal embolization. There are two low-profile catheters, 6 French for the arterial thrombectomy and 8 French for the venous thrombectomy. The next interesting thing is the new Indigo system, Indigo Lightning by Penumbra. As the previous Penumbra, it could be used for removal of fresh thrombi and emboli from the arterial and venous system. Also, it's again indicated for treatment of pulmonary embolism. But the new thing is that there is an indicator and a valve. So when the tip of the catheter is into liquid, so into the floating blood, the valve closes, so that prevents the blood loss during aspiration. So let's go to the new debulking devices. I'm going to start with the shockwave balloon, which is a great device for endoarterial lithotripsy. So it has great procedural success without any embolization, and the major adverse events at 30 days are quite down to 0, and the freedom from TOR at 30 days is 100. So the results are really impressive. Bicross by Plasmedica. By the way, Plasmedica is a great German company with a really nice portfolio, many stents, many balloons, and also they have good ablation devices for treating chronic venous insufficiency. But let's go back to Bicross. So it's a 6 French bidirectional rotational atherectomy device. The good thing is that it's battery powered, so we don't need any additional gear to use it. The calcified debris is aspirated through the integrated pump and collected to the collection bag. And the good thing is that when we have heavily calcified proximal cap, we can use it without the wire. So first we can mow a small incision through the plaque, and after that advanced with the wire. So now I'm going to show you 2 real lightsabers for endovascular procedures. The first one is Auron by Angiodynamics. It is a laser debulking device using 355 nanometer of wavelength. It's very interesting that this is one of the very few debulking devices indicated especially for in-stent restenosis. It could treat both super and inferior inguinal lesions, and both below and above the knee. So the other similar device is Dabra. The interesting thing about it is that due to photoablation reduces the plaque types into their fundamental chemistry, so no risk of there is practically no risk of distal embolization, and also because it doesn't have any mechanical mechanism of action, it doesn't stretch the arterial wall and does not penetrate in the subintimal space. Some of the balloons, Celotron. Many of us know it is the first limous balloon used treating peripheral artery disease. It's with different diameters and lengths. I'll try to go as fast as possible. The other balloon is Magic Touch by Concept Medical. The good thing in that is that the sirolimus is micronized and kept in small lipids micelles, let's say. So when we deploy the drug to the arterial wall, it remains there for longer, and the plasma levels of the limbus are much lower compared to other balloons. The Paradise by Record Medical, we already heard today a great presentation by Dr. Petrov about the renal denervation, so just mentioning it. Some of the brand new implants, the eye cover, probably many of us know it. It's nothing that interesting about it, but it has a quite good flexibility for a balloon expandable stand. Also, it has really good so it's the membrane, the PTFE membrane is very elastic, so it could expand with more than 2 millimeters in diameter. Another very elastic implant is Solaris, which is self-expandable stent graft, and it has a great flexibility, and because of the flexibility and the elasticity, it could be also used for compromised arteriovenous accesses. The temporary spur stent system, really interesting device, which is not launched to the market already, still in investigation phase. So it's basically a retrievable stent system with radially expandable spikes, which helps to deliver the anti-proliferative drugs into the vessel wall. So that makes easier to make good revascularization without leaving anything behind. Another interesting stent graft balloon expandable, this is the Radiant by Medtronic. So this is the first balloon expandable cover stent indicated for CHIVAR. Raisin by Terumo, it's dual layer stent, so the inner micro mesh has very small size, designed to limit the plaque prolapse and reduces the distal embolization. On the other side, the outer layer has really good radial force and the same time low chronic outward force. Also, it has great flexibility and adaptation to the wall. That stent is especially indicated for SFA and popliteal artery. And I'm going to finish my presentation with two interesting gadgets. So the first are the first is the rods and cones smart glasses, which could be used both for teaching and mentoring during open and endovascular procedures. And of course, Corindas by Siemens. This is the brand new robot, actually the first robot which is indicated for peripheral procedures, because the other endovascular robot R1, I think, it's only for coronary interventions. Of course, it has all the advantages of each robot. So thank you for your attention, and I'm sorry that I was a bit late with, yeah.
So we have some new stuff in the peripheral interventions. Some questions, colleagues? Lots of questions, lots of stuff. Okay, let's continue with the program. Professor Business.
Okay.
Advanced endovascular techniques for BTK chronic total occlusions.
Thank you again for the kind invitation. I have my, okay, perfect. So I'm going to present you a short overview with videos of what you're able to do in CTOs. But before we starting with the CTOs, we have to understand how it looks like, because by this way you will understand what kind of technique you have to use. So the chronic total occlusion, if you see in a macroscopic view, you see that it is full of calcification. There is a small always channel in order to go with your wire, and in the histological analysis you will never be able to get inside through these black stones. You're going to find a lumen, maybe it is subintimally, maybe not, in order to find a way to open the vessel. Until now, or not until now, let's say during the last years, we are trying to analyze the CTO. And what we have seen is that in the structure of the CTO, there is always a hibernating lumen. That means a lumen that it seems closed in the angiography, but it is always open. And this is where you have to go with your wire. In order to get into this hibernating lumen, you have to study the CTO in such a way that to understand how you're gonna reach this hibernating lumen in the best possible way. So you're looking at the CTO if it is an undergrade or if it is in the undergrade part, if it is a convex or concave, and the same thing is in the exit of the CTO. So you may have this kind of, let's say, structure where you have to go from undergrade. You may have this kind of structure where it makes more sense to go through the dorsal pedal or the posterior tibial artery upwards, or you may have a combination of both proximal and distal tip where you may need a rendezvous technique with 2 wires. So again, this is the hibernating lumen of the CTOs. You can see there is calcification, but it's also fibrotic tissue and thrombus. So what you need is to penetrate this kind of fibrotic tissue. At the moment, there is a very nice classification that it is in trend, the CTOP classification, which classifies the CTOs below the knee in 4 different types. Type 1, where you can go really through an undergrade approach. The type 2 is really difficult because if you get inside through the undergrade approach, then you're going very nicely in a subintimal space when you're trying to exit the CTO. Then is the type 3, where you probably need a lot of different techniques to have the rendezvous technique of the wires. And finally, the type 4, you can do everything through the so-called TAMI procedure. That means from the pedal arteries upwards. So what actually is recommending is for the type 1, it is to make a traditional CFA access. For type 2 and 3, a dual access, that means pedal and femoral, and for type 4, a pedal access. So this is some kind of pedal access. For this reason, you need the hockey ultrasound stick in order to have a better and more comfortable place to puncture. Try to puncture always at 12 o'clock of your artery in order to have better closure with the manual pressure, and try to avoid puncturing above or below of these 2 red lines, because otherwise you are at risk of a compartment syndrome, and we have seen it quite often when we are puncturing the fibular artery. Here's a way of puncturing with ultrasound. As I said, 12 o'clock with a hockey stick. It is very, very simple. You think it is difficult, but it is very simple. It's like puncturing the radial artery. If you have or you are not familiar with the ultrasound, we have developed a small technique that we are giving contrast agent, and we are puncturing until the contrast agent is outside. You can see here the contrast agent is coming closely. We are puncturing on that side, and then the contrast is getting outside. You are pretty sure that you are inside, and then you're going upwards. So appropriate equipment, you need a needle, you need an O18 wire. We're preferring the V18 wire, and we're preferring either O18 balloon, for example, Pacific Plus for Medtronic, because you have the stability, or a CXI catheter, or every support catheter that it is O18 compatible. This is such a case where you can see that we have a really bad tibial vessels. Here we have puncture the artery, we are going up, and then we are having a rendezvous technique because we were not able to get further down. And after getting inside the artery, we were able to get directly through the sheath, then ballooning the anterior tibial artery, and then have a nice overview and a nice flow through the artery into the different branches of the forefoot. Massive improvement of the arteries. This is the case where actually this case was sent for a major amputation, but we were able to do a minor amputation in this case. Then in a second stage where actually the infection has been gone, you can perform a metatarsal amputation. You're taking skin from above, and then you have a nice result. And at 2.5 years follow-up, you have a nice, still the foot is on place and the patient is still walking. So there are, however, there's not everything so simple by just bringing the wire upwards or downwards. You may be in subintimal space from both sides. So there are different techniques like cart, reverse cart, parallel balloons, facilitate re-entry catheter. This is such a case with a reverse cart technique. When you are actually going up to the level of the distal anterior tibial artery, nothing goes through. You see we have a loop like in the live case before, In this case, we were not so lucky. So you're going in subintimal space, so no way to get out. So puncturing then the dorsal pedal artery going above, and then trying to get at that level again subintimal space. What is the next step? You're taking a balloon from above and balloon from below. You are bringing the distal marker from both at the parallel position. You are opening the balloons and you're deflating acutely both of them. At the same time, you are pressing the wire upwards, and in the majority of the case, you have a successful, let's say, rendezvous technique of the both wires and a nice opening of the artery. And this is what actually leads to a very good healing of the gangrene. So the use of out-back re-entry system is a very elegant technique because you're using the needle and you're trying with the needle to get in an inflated balloon. That means you're pretty sure that you are inside the artery. This is the case, for example, very, very tough case of below the knee CTO. You're going up with the wire retrogradely. Here we are not able to get inside. What we have done, you see an inflated balloon from below the out-back catheter. You see a reversed L. The L means where the needle is getting outside, and you're putting in such a way that the needle will penetrate, will destroy the balloon. After the destroyment of the balloon is deflating acutely, and the wire is cut, is jailed inside the balloon. And by this way, you're removing the wire outside. This is the way you do it. You're puncturing. You see now acute deflation. The wire is inside the balloon, and you're just removing the balloon outside. It seems very exotic, but believe me, it is relatively simple. Now, in this case, we have done a nice angioplasty. The gangrene is on the first two, very nice improvement, and after minor abutation, we had a very good final result. Pierce technique, my best one, because it really helps. This technique has been published always from the guru of CTOs in the BTK, the Japanese guys. They have a lot of fantasy and imagination in their techniques. What they have developed is very simple. So in this case, it was very difficult to get through the dorsal pedal artery. So we went with the wire and the balloon. The wire went very nicely through, but the balloon couldn't get inside through the calcification. What we are doing, you are puncturing the skin and you are destroying the artery with the needle just to have the balloon coming through a fragmented calcification. Again, here we couldn't go further. Try to be as aggressive as you can. Nothing will happen, because after the balloon angioplasty, everything will be recovered, and by this way we were able to get through the balloon, through the lesion, and to have a very nice result at the end. And this is how it looks like. The final result, we were able to save at least all the tooth of the patient. Important, however, before starting doing PDK is careful. Read about the anatomy of the arch, because nobody, it is actually the majority of the people, they're starting doing interventions and they do not know how it looks like. Very nice paper, the one from Marco Manzi. Read everybody about this paper in order to understand how it looks like and the anatomic position of the different arteries. Here is another difficult case where you have to know exactly the anatomy, and here, of course, an important artery is missing, is this one. After opening this artery, we had a very good flow, but however, this was not the key point for healing this wound. The key point was this branch that was closed. Don't ask me how we call it, I have no idea, but you have to know that it is there. And we opened this and after a lot of years of this patient using again and again wound dressing, we had a nice healing. And our final case is the recanalization of collaterals, very frequent in diabetic type 1 patients where you cannot see any continuous flow. This is a very, very difficult case. Amputation, salami effect, always they have been amputated something from this patient. However, looking at the angiography, you see that there is a nice collateral from the fibular artery going up to the posterior tibial artery. And this is what we are doing, this kind of spectroscopy in Athens, in order to see if we have a better effect after the opening of the artery. This is an important branch. We open it with several techniques, and this is the spectroscopy before and after the recanalization of the branch. And by this way, you know that whatever you're going to do, and here we have done a skin transplantation and minor amputation, we were able to save the limb. Even in this picture, the patient still can walk. Finally, we have heard about the lymph flow. We are not so rich. We are trying our best again in Greece, but we are not so rich to use the lymph flow at the moment in Athens. So we have used the VAS technique developed from the Spanish guys, August Isa, where he were using two snares, one in the vein and one in the artery. We are going with the needle through the artery, and then from this part through the vein, having the needle inside both snares. By this way, you're checking that you are with the needle inside. You are inserting an 014 wire, very floppy, and then you're just pulling out the two snares. That means you have a wire in the vein and a wire in the artery. Having this, you have now the same effect that they have done with the two expensive devices that LymphFlow uses. And then what coming next is to open the artery with a respective balloon. You were using a balloon expandable stents, and then one after the other. Here is, for example, the balloon expanding stents coming from the artery into the vein, and then with all the steps that are actually staying the same, you see we are destroying slightly the valves. We're getting inside the venous arts, and then aggressive with 5 millimeter ballooning of the veins. You see how it looked like. There is always a spasm there, but nothing happens. You're still working. We're giving a little bit of nitro, and then at the end you have a very nice result. You see we have to go through the arts in order to open the whole system. So this is the case after further amputation. We were able to still keep the forefoot in place. In synopsis, ladies and gentlemen, the TAMI procedure, the retrograde puncture of the pedal arteries, the CTOP classification changed completely the success rate of recanalization of BTK CTOs. The technical success amounts at the moment around 97%. It requires a learning curve and the appropriate equipment, and the AV reversal seems to be an effective strategy in no-option CLI patients. Thank you very much.
Questions, colleagues? I have a question, Theo. Go back or out back?
Good point. I would say the go back in the video seems that it's everything so simple, but it is not, because when you're trying with a go back, it is a support catheter, but the point is if you are not really, you have enough space to push the go back inside the lesion, the go back is not pushed because you need the support of the wire. So this kind of, I'm just changing the rotation and I'm going few millimeters with the wire and then pushing further, it doesn't work. However, you have two things in one. That means you have two devices in one device, and in the from the point of view of cost, of course, it is good. The second thing is that you have a 2.9 French. That means you can use it very nicely below the knee. And the third point is we have seen a lot of problems with a go back catheter if we have a very difficult bifurcation to go through. Yes. This does not happen with the go back catheter.
And about the Pierce technique, do you use?
I love it. I love it.
Without vocal or?
Without?
Vocal anesthesia?
No. You can use a little bit of contrast because the majority of them, they are diabetic. They have no pain at all. You can do whatever you want. You can cut the leg. They will not understand it. So you know it. So at that point...
Hopefully not.
Yes. No. We are trying our best. So the point is with the Pierce technique, we are going very closely to the artery. The majority of them, they have, it is like a calcography. You can see very nicely under fluoroscopy. So you're just not, puncturing in the middle middle of nowhere. You know exactly where you're puncturing. You see that the artery is moving up and down. And of course, you may see a lot of extravasation afterwards, but after 3 or 4 minute angioplasty, everything is fine.
That's good. Okay, thank you. Anybody else? No.
Thank you.
Thank you, Theo.
Next presentation is open versus endovascular.
Yeah.
First approach, what is the current evidence?
So, dear colleagues, I want to present a study of our department about open vis against endovascular first approach in SFA and what is the current evidence. We have this guideline 5 years ago, which says that in lesions more than 25 centimeters, we have to go hybrid or open surgery. Hopefully, we will have the new guideline in 2024, because I don't think this is the situation now for the SFA especially. We have this guideline for 2 years after the first one for the critical limb ischemia. It gives some directions when to use bypass, when to use endovascular, and this gray area, which is not so gray now, and the Wi-Fi classification. We have so many studies comparing endovascular first or open surgery first, and if we sum up, they all say yes, surgery is good patency, but high morbidity, high mortality, endovascular low mortality rates, more interventions, and low hospital stay. Let's see some of the biggest publications. This is endovascular against open surgical repair from 2017. They compare almost 6,000 patients. And as you can see, amputation or mortality is bigger in the open surgery group. But this comes when you look at the right table. This comes mainly from patients who are with critical limb ischemia. So these are the sickest patients of all. As you can see in the co-education group, there is almost no difference. Another good meta-analysis, this is again comparison between two techniques. As you can see, almost 70,000 patients to 27 studies, 7 of which are randomized. We have less complication rate in the endovascular group, shorter hospital stay, as I said, less amputations and lower mortality. Another good publication from this year, the outcomes in the Medicare link database. And when they compare two methods and make adjusted hazard ratio, it was obvious that in limb salvage we have no difference in, almost no difference in reinterventions, a little bit more in the endovascular group, and almost no difference in amputation-free survival. But there is this publication, again from this year, from Australia and New Zealand. They have matched pairs, endovascular versus open surgery. They didn't seek for patency, but their main conclusion was that we have a slightly higher mortality rates with the endovascular techniques. Katsanos? No. Okay. We have these publications, this meta-analysis, when we have failed endovascular procedures and we go with open surgery. And this meta-analysis in the European Journal of Vascular Surgery says that, yes, open surgery is much more difficult after failed endovascular. But from this year, we have this publication from Nicola Truisi, that he made a comparison with the limb safe registry, and the conclusion is that if we respect the surgical sites, no problem with failed endovascular reconstructions, you can do in situ venous bypass. So there will be no issue if we respect open surgery landing zones and vice versa. What does this mean? How many times you see ligated or transected superficial femoral artery and you cannot do endovascular treatment, or ligated and transected popliteal artery, for example. So we have to respect each other
specialties. The only trial we have the comparison endovascular randomized trial comparison about endovascular and open surgical is the Basel. It's old trial. As you can see, they have no difference in amputation-free survival, bypass surgery, but bypass surgery is more expensive. This is not so in Bulgaria. Bypass patients, nevertheless, gain after 2 years, gain more 7 months of life expectancy. We are looking for Basel 3, and basically studies, but to my opinion, I think whatever the results are, endovascular will be the first option for such patients. I want to show you our retrospective analysis. We have 3 groups of patients, almost the same numbers, open, endo, and hybrid for 5 years. So as you can see, during the years, the open surgery getting low and the endovascular group is getting bigger and bigger. We have a stable level of patients with the hybrid. The hybrid technique is reserved only for the toughest of the cases and more extensive one. DH, it's almost identical in all groups. This is the distribution with Fontaine classification. As you can see, more of the sick patients going with the open surgery, 34%, and more of the claudicants are treated by endo procedures. The hybrid is stable again. As you can see, this is the complications we have in the 3 groups. The mortality rate is almost identical with the open and the hybrid procedures, and almost 4 times lower in the endo procedures. We have this rethrombosis, restenosis, hematoma. As you can see, the restenosis rate is biggest in the endo group, and the amputation rate, I'll speak about that later. This is the difference in the ABA index when the patient comes into the hospital and discharged. The main difference is at the hybrid group, and this is the primary patency of these patients for 1 month. As you can see, the best patency we have with the endo procedure, and after that is the hybrid procedures, and last comes the open surgery. This is the cumulative patency for almost 5 years. As you can see, after the 2nd year, we have a clear benefit of the open procedures. The blue, they have better patency than the endo and the hybrid, but this is after the 2nd year. The reintervention rate, the biggest percentage of reinterventions we have with the endo procedures, after that the hybrid, but as you can see, very good primary assisted and secondary assisted patency rates. The amputation-free survival is the more important thing we are looking for in this study. So at the 1st month, it is no matter to say that, but at 1 year, the better amputation-free survival has the endo group. And after that, the open, and at 3rd place is the hybrid. At 5 years, again, the best amputation-free survival rate has the endo group, and after that, again, the open surgery, and hybrid is last. So, the treatment strategy in SFA disease, don't forget that we have to start with something else, not directly with the procedure. We have to make a lifestyle modification, tobacco use, weight, and especially exercise training programs if you have such. The optimal medical treatment, the comorbidities, it is obligatory to give our patients with PAD high-intensity statins and an antiplatelet agent. I prefer clopidogrel, but there we have very good evidence to use acetyl salicylic acid and rivaroxaban from the COMPASS and from the Voyager PAD study. And of course, psilocybin, we heard about that today from our colleagues, that it's a very good treatment strategy. If we have invasive treatment, endo is first. I'm pretty concerned about that, especially in the SFA region. This is my first approach. What are the benefits? Invasiveness, morbidity, mortality, hospital stay, cost effectiveness, mobility, complications, and so on, and so on, and so on. So endo first in SFA disease. If bypass is needed, we have enough evidence. Autologous vein is first. Then we can use the hybrid surgery. It's the best place for this disease. And as last resort, we can use biological prosthesis. And if we have no other options, synthetic bypass should be used only in very extreme cases. And of course, in teaching hospitals, for the surgeons not to forget how to operate. So thank you for your attention.
Presentation is open for questions, comments. Yeah.
Fantastic presentation, very, very objective. Congratulations. And of course, there are pros and cons for all the methods. I would like to ask you, and it's very much operator dependent, both techniques, endo and also surgical. So it depends quite a lot on the experience of the team. I want to ask you for a methodology that was popular several years ago. Now is probably not so much. I don't know why. And also, I would like to be happy to listen to opinion of Dr. Bizdas regarding the so-called endovascular bypass. You know the hemoban and viaban on a long segment from the first point to the exit, and special modification of this. You probably saw many cases done by Andre Schmidt with total destruction of the vessel, including extravasation, but massive extravasation with oversizing balloon, destroying the calcium and destroying the vessel, and very fast implantation of a long covered stent graft, gore, hemoban and viaban. What is your opinion?
Pave and crack technique.
Yeah.
So actually it's the only way to treat a severely calcified SFA, but important is in the strategy of Andre that he's using afterwards a superior stent. That means not the viable alone. Yeah. It doesn't work. You need a superior afterwards.
Support.
So yes, to support, because we know from the long viaban study, this is one from Thomas Zeller, the 25 centimeter, it seems that it has good patency, but it is quite the similar thing with the superior. Everybody sees in the evidence it works, but when you're doing alone, it doesn't work. I don't know why. So the same thing is with the viaban. We see good results in the dedicated studies with well-selected patients, but when you put the viaban, it always closes. So what is the mistake? Probably is exactly what Andre performs. He's performing a very aggressive paving and crack in order to open the vessel, and then supera in order to avoid the recoil. So this kind of endo bypass, I'm a big supporter of this. It is too expensive, however. Probably it is better to perform a good vein bypass if you have a good landing zone. If you have the money, of course, it makes sense. There is also the PQ bypass, where you're going through the through the femoral vein again into the artery. We still need evidence about this. The Cleveland Clinic supports it a lot. For me, I feel a little bit uncomfortable to have a stent inside the vein for a deep vein thrombosis. They're saying they don't see it. And there is also a third treatment strategy coming from a Greek guy from Paris, where he's going externally through the, he puncturing the SFA, he puncturing from above, and he performing an endo bypass outside from the artery. But still it is only one person that's doing it, so we still need a little bit more evidence. So this is my response.
Yeah, you
Thank you.
Yeah.
The detour, PQ.
Yeah.
Thank you so much.
Any other comments, questions? Dr. Voce?
I have only one short question for you. Do you believe that endovascular first approach would sacrifice your result in the consecutive open surgery in case endovascular fails in CLI patients?
No, because I know what to keep. which landing zone to keep.
Thank you.
You have always, if a surgeon or an endovascular specialist, you have always have to think about consequences and to leave a plan B for you. Because in fact, we are not treating this disease radically and forever. The only radical operation in vascular surgery is the amputation. So we have to think about consequences.
Okay, thank you. Next presentation is from Professor Lombero, intravascular lithotripsy in the treatment of calcified lesions.
Well, thank you again for the invitation, Ivo, and the rest of the organizing committee. Dr. Dobrikov introduced you to this technology, intravascular lithotripsy for the treatment of calcified lesions. I will try to give you a more deep vision of the technique. Let me go. As you know, 30 to 50% of peripheral endovascular intervention have to fight with calcification of the artery. Intimal calcification is the result of the atherosclerosis disease, but medial calcification is a different animal, probably most often associated with renal disease, diabetes, and aging. Calcification of the arterial wall has some consequences related with the endovascular treatment. That calcification restricts the arterial compliance of the artery, result in poor balloon expansion and final arterial lumen, increase the risk of dissections and acute procedural failure, impeding device crossing and good stent expansion and apposition, and reduce long-term patency following endovascular treatment. May impair to the effectiveness of drug-coated balloons. Distal embolization, no reflow, dissection, and perforation remain a concern with the atherectomy usage. Then the development of this new device for the treatment of calcified lesion could be an interesting thing. How is its intravascular lithotripsy developed? Is based in extracorporeal renal lithotripsy, but have some difference. Extracorporeal emits a focused beam through the calcium. Intravascular lithotripsy emits an unfocused circumferential beam. This is important. Penetration of the extracorporeal is around 150 millimeters. The penetration of the intravascular lithotripsy is 3 to 7 millimeters. The mechanisms are different. The mechanism of extracorporeal is compression and tensile stress, cavitation, expel, squeezing, etc. The mechanism of intravascular lithotripsy is compression stress to fragment the plaque. This is the device. The device consists in a generator who generates electrical discharge that goes through the connecting cable. The connecting cable has a command to activate the pulse sequence, and the balloon catheter for lithotripsy is variable in diameter and have different number of shock wave emitters. This is how shock wave works. First, the IVL catheter is delivered over an O14 coronary wire, normal coronary wire, standard coronary wire. The balloon is inflated to 4 atmospheres. This is not to dilate the artery, is to achieve balloon vessel wall apposition, to oppose the balloon to the wall of the artery. An electrical discharge from the generator up to 3,000 volts vaporize the fluid within the balloon. The fluid is a mesh of dye and saline, creating a rapidly expanding and collapsing bubbles that generates sonic pressure waves. The sonic waves create a circumferential effect that travels through soft tissue without consequence, without damage the soft tissue, and cracking intimal and medial calcium, not only the superficial calcium, but the deep calcium too. After calcium fragmentation, cracking, not fragmentation is not correct. After calcium cracking, the balloon can be used to expand the artery up to 6 atmospheres. It's not a high pressure or medium pressure balloon. Here you can see the OCT images of the effect of the device in the plaque. This is the pre-treatment image. This is the post-treatment, where you can see the cracking longitudinal fissures of the calcium. There are different devices for different territory. Now we have a new M5 lithotripsy balloon dedicated in general to TAVI and EVAR access, 8 millimeters in diameter, 60 millimeters in length, with 5 emitters. The M5 is for iliac and femoral arteries. The balloon is 3.5 and between 3.5 to 7.0 millimeters in diameter, 60 millimeters in length, and have 5 emitters. And the S4 for below the knee arteries, 2.5 through 4.0 balloon, 40 millimeters in length with 4 emitters. There are a number of studies that support the usage of this technology. The Disrupt Peripheral Artery Disease Study 1, 2, and below the knee are safety and performance studies done to demonstrate the feasibility of the procedure. The Disrupt Peripheral Artery Disease 3 is a randomized controlled trial who enrolled 306 patients, and there are ongoing registry that will enroll 1,500 patients. It's important to know and to accept that intravascular lithotripsy is the objective of the intravascular lithotripsy is to increase the compliance of the artery wall. But this treatment needs a definite treatment to finish the procedure. In this series of 333 patients in 5 studies, you can see that in 50% of the cases, lithotripsy was associated with drug-coated balloon usage. In 4% of the cases was necessary to use special balloon, in particular high-pressure balloon, atherectomy device in 12%, and stent implantation in near 20% of the cases. Then again, lithotripsy is not the definitive treatment. The object is to make the artery more compliant and to respond better to the different device. Here are the complication rates in these more than 300 patients, and as you can see, the severe dissection is exceptional, less than 1%. Perforation, 1 case in 300 cases, in 300 patients, or 3%. There were no thrombosis, no distal embolization, not abrupt closure, and no reflow. We can say that the method is secure. This is a comparison with other methods of treatment of the calcified lesion, directional atherectomy, rotational atherectomy, and orbital atherectomy, and you can see that the incidence of complications with IVL is extremely low and not equal for the other methods. Here in the randomized trial, which compare IVL with plain balloon for superficial femoral and popliteal lesions, you can see that the final lumen is final residual lesion is less important for IVL than for plain balloon, and that only in 11% of the cases with IVL don't reach a lesion, a final lesion below, above 40% residual. And with plain balloon, this success in 20% of the cases. This is our experience in Argentina. In 1 year and a half, we have done 78 cases, 97% gross success, and geographic success in 100% of the cases, without major complications, without minor complications. The great majority of the cases were iliac or femoropopliteal cases, not too much below the knee treatment, but I think, in my opinion, below the knee is one of the principal indication of must be the principal indication of the method. To finish, which are the advantages of IVL? IVL is easy to use, like a conventional balloon, don't need a learning curve, disrupt deep and superficial calcium, not only superficial, don't need special wires, or 14 coronary wire, standard coronary wire is enough, In bifurcations, the second wire is not retrieved, can be left during the treatment, have very low incidence of complication, in particular perforation, slow flow, distal embolization, and is effective in large arteries. In my opinion, the potential indications of IVL are the treatment of moderate to severe calcified lesion of iliac, common femoral-popliteal below the knee arteries, calcified lesion of abdominal aorta, pre-TAVI, pre-IVAR, pre-TIVAR, and pre-impella iliac artery condition in cases of heavy calcification, and potential could be used in carotid arteries, renal arteries, superior mesenteric and celiac trunk. Thank you very much.
So, some questions, colleagues, to Professor Londero. If not, I have a question. What do you think you have potential for the carotids? Should we use it with a filter or directly with...
With filter?
Yeah.
No, without
for the
filter.
carotid.
No, without, because
without filter.
the calcium is don't remove. The calcium is just crack. And it's not embolized. The calcium don't embolize with this technology. This is one of the advantages, the big advantage of the technology.
If you allow me, because we have some experience in different territories, this is probably the biggest advantage, that it's not fragmented, but it's only cracked. So it's a release of the resistance, nothing more. It stays there. For example, we had a very interesting patient after carotid stenting. The stent stayed relatively compressed, and in several months, in fact, the patient, unfortunately a doctor, he had additional restenosis. And we tried to open with a non-compliant balloon. It was non-dilatable lesion. And with a 6 millimeter shockwave balloon, we succeeded to crack the calcium and the stent opened. And it's only one of the cases. In fact, because it's too expensive and it's not reimbursed, we use it in a very special indications. For example, for TAVI, to open the artery up to the diameter that is in fact advisable by the company in order to cross with the TAVI delivery system. For non-dilatable lesions, the problem is that like all new technologies are applied only in most desperate cases. For example, long calcific occlusion CTO of the SFA, after crossing with the wire, sometimes it results that it's really undilatable. And unfortunately, still they have only short versions. And this situation, we need 200 centimeter version, not only 60 millimeter, 200 millimeter. And of course, this is like a proposal to the company to elaborate longer versions, because otherwise the technology for me is definitely very good, very clever, very intelligent.
Yes, it's important to say that to have longer balloons, you need more emitters. To have more emitters, you have more connections to the generator. Then the diameter of the catheter may increase. This is one of the problems of increase the length of the device. Stent subexpansion is one of the most important indications in coronary arteries, pre or post stent implantation.
We did last week a patient very calcified coronary lesions. We did IVL, intravascular lithotripsy, both for the LAD and the huge diagonal branch. it was like a cast of calcium. Of course, diabetic, it's typical for diabetic patients. So only this way it was possible to dilate these lesions.
In this case, important is that you can use both wires in place during the procedure.
It's true.
The principal vessel and the secondary branch can be cannulated during the procedure. You don't lose the position.
Thank you.
Thank you.
So, next speaker is Dr. Dimitar Nikolov, retrograde approach to infrainguinal CTO.
Thank you. Can I have my slides? Dear colleagues, I will try just shortly to remind you the importance of this technique. We know that in over 50% of the patients with symptomatic PET, we have total occlusions, and this is our daily practice. In critical limb ischemia, there is often multi-segment involvement of the disease, and this population often is unsuitable for bypass due to poor target, lack of appropriate venous grafts, and severe comorbidities. That's why there is a clear trend in the treatment in recent years, not so very prominent, towards increasement of the endovascular procedure in the periphery compared to bypass surgery. Any endovascular treatment of total occlusion have to pass through several steps. First, to get good access, second, to cross the lesion, and finally, to deliver therapy. And the retrograde access we'll talk about have implication in all of these steps. The most important in crossing the lesion, it was initially proposed for cases of antegrade fails, but it later was introduced as a primary access if the antegrade access is unsuitable or in specific morphology. And it is also very useful if you have through-and-through wires to easy deliver therapy in tortuous and very stenotic lesions. The retrograde access was introduced in more than 30 years ago with popliteal access in prone position, and years after that it was used by using tibial pedal, distal SFA, popliteal in supine position, and so on. Why is the retrograde access working? It is because very often it is easier to be done, and the distal cup is softer than the proximal cup. There are less collaterals engagement. The short working distance to the occlusion gives more support. Many operators prefer it because it's cheaper than the re-entry devices, and the most important, the complication risk is relatively low. In most of the cases, the retrograde access is used if antegrade crossing is not possible, and it can be the situation in up to 25% of cases because of flush occlusions, some superintimal crossing with impossible re-entry. In cases of perforation, impossible progression of the wire in heavy calcified arteries, and this is the cases for additional retrograde access. This is one of our cases with wire leaving the artery. You can see on the second picture. We used direct puncture of the distal SFA under fluoroscopic guidance. Easy progression of the wire, snaring, ballooning, and very good final result. Another typical case with three occluded tibial vessels. Only anterior tibial is patent distally, but the antegrade wire going always around the artery, and after successful puncture at the level of the ankle, rewiring, ballooning, the result is perfect. There is a growing evidence of effectiveness and safety of this technique, and after this come popular in years, we can now use it even for a primary access. This is a very good paper from American colleagues. Dr. BEC&ISEVS also mentioned it, the tummy technique, which uses the pedal axis as a primary axis. This is another case of ours, of a 68 female with the rest pain of the left leg. The previous aortobifemoral bypass made a difficult antegrade puncture, and on the CT there was a short occlusion of the distal SFA and only one vessel runoff, peroneal artery, but also a short patent proximal anterior tibial. We succeed to puncture this artery under ultrasound guidance and introduce a micropuncture set, and after that a 4 French sheet. This is the level of the occlusion above the knee. It is relatively short with some disease in the SFA, and after the ballooning the result is acceptable. How can we predict who will need retrograde access? This is a very, very good work. Dr. BEC&ISEVS also mentioned it, the C-top classification, which relies on the morphology of the proximal and distal cup, where type 1 is probably very well doable with antegrade access, and type 4 with primary retrograde access, and the 2 and 3 types probably need bidirectional approach. There are still some controversies and differences in practice. Which vessel should be used when you have several options? Under what guidance, ultrasound or fluoroscopy? Should we use introducer and when? And how to achieve hemostasis? I will share some of our preference. When I'm trying to do retrograde approach, I was always try to stay as close as the distal end of the occlusion, as proximal as possible. This way, I think we can spare distal vessels for future interventions. I'm doing it with roadmap or calcium as a guide. Some cases are very easy to be done with ultrasound, the distal ATP, ATA, and SFA. We always use 21 gauge needle with the 018 or 014 wire, most of the time only with support catheter, very rarely with introducer. And after lesion crossing with the support of microcatheter, we use snaring of the wire, externalization, and most of the times completion of the procedure from above. And hemostasis can be achieved with manual compression or with low pressure intraluminal balloon for 3 to 5 minutes. Our personal experience includes 87 cases of 85 patients with CTO of above the knee, below the knee, or both. We used, in all this series, retrograde approach after failed antegrade. This is the clinical stage. Most of the patients are critical limb ischemia, only 15 claudicants. The location of the lesions was equally above and below the knee, and in 13% engaging both territories. The occlusion length from 4 to 44 centimeters. The most used artery was anterior tibial, and the second, the SFA. We used introducer only in 10 cases, and the primary technical success was 95%, and procedure success 94%. We used POBA, DCB, stent, and boards in these numbers. And most importantly, the complication is pretty low. We have one distal embolization, 2 AV fistulas, one of them discovered on the table, but it was very, very non-significant and remained like this for 3 years. The other one was detected 2 weeks later when there was a drop in the ankle brachial index, and we had to recover it by surgery. 1 spasm and 4 hematomas, 2 of them related to the distal axis of the SFA and 2 to the antegrade common femoral axis. And also 2 cases of contrast nephropathy, because I didn't mention, but half of the patients are diabetics, and there is a danger for them. In conclusion, retrograde ataxis is feasible and safe. It is very effective despite the technique varies among operators. It can be used as bailout and as primary approach for infrainguinal CTO. Several clinical and lesion characteristics, including the C-top morphology, can be considered when planning and performing the intervention. It is obligatory for every interventionist dealing with PET to be familiar and to get training in retrograde ataxis. Thank you for your attention.
I have a question. How long are you staying from above? I mean, 10 minutes, 20, 1 hour?
Well, it depends. 2 hours.
Yeah, we saw the contrast nephropathy.
Because when do you think that is, okay, enough, I have tried anything?
Yes.
When you're chasing for, when you are at the moment where you're dissecting everything, or you see, okay, it cannot go very quickly, I will not change to different catheters?
In the past, I struggled a lot because I was afraid of retrograde ataxis.
Okay.
Nowadays, no. And many times, most of the times, we have CT for these patients, and I have in mind that I will need probably retrograde access, and if it doesn't work from above, go directly. The patient is usually prepared, draped properly for retrograde access most of the times initially, before the starting of the procedure.
For me, Theo, as the specialist become more experienced, so he has less patience.
Yeah.
10 minutes maximum.
Actually, yes.
Yeah.
The same for you.
Yeah, if you allow me, in fact, in our practice, nowadays we are switching much faster. So the threshold to switch to distal is much lower, because we have read, of course, the results, but also we revised our results retrospectively, and we saw that we have 0 distal complications. So there is, in fact, no complication. In the beginning, we used to make a hemostasis with a balloon inflation, prolonged balloon inflation, but not anymore, because simple compression for several minutes with 2 fingers is absolutely enough. Still, sometimes we are putting gauzes over the puncture site, but even sometimes we don't do even that. And because in several cases, in fact there are not several, there are 15 cases of sheetless implantation of a superstent all the way to the femoral artery, so the proximal SFA. It's absolutely doable to implant the superstent without putting a sheet. So like you mentioned, in very rare cases we are using a small sheet, 4 or 5 French maximum. And in fact, it's quite efficient because of that. Probably enthusiastic by the cart and reverse cart in the coronary CTO and retrograde approach. We have colleagues, cardioangiologists like we are, that are routinely using tibial pedal and radial approach to open from the ostium, the SFA, to all the way down to the distal popliteal and tibial. So as a routine approach, not as a second plan B, but as a plan A. So this is Zoltan Ruja. He has several publications and very big series of patients with very good success.
If you consider that, for example, Biotronic provides a 4 French stent, the pulsar stent, actually you can do everything from below. So We are doing the same if we have really patients that they are adipose with a lot of, with a belly like this. You're not able to do anything there.
Absolutely.
Yeah.
But their DCB is 5 French.
That's a problem.
So you have to use, for example, the slender sheet, 4 to 5.
Okay. Thank you very much.
Thank you.
It's a fantastic, really very nice experience, and we are going to shrink a little the program in order, of course, to have the possibility to finish on time. And I would like to ask Dr. Velchev to join the panel team. And also I would like to ask Dr. BEC&ISEVS to share his experience regarding the role of endovascular therapy in penile arteriopathy. That is new territory for us, so it will be quite interesting to listen to your experience.
Yes, so erectile dysfunction was always something difficult for the vascular specialists, because the urologist always said, we are doing the job, there is nothing to do there, and also due to the fact that the devices that they have been used there were not really dedicated for this problem. But believe me, it's a huge problem at the moment in the society, and I will show you some important issues. The penile erection can be caused due to a problem with the functioning of the nervous system. In order to have a penile erection, you need a good arterial flow, you need a healthy corpora cavernosa, and then after this, you need, due to the healthy corpora cavernosa, this makes it able to block the venous blood spill, and then by this way we have the penile erection. So where we are now working as a vascular specialist is to check the good arterial flow and the healthy corpora cavernosa, and we have amazing now tools in our armamentarium in order to really help the urologists and not to take the job from them, because this is how it looks like. So the vascular etiology is the most common cause. We have neurological, we have drug-related, we have hormonal, let's say, causes of erectile dysfunction, but the vascular etiology remains with a percentage between 60 to 80%. More important, and that is why that is explained my comment about how huge the problem is that actually the erectile dysfunction is the top of the iceberg, because the problem is that 75% of diabetic patients will develop erectile dysfunction, and more important is that erectile dysfunction is more common than retinopathy or nephropathy. Average time interval between onset of erectile dysfunction and coronary artery disease is between 2 and 5 years. That means if the man is really clever enough to tell to the cardiologist, I have an erectile dysfunction, he can give him the opportunity to make an ultrasound, a coronary angiography, and to save his life. And he has been associated with silent coronary artery disease in diabetics, number of cardiovascular events. That means if you have erectile dysfunction, you are 2 times higher at risk of myocardial infarction with increased LDL and decreased HDL, that is clear, and it is, has been associated also with smoking. However, the current guidelines for therapeutic management, according to the American Urological Association and the European one, the first step is to modify the lifestyle of the patient. Second one is to start using the PED5I, that means Viagra and all the other medications. Then there is the vacuum erection device. Believe me, if you have seen it once, you will never use it. Then it is the intraurethral alprostadil. The quality of life for those patients is not the best one, especially if you think that he has to do it always before the event. And then they are using, and this is actually the most common thing, the low-intensity extracorporeal shockwave therapy. Finally, there is the penile surgical arterial reconstruction, which is actually something that will destroy the corpora cavernosum. There is no return, there is no other option, and it has been associated with high infection rate. So and then it goes to the penile prosthesis implantation. No mention about endovascular arterial revascularization in atherosclerotic disease. No mention about endovascular embolization with microparticles in case of venous insufficiency. Now, important is to understand that 75% of patients with erectile dysfunction present an arterial stenosis, and now it starts the game. So you see here very nicely the most important branch for this reason of the hypogastric artery, which is actually the pudental artery. The pudental artery is the artery that goes from here, goes down, and then goes to the penile artery. And you can see it very nice, very simple in your DSA, but just putting right oblique for the right pudental artery, left oblique for the left pudental artery. Actually, when we want to see the right hypogastric artery, we're going for the left oblique, but here is quite the opposite. We're going the right oblique for the right pudental, left for the left one. There are different, let's say, types of the origin of the pudental artery. Please don't care about them. This is just for science. It is very simple to find it. There is a protocol. This protocol has been adapted from our Italian friend, cardiologist, Dr. San Giorgi, where he's looking at a very nice and simple score. This is the IEF-5 score. Actually, it is IEF-20, but they have simplified in five important questions. This score is actually is used from the urologist. Then you can do a penile Doppler, and you can see the inflow insufficiency when you see a peak systolic velocity of less than 25 centimeters per second and EDV less than 5. If you see that there is bigger than 25, higher than 25, with higher end-systolic and diastolic velocity, we're talking probably about venous leakage. This is something that it is better to do the interventional radiologists because they are more familiar with embolization. And then there is also the mixed pathology. After that, you don't need to go for an DSA. You can do a very nice CT angiography of the pudental artery. Believe me, you can see very nicely the whole length of the pudental artery. And then the first step is always, of course, to start using conservative treatment. That means PDI inhibitors that can be used for at least, let's say, 3 to 6 months. And then if it doesn't work, the second stage is to come to the vascular specialist. Here is an angio-CT where you can see 2 high-grade stenosis of the pudental artery, and then you cannot really appreciate what happens in the penile artery. What is really important is to understand if you're gonna open the pudental artery, it will work. And why we are asking ourselves this? Because if you open the pudental artery, but the corpus cavernosum has a fibrosis, then nothing will happen. And thanks God we have nowadays the CO2 as contrast agent. Due to the high viscosity, to the low viscosity, it goes up to the corpus cavernosum, and by this way we know exactly if our intervention will work. That means we're inserting a small catheter in the pudental artery, we're injecting CO2. If the CO2 reaches the whole corpus cavernosum, we know there is no fibrosis or microangiopathy, and then we can do the intervention. Otherwise, if nothing reaches the corpus cavernosum, then the problem is done. The patient needs a penile prosthesis. And then you are going and you're starting doing the intervention. It is a simple intervention because the arteries of the branches of the hypogastric arteries, they have the same structure from a histological point of view like the coronary arteries. So whatever you're using for the coronary arteries, you're going to use also for the pudental artery. Sometimes if you create a dissection, you may need to plant a stent. There are different branches that can be affected in the angiographic analysis of 291 lesions. The majority of them, they were up to the penile artery, so we're talking about diameters from 1.5 to 2 millimeters. So what should we do? There are several devices. The old traditional treatment was the POBA. It was a disaster. Everything has a restenosis within a few months. Then they used the drug-eluting stents from sirolimus and zotarolimus. And finally, due to the fact that they have seen a lot of fracture and high-grade restenosis, they now started using drug-eluting balloons, either paclitaxel eluting balloons or sirolimus eluting balloons. There are several studies that they have been published about the procedural success. The procedural success is actually relatively high, almost 100%. There is only one paper talking about 65%, but if you see more of the majority of them, they are cardiologists that they are really, really well familiar with this kind of devices. Now, regarding the evidence, we're starting with a ZEN trial, which showed high-grade restenosis. This was a study that used only drug-eluting stents. The same then the Perfect 1 and 2 trial. This is the reason why the interest was left from the society due to the high restenosis rate at 12 months. Then we have the Perfect 3 trial, which actually randomized POMBA versus drug-eluting stent, and it was discontinued for drug-eluting stent. And finally, the Perfect 4 trial. You know, these trials, they tried, but still they couldn't reach the result that they wanted. And then it came a very important study from St. George's where they used for the first time sirolimus eluting balloons and not paclitaxel eluting balloons, which actually started showing very good results. So in conclusions, ladies and gentlemen, the endovascular revascularization of arterial inflow is a safe and effective option to treat erectile dysfunction. The POBA alone showed poor results. Drug-eluting stents showed high restenosis rates, but due to the fact that we have now paclitaxel and sirolimus coated balloons at the diameter between 1 to 3 millimeter, it seems that we have a new treatment tool in this important vascular territory. Thank you very much.
Excellent presentation, Theo. Some questions from the audience?
Yes, I would like to ask you, a few months ago on Leipzig there was a great presentation regarding this disease, and it started, they don't say, we don't ask, we don't learn. Did you manage to convince the urologists in Greece that it's important whenever they see a diabetic patient to send him for vascular checkup?
Well, it is what I'm saying to the urologists is that I will not take their patients. I want to help them because the patient is a diabetic patient. He has erectile dysfunction. The urologist will do his job by doing all the ultrasound, all the medication, the shockwave therapy that they are doing. But the point is, I can help me by explaining him. Okay, if with the CO2 I cannot see the corpus cavernosum, whatever he performs, it will not work. The patient needs a penile prosthesis. And actually this helps the neurologist from a legal point of view to explain to the patient, okay, we have to go directly for the penile prosthesis. On the other hand, if the corpus cavernosum is working fine and he has a high-grade stenosis, I will open or you will open the arteries, and again, that doesn't mean that then the patient has a very nice erectile function. He needs a little bit more support from the urologist, and actually at the end, the urologist seems that was the successful guy that helped the patient. By this way, at the moment, the urologists are starting helping and supporting us. It is the same problem like the gynecologists, the obstetricians with the pelvic congestion syndrome. It is difficult to convince, you have to try, still trying it.
And do you have any experience with varicocele regarding this subject?
No, I don't.
Any other questions? Thank you, Theo.
Thank you.
Thank you. Excellent presentation. And the next speaker is Dr. Alexander Gheoreschi from North Macedonia. Can we?
Thank you very much for
Hello, Alexander.
your invitation, kind invitation. It is a pleasure to speak after this hot topic, interesting topic. We have actually we have the same issues for prostatic artery embolization, and with our urologist and with our gynecologist for the uterine fibrate embolization. However, I will try to finish the session for below the knee interventions. The topic of my today's lecture is current status of endovascular treatment where we are today. As a background of this lecture, with an aging population as well as the increasing prevalence of diabetes and chronic renal insufficiency, there has been a recent global increase in the patients with chronic limb-threatening ischemia. These patients typically have tibial and pedal artery occlusive disease, which is characterized by long stenosis and occlusions as well. Amputation is one of the most devastating consequences of chronic limb-threatening ischemia, and the evolution of our treatment options is to prevent and resolve this complication. However, 12-month outcomes of these patients are very, very poor, and the mortality rate is very high. Amputation rates at 4 years for Rutherford class category increases with every category, being around 70% for a Rutherford class C. At the first diagnosis of CLTI, the mortality risk is around 25% and 60% at 5 years. So how do we treat these patients? We heard a lot today about endovascular treatment, but is there still a room, is there still a place for surgery? I took for this lecture the Italian Society of Vascular Surgery protocol and guidelines for treatment of patients with CLTI, and I found that they have very nice step-by-step approach for this patient. If a patient has a nice clinical status, which means he is in a good clinical cardiovascular condition, if this patient is suitable for bypass surgery, for example, there is no tissue loss, there is no bad infection, if there is a suitable vein for bypass and the diameter of the artery, the distal diameter is above 1.5 millimeters, then this patient can go to open surgery. However, not more than 5 or 10% of these patients achieve all of these 4 steps. So if any one of these steps is no, then the patient goes back to our cath lab for endovascular recanalization. Of course, if we fail to improve these tibial vessels, then the patient can still have some option, and at the end of the presentation we will see which is this option. It was already mentioned before by Professor BEC&ISEVS. What about the problems? The problems are becoming from the calcification, as we know, not like in the other vasculature. In the BTK vessels, medial calcification are particularly common. And this medial calcifications increases the arterial stiffness and drives poor prognosis of our treatment. As we know, modern devices like atherectomy, scoring balloons, cutting balloons do not modify the medial calcification so good as the intimal calcification, for example, in the proximal SFA or the popliteal artery. What about the comparison? What about the devices that we use? Is drug-coated balloons equal or better to standard PTA? Several studies and one nice meta-analysis done several years before in 2016, which shows that there is no clear benefit regarding the TLR rate, so the target lesion revascularization. If we take for a point of success, there is no clear benefit if we use drug-coated balloon versus the standard plain balloon angioplasty. You can appreciate the numbers. What about if we take the wound healing, which is also a very important point, and the Rutherford class improvement, again, comparison between drug-coated balloon and standard PTA. Several studies and the same meta-analysis show that there is no clinically, statistically significant difference in long-term wound healing, which is around 6 months after the procedure. There is no clear benefit and there is no proven success for the DCB group over the PTA alone. If we take the amputation rate, which is, in my opinion, the most important endpoint of these patients with CLTI, also comparison between the drug-coated balloon and standard PTA, we can appreciate at the end of is there better amputation rate or lower amputation rate, I would say, in the drug-coated balloon group. If we take all these studies in the same meta-analysis, the answer is still no. What about the comparison for the drug-eluting stents versus standard PTA? Well, there are also several studies which compare the drug-eluting stents. To be honest, the lesion length of the stented region was around 4 centimeters in total in average, so not so long as usual when we do standard PTA for below the knee vessels. But if we compare, we can compare the TLR rate in all of these studies. We have clinically and not clinically, but statistically significant difference in favor of the drug-eluting stent group. You can appreciate on this slide how the TLR rate is the lowest in the group that was performed by drug-eluting stents. What about the amputation rate that we mentioned before? Comparison with drug-eluting stents versus standard POBA. Several studies, again, the newest one from 2017. There was no clinically and no statistically significant difference if we compare the drug-eluting stents versus the bare metal stents plus POBA. So in short conclusion, I would say that randomized trial mainly report the TLR and the amputation rate as the clinical endpoints of our success of endovascular treatment regarding the BTK vessels. There is a substantial improvement in the TLR rate if we use DES applied but in short lesions up to 5 centimeters below the knee. Drug-coated balloons, there are many drug-coated balloons on the market, and they were mainly all investigated in BTK vessels, but on the opposite of the SFA region, in long lesions, they didn't show any significant difference compared to the standard plain balloon angioplasty. And current randomized trials support still the PTA as a workhorse technique for our everyday patients with CLTI and long BTK lesions. From this paper from Roberto Ferraresi and Marco Manzi, we can appreciate that more than 80 or close to 80% of the patients have involvement of 2 or more than 2 BTK vessels. So this is a very complex disease and very complex procedures that we need to deal with. I would take the Abano-Terme endo strategy, and I use the same one in my cath lab. I always tend to start endoluminal with the common femoral artery approach in an antegrade fashion. I try to stay endoluminal. If not, I go to the subintimal approach, but still from the antegrade fashion. If there is an impossibility to cross, then we switch to the retrograde access and one of these famous techniques. I would suggest for everyone who deals with the critical limb ischemia patients and also with the endovascular treatment of BTK vessels to read this older paper from 2011 from the same group of Marco Manzi and Roberto Ferraresi. They show they very nicely in a didactical way, they show the normal anatomy of the above the ankle and also below the ankle arteries. How to standardize our everyday procedure, so which projections to use, the correct projection in order to have repetitive procedures, and we can do in our everyday practice. And they say that around 80% of patients still have this, I would say, normal anatomy with one dorsalis pedis artery and medial and lateral plantar arteries, which are connecting in the so-called pedal arch. So as we mentioned, antegrade CFA approach, first choice, is accepted. There is also our recommendation from our Society of Vascular and Interventional Radiology for treatment of below the knee vessels from 2021, which are very nicely explaining every step of this procedure. We have several concepts so far, the so-called complete concept, which says that one vessel is better than 0, and 2 or 3 vessels are better than 1 in favor of the tibial vessels against the peroneal one. The so-called angiosome or wound-related concept, we have the direct revascularization is better than the indirect, for example, the collateral way, and the old concept linked to the limb salvage. Let me show you some cases, a typical diabetic cases, dialysis, critical limb ischemia, and non-healing second toe amputation wound with Texas University class 2C on the first and third toe. This is the baseline angiography. You can appreciate some moderate stenosis of the fempop region and very, very poor vessels in the forefoot with very small and tiny distal dorsalis pedis artery. So as I mentioned, we try to go antegrade. We managed to recanalize the anterior tibial artery up to the ankle, but we went subintimal and we went into dissection and we couldn't proceed. So we punctured the distal part of the dorsalis pedis artery, connected the two wires, and we did the revascularization, the so-called direct revascularization. We managed to open the dorsalis pedis artery, and this is the final result with a nice vascularization in the foot. In this patient, another patient, similar like the previous one, some small stenosis in the Hunter's channel of the superficial femoral artery. 2 vessels above the ankle, dorsalis pedis, without any medial or lateral plantar artery. In this patient, we chose to open the posterior tibial. We went up to the calcaneus, but we couldn't get any further. We went subintimally, so we tried to go retrograde from the anterior tibial artery through the pedal arch. We managed to make the so-called rendezvous technique and to connect the 2 wires. You can appreciate how the balloon doesn't want to open because of the stiffness of the medial calcification that there is in the lateral plantar artery. At the end, this was the result. There is some residual stenosis, which was treated with cutting balloon at the end. And this was the final result with successful intraluminal retrograde recanalization of the foot arteries. I would skip these slides for the perfusion angiography, but nowadays this is very important and hot topic that we should all try to use if our software and our NGO suite provides the so-called perfusion angiography in order to be sure that the vessel we treat is going to have impact or is going to have success for the patient. What is the new options? It was mentioned before from Dr. Theo Bizdas in the so-called no option CLI patients is the procedure which is called venous arterialization. Who is the no option patient? A no option critical limb ischemia patient is a patient without any target foot vessel. Today, the small artery disease is the most common cause for these no option patients. At least 10% of the CLI, maybe even more, present with the final failure of the foot distribution system. Let's see 2 cases. This is a very diffuse but no critically stenosed femoropopliteal artery with involvement and occlusion of all the 3 below the knee vessels, and in the forefoot we have some small dorsalis pedis, everything else is collaterals. After opening of the anterior tibial artery, these are slides from Roberto Ferraresi group. I need to thank for providing me for this presentation. So in this particular patient, they only opened the anterior tibial artery and look at the end how nice patent pedal and distal foot arteries from this procedure with opening only 1 artery. This is more or less the same patient, it's a different patient with the same angiography picture, I would say. Some stenosis of the femoropopliteal region, maybe even better tibial vessels. However, in the forefoot, there is a small dorsal pedal artery without any peripheral arteries. And this is the so-called small artery disease, the SAD patient without any small vessel which is providing circulation in the foot. The same balloons, the same angioplasty, the same wires, the same techniques were provided in these 2 patients. And look at the result at the end. This is the BED patient, so the big artery disease patient versus the SAD, the small artery disease patient. How bad is the distribution of the circulation of the foot in this left patient. So this is from one side, these patients are very similar regarding the baseline angiography, but from clinical point of view, these are totally different patients. In the patients on the right, in this one, there is for sure going to be a major amputation. So for this patient, this technique was developed, the so-called venous arterialization. You can appreciate the normal X-ray of these patients is a typical medial calcinosis, the so-called Mockenberg calcinosis, without any normal and healthy foot, healthy artery in the forefoot. These are all collateral vessels. In these patients, the technique can be also a hybrid one, combination of endovascular and surgical, and also can be totally and completely endovascular. So what basically is they try to go from the venous side, they break the valves and connect the arterial system with the venous system. This is why it is called the venous arterialization. And this is one patient from their study, which I'm going to show you later. They managed to save with only transmetatarsal amputation. The right leg was previously amputated. So in some patients, this can be the only and the last option. They published the results of combined hybrid technique of percutaneous and surgical venous arterialization. They managed to have a major amputation rates of 30% only with limb salvage of 60%. And time to the healing of these wounds was approximately 8 months. For the percutaneous group, there are several ongoing studies which are investigating the completely percutaneous approach for making venous arterialization with a nice technical result. For example, this group from United States, Jihad Mustafa group, they have the technical success of 100% and amputation-free survival around 100% as well. To conclude, the no-option CLI patients, foot venous arterialization can be proposed as the last attempt to avoid any major amputations. Percutaneous deep venous arterialization using the lymph flow system is a novel approach for treating these no-option critical limb ischemia patients, and this can lead to reducing the amputation rate in this severely diseased population. Thank you very much.
Thank you, Alexander. Great talk. Questions from the audience to Dr. Gurevsky? No. Okay, Alexander, thank you once again. But
thank you for inviting me.
But we are so late, so we continue. I hope you watch us. Okay, bye. The next presentation is in which circumstances is open vascular surgery a better approach than endovascular. We have the presenter here. Okay, Dr. Rahul Velenini. Thank you.
All right. Hello, everyone. Thank you for inviting me. I've been a bit embarrassed by how good you all are at endovascular stuff. So I'm just here to present a slight counterbalance. So I'm from Edinburgh. We wrote the paper saying EVAR may not be a good thing 20 years ago, which we slightly regret. Yeah, so how are we go? So I think the short answer is if you can do endovascular well, do it. I believe open surgical treatments still exist. I think the envelope for open surgery is getting smaller and smaller, and in about 20 years' time, I will probably be a fossil. However, there's an English phrase, multiple ways to skin a cat. There's many ways of treating a problem, and given the training I've had, which has been endo and open, I've developed my own personal biases, and I thought I'd just present some of the stuff that I've been up to for the last couple of years. So, the definite opens. I don't think you can do an amputation endovascularly yet. If you could, I'd be very happy, because I do a lot of them. Big bleeding major trauma inside the belly or in the leg. I think a lot of what I've done has been open, and clearly you can't explant something endovascularly yet either. Mostly open in my practice. I do my renal access open. I appreciate that. I'm very excited about endovascular fistula creation, but for us, it's not just yet. I tend to reserve the common femoral as an open surgical field, which could be a talk in itself. And I tend to do long complex lesions or complex lesions open, or perhaps as an endo salvage. And then, a bit controversially, you may have read the NICE guidance in the UK. We've been told to do our infrarenal aortic aneurysms open. I won't dwell on that too much. We have a thoracoabdominal service in Edinburgh, which does open and endovascular. So we're very proud of that. And clearly there's a little brackets, connective tissue diseases. I would strongly advise that open surgery might be an idea for those particular patients. So trauma, just a slide, something gory I found on a Sunday morning in Edinburgh. Couldn't fix his endovascular, had to fix something open. A few arteries needed fixing. There you go. And just another one, again, I'd love to be able to fix this endovascular, but an exploding fistula, I just ligated it open. This is just me being silly. Going back to the true niggles, I'm not very good at reconstructing CTs, but the only vessel that this young man with critical limb ischemia had was a patent PT at the ankle. And all his other tibials were obliterated. He was in his 40s and he smoked like a chimney, which is quite common in Glasgow. And so I did a bypass and it worked. And then again, a long femoropopliteal block, no stump. He'd had an iliac stent, one of my colleagues a few weeks earlier, but hadn't fixed his critical limb ischemia, so I just went in and put a bypass in, which was done on my birthday in 2021, and as of July 2022, it's still patent, and I hope it remains patent for a long time, because he's a kebab shop owner, and he provides kebabs for me once in a while. This one's a bit controversial. I appreciate there might be some endovascular options. This is an older woman. She had great vein. She had a horrible femoropopliteal lesion, but if you look carefully at the trifurcation, it's heavily diseased, and I was a bit wary of trying to recanalize that. And given the complexity, I opted for a reversed long saphenous vein bypass, and in Edinburgh we're taught to do the lateral approach, and I think it looks very well, and to all my knowledge this is patent as well, but I've not brought my data, so I could be lying. And then again, this one was a no-hoper because I was told not to do him because his calcaneum had broken down, and I wasn't quite happy with that because this is a young man. So these are the duplex reports. He had a long femoropopliteal occlusion. We could have probably got through this endovascularly, but in the presence of a very good vein and a relative youth and relative fitness, I opted to do a bypass, and his heel was debrided aggressively. I shaved back the calcaneum. At the same time, he got out of hospital. He has 2 legs and he still works in Edinburgh as a hospital porter. And then, obviously, the common femoral artery is something I reserve for open stuff. This is a slight exaggeration of the thing, but I replaced everything and did an interposition. Maybe that was the wrong idea, but I felt that an endovascular solution to this would not be very good, so I did this with the backing of my excellent colleagues in Edinburgh. And then, clearly, I had to explant something on someone else. This was a bailout for a chap who'd had very good SFA stenting in another hospital. I had to pull out the clot and do a bypass, which is fine, but I couldn't remove the stents without doing something open, so evidence for open, perhaps. And then this was a slightly horrible aneurysm. Double renals, short barrel-shaped neck. He was 20 millimeters just below the renals, but he ballooned up quite nicely. He was being worked up for a FEVAR, which would have been 6 fenestrations, but then COVID happened, he got delayed, the device never turned up, he turned up with a rupture, I did him, I made a neck out of it, he survived, albeit with an incisional hernia, but he's done well almost 2 years on, which I'm delighted about because he's a very fat, unhealthy man. So I still think we need to do open aneurysms. This one's interesting. This is a man in his 50s, not a smoker, no atherosclerotic risk factors, isolated right iliac aneurysm. I appreciate Dr. Hamid presented his wonderful series of iliac work, but this is we strongly felt this was connective tissue disease, and on the basis of it being connective tissue disease, we opted for an open repair because we knew the tissue would be rather friable, which it was. Every anastomosis was pleated. It wanted to fall apart at repeated opportunities, but we got there in the end. And what we've done is we've done an infrarenal to left common iliac graft, and we've gone onto the right internal with the Y limb of the graft and done a jump onto the external. He was discharged 4 days post-operatively. So when people say open repair does have increased morbidity, I would counter that by saying if you do enough of them, with good anaesthetists and good institutional knowledge, you can get a good result. And I think doing open was probably the right thing in this particular man because of his connective tissue. And then this video may not play, but this was an awful, awful, awful type 4 thoracoabdominal aneurysm. I walked in to see one of my colleagues. I was hoping to show you the video that demonstrated a hole in the aortic wall feeding into a false aneurysm. So this is basically a retroperitoneal approach. A jump to a renal, the other renals encompassed in the visceral island patch, and again, a good result. But given the horribleness of the visceral segment, endovascular may not have been the right thing here, but we, because of our case series and our experience, were able to get through it. But I have to hand up, I do not do thoracoabdominals very often, so I have to give the credit to my excellent colleague, Mr. Fowler in Edinburgh. And then we're going to try and make this slide go forward. And just to put something in there, I do endo treatments. This man had a long femoropopliteal block with a stump. He had a horrible bit of tissue loss, and I debrided it. We got an SFA angioplasty. It worked very well. He had no vein. And so just to put it out there, I believe in the duality of our practice, or the triple phase of our treatment, which is open, endo, and hybrid. So we do endo in England and Scotland sometimes. And then just to say thanks to all the colleagues I've worked with over the world, I'd like to point out particularly that we can't always cure, but we can always care. I didn't say at the start that I have no real institutional or sponsorships, but I do use a lot of Proline, so I'd like to thank them particularly for my jobs. Appreciate I've been a bit offbeat, but if there's any trainees out there who'd like to come to Edinburgh, you can find me. We would welcome a fellow every year, so please get in touch if you need me. Any questions or queries? More thanks to my colleagues.
May I ask? So thank you for the nice overview. I have two questions. The first question is, what about the carotid artery disease? What is your standard?
My standard at the moment, well, the UK is quite defined. We're driven by NICE. My training has been open carotid endarterectomy, which I think is a set-piece operation we do. In Edinburgh, we do it under local anaesthesia. We're home the day afterwards. I think carotid stenting is catching up. Based on the numbers, I suspect I'll be out of a job for two reasons in 20 years. One, because you've got the endo guys will have done so many good endovascular carotids, and there's worked out brain protection. The second reason is I think there are moves to repeat the 1980s trials for symptomatic carotid disease. I think they will show that best medical therapy will take away a lot of our work.
Okay.
So,
second question, popliteal artery aneurysm?
Tend to do it open unless unfit, and then when the realms of the unfit, we would go for covered stents.
Okay. And the third question is, do you have experience, because I really like it, instead of doing bypasses for long SFA, or in case that we have an iliofemoral disease, have you experience with closed endarterectomy with a Folmer ring? Are you doing it in UK?
I think it's an idea that's come back and around, because back in the day, people would use the ring strippers to pull out a lump of rubbish from the iliac artery. So I've probably modified that technique from open perspectives.
Yeah, okay.
But we better not talk about it, because one day I'll get into trouble.
Okay.
Good. Anything else, I think? Thank you all.
Thank
very
you.
much.
Cheers. Thank you very much.
Next will be Abbott symposium. Okay. Floor is open to Fernando Gallardo. Endovascular treatment as novel alternative to endarterectomy of common femoral artery, interwoven stents approach.
Hello everybody. Hi, I'm Fernando Gallardo, vascular surgeon from the south of Spain, from Marbella. Thanks to the Society for this invitation. It's my first time here, and I'm very honored. So my lecture is going to be of a very controversial topic, which is endovascular treatment of the common femoral artery. And obviously I'm biased because I'm a vascular surgeon, okay, but I think it's a very interesting topic to discuss. First, I will start with some case presentation, and later we discuss a little bit the literature review and the standards that we have now. Okay, my disclosures. Okay, this is prior consideration that here is good. We are vascular surgeons, so cardiologists, angiologists, radiologists, but we need to understand that as vascular surgeon, for most of us, common femoral artery has been always a no-stent endothon, okay, based in the previous studies. And even no matter what data literature, it's a very basic technique for us. No complication in most of the patient. It's easy to assess surgically. We are the best doing this compared with other specialists. It's basic procedure during the training of vascular surgeon, and we can say that it works very well for most of the patients and with very good mid and especially long-term data. And do we really need to advance in the common femoral artery compared to below-the-knee procedures, ACFA? That's a question, but I think that yes, that we need to advance because not all our patients are good for SEA. Because we all need to accept that surgery has inherent complications that will never be eliminated, especially in frail and obesity patients. And also that we compete in this world with other colleagues, cardiologists, interventional radiologists, and they are going forward and doing this case. So if we want to keep involved with, we also need to go in this way and lose it. If not, just look on Inclady, whatever, and you will see a lot of with scalpel, no blade, no scars, and patient read that. So they have to know which case could be good for endo, but which case not. Okay, and why is not yet endo the first option for common femoral artery? We know that in the aorta and SFA and iliacs and other territories, endo is going more and more, but not here. Why? Because here we have some specific issues of the common femoral artery, especially the origin of the profunda of the SFA. And that the literature that we have, especially in the early times of the endo treatment of the common femoral artery, was not good and was really inferior patency compared with open. It was like 10 years ago. And that we need to recognize the importance of the profunda femoral artery. And some people confuse treating of endovascular common treatment of the common femoral artery with total reconstruction of the bifurcation. That is a little bit more complex. Okay? Why? Because also here, if we have embolization or we rupture the profunda, we have a dramatic situation. So this is something that scares many surgeons and interventionalists. And especially because this area, we know that there's flexion and torsion issues. And that the strength fractures happens. Less nowadays with the stent that we have nowadays, but in the past when people use balance expandable stent or other kinds of stents, they cannot be used there, okay? Because it happens, really. So the interest, but still with this, the interest in endo is growing now. No? You just make a literature review and you can find a lot of publication, especially a lot of publication in endovascular treatment of common femoral artery, and very few more publication on the TIA in the era of endovascular times. So maybe we can find some selecting indication nowadays for common femoral endovascular therapies. I will tell you what are usually mine. First is that the anatomy should be favorable for endovascular treatment. We know this also for the aorta, so we cannot treat nowadays with our tools all the common femoral artery with endo, okay? Probably what's going to do better, mild to moderate calcification, neo-intimate hyperplasia, and especially radio intervention after previous surgery. Why? Because if we have a very, very big stone of calcium on the common femoral artery, we need to start with lithotripsy and then with the vessel preparation or dart atherectomy using a distal filter, and it increases the price of a procedure that can be solved with just a simple incision. In my opinion, the presence of previous surgical is one of the main indications. None of us like radio intervention, and we know that many radio interventions are associated with complications, and it can be solved easily with angioplasty. And also, we need to make into account the patient's choice and the doctor's choice to avoid radio surgery, especially in obesity and severe comorbidity space. And it's very important that, in my opinion, that the origin of the profunda is not very highly diseased, because we don't have nowadays good tools to perform a profundoplastia. That is a technique, very good technique, that have excellent results. I will show you some of my case. My experience is limited. I have performed with 20 cases of treatment of the common femoral artery over the last 5-6 years, so it's not something that I do all the weeks, because I prefer to do, for most cases, endarterectomy. But this is an example. 74-year-old woman, obesity with rest pain. Many times the total occlusion of the common femoral artery is associated to the external iliac and the origin of the SFA. In this case, you can see how what I do usually is my contralateral approach with 5 or 6 friends. I go to the occlusion, okay, and then I start with an MAP, or sometimes if I think I'm going subintimal, I go directly with an 0035 and I make a small loop and I go inside with a total occlusion. I try always to keep intraluminal, then it's better to go with an 018 guide wire. But in this case, I need to tell you this is very difficult to go totally intraluminal with. Even they are not very long occlusion nerves, the common, they are very, very calcified and occluded. So if there is occlusion, I do a small loop. And here, the key point is where I enter my loop. I always try to go in most cases to the profunda, if the profunda is open, okay, because it's the vessel I never want to lose. Here, I'm playing a little bit with the guide wire there. And finally, I reach the bifurcation previously to the bifurcation of the superficial and the profunda, and then my choice is always, in this case, going to the profunda first, okay? And though do an angioplasty, preparing the vessel to the profunda, to the common or external iliac artery. Why? Because with this maneuver, I can close sometimes the ostium of the SFA, but it's quite easy to recover the ostium of SFA if you go distally and do a retrograde puncture. But the recovering the profunda is not so easy distally. It goes deep, and you can do maneuvers to do the retrograde puncture, but if you lose the profunda, it's a disaster, and we all know that, okay? So in this case, I go to the profunda, then I do an angioplasty, and I open it. Then I put a guide wire, a small guide wire in the profunda to protect it, and then I go to the SFA, and I do an angioplasty, and I get my bifurcation reconstruction, okay? So in my opinion, in this case, if the result is okay, I don't put stents, okay? It's better to avoid the stent as much as we can in the common femoral, even if we have the supera that work well. So what I do is angioplasty of the common femoral artery, and then if the external disease is yes, I use a stent there, usually a drug-eluting stent or a self-expandable stent. So finally, many of my cases I can solve it just with balloon angioplasty with drugs and the common femoral artery. The next case is a woman 71 years old with obesity, rest pain, and stenosis of the common femoral artery and occlusion of the SFA. This is probably the easiest case I can do with endo approach. The same contralateral approach, 5 or 6 French sheet, and here it's quite easy to cross this stenosis, okay? And here you can see the result previous to the angioplasty, it's about 70% stenosis, and here, and also was associated with occlusion of the SFA. So I could easily cross the lesion, I could use a balloon angioplasty, drug-eluting balloon, the result is appropriate. If I see this kind of result and I don't see stenosis here, I don't put a stent there, okay? And then I could recanalize the SFA and use a drug-eluting stent in the SFA. And this is, in my opinion, the most complex case of the common femoral artery. This was a 75-year-old man from UK has a previous right bypass to the below the knee that is working perfectly in the left. And in the left, he also has previous profundoplastia and other procedure that was a distal bypass that was occluded. So this case is more complication because the external was not totally occluded, but you can see it is filiform, and especially the groin. In this case of radio intervention, I usually do my planning for volume rendering reconstruction to study where I'm going to clamp distally the profunda. And here we can see the profunda is very bad, and also that this groin with 2 previous intervention, all the ganglions are inflamed, so it's not going to be an easy procedure for radio intervention. So what I decided to do is going contralateral. Here you can see some of the reconstruction also on the MPR, and there is almost no common femoral artery, very calcified, occluded external, and there is not a good profunda. And if I go to the profunda, I have to go distally. The SFA is also occluded. Distally, the popliteal is patent, but also the third portion is quite bad for doing a distal bypass. This patient has also previous surgery. So what I decided to go is go contralateral. I go with my long sheet, and I go to the external. The external was quite easy to cross, but the problems arrive when you go to the common femoral artery, and everything is closing, and you don't have where to go. In this case, the profunda was not good. So what I try to do is keep as medial as I can to the patient, because usually the stamp of the SFA is there. So you go medial, and I try to find the stamp of the SFA. Obviously, I'm going subintimal here. It's no way to go intraluminal in these kind of situations. We can see the profunda now distally. And what I did is crossing until I was here. I'm going the more in the inner part of the artery that I can, avoiding the profunda and going to the superficial in this case. And I could reach the SFA distally that was also occluded, but I could recognize it. So finally, I could cross my guide wire from the external occluded to the SFA. And I do an aggressive recanalization of everything, very good vessel preparation until the below the knee arteries. Here is very important. If you are thinking using supera, do a good vessel preparation. If the vessel preparation is not okay, don't use supera. It's not going to work, okay? But in this case, the vessel preparation was okay. I start deploying my supera over the knee, and I go up, and I cross the common femoral artery, and I go just to the origin of the sternal artery. You know that supera is very good in precision distally, but proximally is not as good. So here I just wanted to cross the common femoral artery with supera because it's the better stent to cross the common femoral artery. You can punch on it again. We will discuss it later. And for the external iliac artery, I prefer to do other kind of stent that are more accuracy, probably drug-eluting stents, self-expandable stents, that I'm very sure that when I deploy it, it keeps there. Supera can be moved proximally. And this is the final result. This is a comparison of how it was previous. Probably you can say, well, the origin of the profunda is lost. Yes, it was previously lost. And the patient, I accept this. And this is the result. And this is 3 weeks later that the injury was going okay. So just to finish, we need to accept that endovascular approach for the common femoral artery is not the best approach nowadays for our patient, but probably yes for some selected and frail patients. And this is the patient that we have to be most worried. We don't need to worry about the 60-year-old man who is going for a common endarterectomy, but yes, the 85, the radio interventions, and the more frail patients. Thank you very much.
Fernando, I have a question.
Yes.
We have atherectomy, shockwave, primary stenting. What is actually your strategy now?
Yeah, I agree with you. We have a lot of new tools to treat with the common femoral artery also. But if we start to do first recanalization, then atherectomy, then if I do atherectomy, we recommend many times using distal filter. Here in the common femoral artery, where I put the filter, in the profunda, in the superficial, to fistula at the same time is complicated. Drug-eluting balloon plus stenting. Well, there's a lot of new technology, but it's very expensive also. I cannot offer this approach to most of my patients. Even in the public or working in the private with insurance is forbidden, okay? In the future, probably with this device become more competitive, we can offer to more patients. But I think that very few centers or very few specialists can now offer all this pool of different techniques to the patient. Probably, if you have a very big plaque of calcium, you can do lithotripsy and then atherectomy and drug-eluting balloon, it will be okay. But we need to compare against common femoral atherectomy, cheaper, good result, and even from now. And now at this moment, better results at long-term patency attendo. So in other aortic, in other territories, aorta, carotid, we can discuss, but in the common femoral artery, we need to show really superiority to what we have nowadays. And maybe superiority is combining 3 or 4 different endovascular tools, but not the moment.
Very, very nice presentation. In fact, I'd like to ask you and also the panel, for example, patients with strictly osteo SFA occlusion,
yes,
with big calcification, in many cases, even after relatively successful crossing, we have really a flow-limiting dissection on the ostium. And we have to stent.
Yeah.
What is your strategy? To stent cross over the bifurcation or just to protrude several millimeters over the carina in order to leave some space for further surgery and so on?
Yeah, that's a very good question. You know, one of the main failures of treatment in the SFA, especially at the old times with Viavan or the base with very few stumps, is that people are not aggressive with the stump of the SFA, and we have to be aggressive with the stump of the SFA. It doesn't make any sense to do a 15 or 20 centimeter recanalization and leave the stent 1 centimeter behind or below the ostium of the SFA, because the ostium, we know from endarterectomy, how is the ostium of the SFA most the case? Diseases. So now my practice is that I go always a little bit inside the common femoral artery. I have never had a problem occluding the profunda femoral artery. Never. You need, I think, to go very, very aggressive, but if you go a centimeter proximal, you are safer. You open with the inflow, you dilate it a little bit with the balloon. And even I have done surgery in this patient after, and people say, oh, you cannot clamp because there is a stem, wherever. We have many maneuvers to do endovascular clamping nowadays. So in my opinion, the bad thing to do is don't treat the ostium at the SFA. So if you need to go a little bit 1 centimeter in the common femoral artery from down, go 1 centimeter down. Be careful, because something, the plaques in the ostium of the SFA, if you touch it with the balloon, you close the profunda. But if the profunda ostium is okay, is healthy, there's no problems. But be aggressive treating always this.
The same.
I have a question. And in case, sorry, Dr. Vocev, in case the profunda is critically stenotic, do you perform a bifurcational treatment, kissing balloon, additional stent at the profunda, or not?
I have done not many cases, because in my opinion, when the profunda is very diseased at the origins, endovascular is not nowadays the best option to do. Okay, yeah. But yes, when I have done, you can do kissing balloon in this area, or even in some cases when I have destroyed it, the profunda tried to recanalize and no stent SFA cases, I have to do kissing stent in the area, or one stent in sequentially the others, but it's not my favorite choice. But anyway, you have to use self-expandable stents and never balloon-expandable stent.
I'm using a self-expanding stents for the common femoral and the SFA, and then I'm getting through the stent struts with a balloon expandable stent, because all self-expanding stents in the deep femoral artery do not work, or they are too long and they will cover the first branch of the deep femoral artery. So due to the fact that the deep femoral artery always goes deeply, you will never you are not at risk when you are checking the pulses that you compress the balloon expandable stent.
Yes. That's true. We need shorter stents. Now, we have multi-lock or other device. There's 3 centimeters, but 4 centimeters when you need to treat a problem in the ostium of the profunda, you go distally. Yes.
Sorry, yes.
The bad thing about the endovascular treatment of common femoral artery, in my view, is that we try to save some money, not do lithotripsy, not do directional atherectomy, just put the stent. But once we start endovascular, we should deal with the failures endovascularly again. And this adds much to the cost because, let's say, the stent occludes in the future. We have to use Rotarex device, we have to use penumbra to suck out the fresh thrombus, and the room for open surgery becomes very complicated, especially if it's a long stent in the external iliac artery. We have to clamp through the stent. Sometimes we have to pull the whole stent out. So we start cheap, but at the end, it gets very expensive.
Yeah. The treatment of the total occlusion of the common femoral artery is not a cheap procedure. So that's the other reason to keep selected for some complex patient.
So maybe the important thing here is patient selection, as always. Yeah.
Not to do, I'm going to do endo for most of the patient. It's not going to work in the common femoral
artery. Do you
artery
perform a retrograde puncture of the deep femoral when you...
I have done to perform 2-3 times in the case of stress and occlusion of the common. You can do it if you have habitude to do ultrasound guide puncture and you use longitudinal, you can go distally. Yeah. You have 2-3 centimeters, you can do it, but it's not an easy maneuver because you go very vertical.
Deeper,
The good thing, the most of the time that you have just occluded the profunda because you have moved the plaque, you can easily recover it. Mm-hmm. If you go on the lateral way of the artery, most of the time you recover it fastly.
Okay. Thank you.
Okay. You're welcome.
Next presentation is yours as well.
Yes.
So we are listening to you.
So now what we're going to discuss is a little bit, after seeing this case, is the evidence that we have today to treat the common femoral artery, and especially with the new interbowen stent approach, with mimetic stents. Okay, so this is the end of the presentation. And we need to know, we have talked previously, that the anatomy and vessel characteristic of the common femoral artery is challenging for stenting and for endovascular treatment because there is a flexion area, there is the profunda is there, and there is a risk fracture risk of the stents, okay? And also because disease of the common femoral artery can be very variable. So in some patients, just 90% stenosis of the common femoral artery is going to be easy, but if you have disease of the common, of the profunda, of the ostium, of the SFA, and involve the femoral evacuation, it's going to be complex and expensive. And especially, it's very, very, very calcified. You can use lithotripsy, but after lithotripsy, more things and more things. And we have said before, it's easy to reach for surgical treatment. The patency, primary patency is superior nowadays with surgical access. And the results of the stents here, we have still data, I will show you later, that is about 2 years, but not long-term data. And many stents compromise posterior, use the common femoral artery as access. So why is still SIA the gold standard? Because it is the gold standard for most patients with common femoral artery disease, because the results are very, very good. Are very, very good, but we need to accept that there is also a dark side of the surgical approach to the groins, especially in elderly and obesity patients, okay? Because it happens to all of us, especially in red interventions. So I like this paper, but I don't like at all the conclusion, because I think that the terms is not as benign as procedure cannot be applied to surgical techniques. It's like we say the open artery repair is not as benign as we think. But this is the largest study that we have after carotid endarterectomy, and show that 15% has convenient mortality and major complication rate. But using the term is not as benign as endovascular is, in my opinion, disagree. But this paper showed this complication happens after carotid endarterectomy. After femoral endarterectomy, sorry. What happened with the early endovascular results? We go to these results, they were published years ago, and they were early comparing the use of just PUVA on the common femoral artery or stents that are not appropriate for the common femoral artery. So obviously the results were very poor. So everybody say, yes, stop, don't treat the common femoral artery endovascular because the results are not okay. But we cannot compare this data with we have nowadays. And we can see still that the complications were obviously lower than with surgical repair, but the patency at only 1 year was yet lower than femoral endarterectomy. But industry is pushing, we have new publications, and it seems that in the last year, endovascular treatment for the common femoral artery is going better. And we have a lot of paper published that is associated with high rates of clinical success in claudicants. Obviously, in claudicants, our results are going to be better. A claudicant, they usually don't have associated disease of the common, the profunda, and the superficial. And they suggest that endo can be a valid alternative or surgery, and that it seems to be a safe technique. Okay, so we're going to go further into this paper, and they may represent an important alternative to surgical alternative, but it's an alternative, not still as at the endarterectomy. And the endovascular seems to provide substantial clinical results, and the fear of stent fracture and local complication due to hip mobility are no longer relevant, because nowadays no one is using balloon expandable stents or not appropriate stent. They are here. And we have the TECO trial, that is the most important trial comparing surgery versus techniques, that they construct the results of the endovascular were very good, and the morbid mortality obviously is significantly lower, and the outcomes are comparable, not superior, but we have comparable results, okay? So we have more papers about the same groups and the TECO, and they present that the morbidity mortality obviously is lower with the stenting, the hospital stay is lower. At the 2 years, primary patency seems not to be different, okay? And we have more papers and more publications, 7 years, that percutaneous common femoral artery is safe, and they consider in some of the papers that with new stenting is safer than atherectomy and PTA alone, but it depends again how is the lesion. And probably the revolution is the apparition of the use of mimetic stents at the common femoral artery. These are very good papers, most of them published by our friend Cohen-Deleuze, and it's very nice what they write in the paper, and we will discuss it later. If Supera correctly implanted, now because you know that it's a stent, it's quite different to the others, and many of the results can be for not very Supera operated and not correctly implanted. So good results are associated with correct implantation of this stent. And also in the study, most of the patients are claudicants, so just Rutherford 2 and 4, so probably not very extensive disease at the common femoral artery, and the short-term results are quite very, very good, okay? So we have more papers comparing endovascular and surgical with less complication for the endo, and the TECO trial finally demonstrated that endovascular therapy with stenting is a viable alternative to endarterectomy. So it seems to be an alternative. Although the use of stent is in the common femoral artery, they conclude is not preferred as primary strategy. No? So if we continue advancing, there are more trials coming, and the most interesting I want to discuss with you is why Supera can do better than the other stent here. It's because Supera maintains as much natural behavior and function as possible in the area. This is a flexion area. Supera, you know, is a mimetic stent, but you need to get an almost perfect opening of the artery prior to deploy it. If you have still a stenosis 50%, you cannot do like with other stent. I put the stent, and after I will balloon my stent, it will open. It will not happen with Supera. So if in Italy you don't get a good vessel preparation, use other stent or other strategy, because if not, it doesn't work. You cannot put a Supera and then try to open it. And this is a compliance stent, minimize chronic vessel injury. That's the reason, because we need to go 1-1 with Supera, avoid oversizing with Supera. If not, it causes infall, and it's not a good option. And other good thing of Supera in the common femoral artery is that you can puncture it later, and you can go with a sheet inside. You can puncture many stents in the common femoral artery. We know that some colleagues, sometimes the cardiology, they need to put a stent because it's bleeding. The problem with stenting in the common femoral, other stents, that you can puncture it, but when you go with a sheet inside, you destroy it. Okay, so with this stent, you can do it. It has a very good flexibility, resistant to compression, if well delivered. The problem is if the vessel preparation wasn't okay and the Supera is elongated, an elongated Supera doesn't make any radial force. So it is a bad option. And we have trials with the first clinical evaluation of Supera that were presented by Cohen-Deleuze some years ago. And if you look with detail, 80% of the patients were claudicant. 90% required only single Supera, obviously, because we are treating short lesion in the common femoral arteries. And 80% of the case post-dilatation was performed. I also do post-dilatation of a Supera in a standard way. And we have the very good result with the primary patency of 2 years, 93%. And we have also the conclusion of our colleague that they say that things are changing, that now no endovascular for this baby statement, like we say for the common femoral, is not appropriate. But we are not still in the time to offer it to all the patients as we offer endarterectomy. So probably, just to finish, the recent endovascular publications are pushing and how show support with treatment endovascular, the common phase. The Supera seems to have high cure resistance flexibility and seems to be the better option to treat the common femoral artery. And just the key message to take home is that still endovascular indication for the common femoral artery is challenging. Probably for stenosis, radio intervention can be okay, but for most patients, it's not the best option nowadays. Still, endarterectomy is the best option with long-term and mid-term patency for most of the patients. But yes, we have now an alternative for the case that we have shown you, with that we have only data 5 years are coming, but not yet, that we need still more studies to compare a technique with 10 years long patency to this new technique, especially in this area. And that we need to keep working on this, but not go directly to the endovascular treatment. And just a very good friend of Spain, Hristo Stoikov, who is a Bulgar that we all love. Yeah. Thank you very much.
I mean, you're using Supera in order to have crash resistance and to have a good stent for such a flexible part of the body. But we know from a study from GUFEC that the most flexible part is not the common femoral, it's the distal external iliac artery. So do we really need Supera for this reason? And why just putting whatever stent you want?
Yeah, and especially a Supera that is not a drug-eluting stent. The question is the result with the other stents in the common going to the SFA or the Profunda. In the early studies, they were not. We cannot compare Isabel and Orange because they were also balloon expandable stents. But the problem with other stents might be that you are limiting posterior options in this area, especially about punction of this area. Because I agree with you. Sometimes we do hybrid procedures and we do a patch in the common femoral artery. But some publications also say go with the stent to the patch. That is the more flexible, and we are using self-expandable stent, and we are finishing in the patch. So that is the curve, and the result seems to be okay. But yeah, in my opinion, Supera, what gives you is that more flexibility in the area, and if the vessel is well prepared, the radial force is very good. But the problem with this stent is the learning curve. Many surgeons in my country, they don't like Supera because they are used to other stents that they just go there and you deploy it fast, and we go and the results are okay. If you do this with Supera, it fails. You need to take 3-4 minutes to deploy it, slow, looking with big image and compressing it, it is going okay. If you deliver on a bad way, and it happens in the learning curve, the results are not okay. That's one of the reasons because many people doesn't use this stent.
But my problem is with the Supera, the common femoral, is that when you're using the 6.5 and the SFA is 6 millimeter, then you are not implanting right.
Yes.
Okay? And then you're starting implanting right after the SFA. Yeah. If, on the other hand, the SFA is good and it is 6.5 is ideal for the SFA, then it is too small for the common femoral artery.
Yeah.
How you're dealing with this?
Good point. Also, I combine with a self-expandable stent at the end, because another big problem with Supera that they need to solve is you can predict very well the accuracy distally, but proximally, no. And if someone tells you I'm accuracy in the distally part, it's lying because you are doing a lot of money over compressing it here, more calcium. So finally, you assume that you're going to end at the origin of the SFA and you finish 2 centimeters down. Yeah. And when you finish 2 centimeters down with a new Supera in this area, probably I combine with other kind of stent. But for a specific use in the common femoral artery, and really I don't mind where I land. Up, I use Supera. Perfect. If I want to have accuracy proximally and distally, I use other stent or combine Supera with other stents. Okay. In my opinion.
Any questions? Yeah, Dr. Nikov.
We know that the bigger diameter of Supera is 7.5. Do you have sometimes problems because in men, especially, sometimes common femoral artery is even bigger? Do you prefer then self-expandable, regular, or?
You told me about the size, no?
The size,
yes. That's a problem because you need to go 1-1, avoid oversizing, but if you don't have more, I combine, as I say, with a self-expandable stent.
Yeah.
You mentioned post-dilation, that in most of the cases you are post-dilating. Don't you think it's better to make a good vessel preparation, very thorough pre-dilation and just opening the supera to scaffolding.
I totally agree. The vessel preparation with supera is so much more important than with any other stents, because if there is a problem, you cannot solve post with a balloon, okay? But anyway, in most of the case, even if the aspect of the supera stent is okay, I like to use post-dilatation balloons just to get it perfectly adopted.
I can guess 1-1.
1-1, not oversizing supera, 1-1.
Thank you.
Okay. Thank you very
so
much.
Dr. Petrov, yeah.
The next speaker, Professor Petrov.
I'll do my best to shrink my presentation. You have heard already about thermography possibilities. It's definitely a absolutely new option. Regarding the scope of peripheral artery disease, all of you are very well aware. It's definitely like a pandemic because unfortunately diabetes is a pandemic. And definitely the prognosis of these patients is very, very unfavorable. Because of that, screening of peripheral arterial, especially critical limb, chronic critical limb ischemia is very important. Unfortunately, the under-recognized conditions of peripheral and distal arterial disease are definitely quite big. The so-called screening not very precise. The most frequent screening is the pulse palpation, and unfortunately the other ways of screening, namely ankle-brachial index and duplex, are operator dependent and technology dependent, so the technology has to be there. And even more, in almost 30–40% of the cases, the ankle-brachial index is absolutely incorrect. So we need probably additional tool that is handy, and it's absolutely more doable without the complex technology like MRI, CT, that it's not largely available in many territories all over the world. I mentioned already that the pulse palpation is not so sensitive. What about thermography? It's an old idea, more than 60 years ago. The idea to use a thermography in order to have objective data regarding the skin temperature as a reflection of the peripheral vascular disease is really from long time ago, but nowadays with the better technology, with much better resolution, and with the addition of artificial intelligence, there are several publications, again, mainly in diabetics. For example, this publication giving the difference into the temperature after walking test in patients without peripheral arterial disease and with peripheral artery disease after walking. It resulted that the temperature is much lower in patients with peripheral arterial disease. And infrared thermography in diabetic patients is definitely quite a promising tool, especially when it's combined with good software based on artificial intelligence. This is the Kelvin health technology, artificial intelligence, that can be applied largely because it's done with a simple but high-resolution FLIR camera. For example, this is one of the patients with Leriche syndrome, and this is another patient with critical limb ischemia. And not only for screening, but it can be used also before and after intervention in order to prove not only what is the result, but what is the situation during the follow-up. And here is an interesting case of a patient with dissection, very young patient, 53-year-old, with type B dissection. He was treated on the standard way in our clinic with the implantation of stent graft from the left subclavian artery all the way down with excellent result. He had, in fact, since the beginning, the problem of the perfusion of the left leg. We implanted Manta after finishing the procedure on the left leg that was utilized for the Valiant Captiva implantation. And we had, during the night, thermography of this patient having the picture of definitely reduced perfusion both on the below the knee and the leg on the left side. And because he was complaining during the night of pain. And we described, in fact, we have found total occlusion at the level. You see the marker of the Manta just before the occlusion. We succeeded to cross. It was not so easy during the night to cross this total occlusion. And after the balloon predilation and stent implantation, the flow was absolutely totally restored, and not only on the level of the femoral artery, but also on the below the knee. And this was before and after. You see the picture before and after for the left foot. Definitely there is a full restoration, and this is also for below the knee situation, and even on femoral level, left foot before the procedure and after. So, as a conclusion, I would say that the infrared thermography, high resolution, combined with software artificial intelligence, it's quite a promising tool both for screening and for follow-up after the interventional procedures, both surgical and endovascular. And thank you very much for your attention. Questions?
I have a question. Amazing. But I have not understand who is selling this thermography. What is the company, or it is an application?
At that moment, nobody. In fact, it's a startup company that we are collaborating with them since 6 months.
Okay.
The name of the company is Kelvin Health, Bulgarian company. And we have gathered more than 900 patients in 3 clinics, in our clinic, and also in Tokuda Hospital and in outpatient clinic, Professor Tsonev. And there is quite good and consistent data, very good matching with ankle brachial index. And also in some of the patients we have also, that was also approved by the CT. And in fact, the screening tool is the thermography, and the control tool are the CT, ankle brachial index,
yes,
and angio. And we are gathering data, and the data are impressive.
I can imagine, because we have used always, when I was in Germany, a camera which actually did the same job, but it was massively expensive. The point is, you're using your iPhone or your...
In fact, it's a FLIR camera. It's a third generation high-resolution FLIR camera with this size, put on the iPhone, absolutely. At that moment, it's not compatible with Android. It's only with iPhone. And it's simple. It's we are making the pictures in 5 projections: anterior, posterior, lateral, both leg and foot in front. So these are the 5 projections, and we have screening in most of the patients in our clinic before the intervention and after the intervention, and after that follow-up.
Nice.
And it's we are on the level of pictures gathering. So we are making database of pictures. And we are going to validate the method in the daily practice.
Amazing.
But it's fast, very accurate, thanks to the artificial intelligence. So the artificial intelligence software is removing all the artifacts. So it's concentrating on only on the level of the organ that is under investigation. It's removing additional temperature artifacts, both from the body of the patient and from outside of the patient.
Okay. Wow.
Thank you.
Thank you.
Thank you very much. Let's go up. I think next presentation is...
Next. No.
In fact,
the next presentation
Herr Atanasov.
Endovascular management
I have
of
done
giant
it.
pseudoaneurysm.
Yeah, giant pseudoaneurysm.
Yeah. Dr. Atanasov, please.
Hello to everyone. For me, it's a great honor to be here this year again. I will present your clinical case from our practice, and I hope that you will find it interesting. So we're talking about endovascular management of giant symptomatic pseudoaneurysm of the superior mesenteric artery. As we all know, the visceral arterial aneurysm are a relatively rare pathology. The incidence rate is about 0.01, 0.2%. Most of them are asymptomatic, incidence physical imaging, and pathogenesis are not well known. They are associated with high rupture mortality. Measurement depend, of course, of indications. Could be surveillance, endovascular surgeon treatment if necessary, of course. The third most common visceral arterial aneurysm is superior mesenteric arterial aneurysm, representing around 5.5%. What about etiology? We know that the development of true aneurysm is due to acquired metal degeneration caused by atherosclerosis, a lot of group vasculitis, connective tissue disorders, spontaneous dissections, but pseudoaneurysm are totally different. The most common cause etiology is infectious or mycotic. Another cause include traumatic, is post-operative lesion of the arterial wall. Our clinical case, the patient was hospitalized urgently in the Department of Vascular and Endovascular Surgery. The patient was with severe osteoanatomic and consumptive syndrome with intermittent upper abdominal pain. Of course, following an examination in color contrast CT with the presence of large pseudoaneurysm as SMA was present. The operative intervention was performed as a matter of urgency. In our case, the development of pseudoaneurysm was due to the chronic pancreatitis. Damage on the arterial wall is due to digestive action of pancreatic enzymes. Okay. This slide shows our patient. We see the really huge formation in the upper part of the abdomen on the right, painful and pulsating. Patient was a 57-year-old man with chronic pancreatitis, as I said, chronic liver failure, anemia, chronic obstructive pulmonary disease, and arterial hypertension, and ischemic heart disease. There's no history of connective tissue disorders, abdominal trauma or operation till now. No history of embolic events and anticoagulant therapy to date. He had a history of intermittent upper abdominal pain for the last 2 years with slowly growing pulsation formation. Loss of appetite, heaviness, and pain between meals for the last 2 years with slowly growing formation. And the patient got over 72 hours severe abdominal pain. During the color-coded Doppler sonography, we found a severe atherosclerosis with vascular calcification, normal abdominal aorta and branches, and giant pseudoaneurysm of the SMA with parallel thrombosis without extravasation and rupture. And we've got a normal function of the venous system. This is CT angio before the procedure. We see the size of the pseudoaneurysm, length 111.3 millimeters and wide up to the near 100 millimeters. We see the lesion of the vessel and really huge pseudoaneurysm. This angio, another slice before the operation. We see the SMA, the lesion, the pseudoaneurysm. There's no evidence for rupture or extravasation. And this is a CT angio 3D reconstruction. We see here, well, pathology. Before endovascular intervention, the anatomy of the target vessels should be evaluated carefully. We took a lot of measurements to make a right choice which graft size to use. For this case, our first choice was endovascular repair of the pseudoaneurysm. Use typical brachial access with 6 French 90 millimeters hydrophilic sheet, 5 French multi-purpose anglet catheter, and 0.018 guide wire. After in this case we use stent graft system, bench graft system, 5 millimeters, a length of 38 millimeters. But after stent graft placement, we have endoleak type 1, distal graft attachment site leaks, and we use a balloon to fix it. 5 millimeters, a length of 40 millimeters. Can you play the video? Oh, thanks. This is intraoperative initial angio before the procedures. The selective catheterization is performed carefully, of course. We see the lesion of the vessel, the pseudoaneurysm. This slide shows stent graft placement. The first two images on left. Then balloon angioplasty was performed stepwise. And the situation after stent graft was deployed, we see the endoleak tip 1. After angioplasty, we got a good result. There's no endoleak. Sorry. This initial angio before the endovascular procedure and the final angio. We have a good proximal distal landing zone, no data for endoleaks, no fracture of the stent graft, and preservation of the distal mesenteric flow was done. This is ultrasound check after a procedure. We see there's no blood flow through the aneurysm. The sac of the pseudoaneurysm was thrombosed. Postoperative, the patient was discharged on the 5th postoperative day with good DCG signal of the superior mesenteric artery and branches, no clinical evidence of arterial insufficiency. We prescribed a double antiplatelet therapy, of course, in vasoactive drugs. Patient was with calm abdomen, without pain, without peritoneal irritation, with a restored passage. Follow-up after with calorie Doppler sonography at the first 4-12 months and CT angio at the 6 months. This slide shows the pseudoaneurysm before and 6 months after a procedure. We see that the size of a pseudoaneurysm was reduced twofold, length 50, near 54 millimeters and width up to 46. There's no data of endoleaks or extravasation. They show the pseudoaneurysm before and after 6-month procedure. Conclusions: pseudoaneurysm of the superior mesenteric artery are an extremely rare pathology with life-threatening, with a high risk of rupture. Timely endovascular surgical intervention and the performance of revascularization with restoration of trunk perfusion are decisive. Using the stent graft system can be a good solution for this problem. With exact precision and proper management, vascular treatment has a lot of advantages compared to this open surgery. Endovascular treatment remains the major challenge facing to the endovascular surgery. Pseudoaneurysm need to be fixed. Thank you for your attention.
Thank you, Dr. Atmasov. Excellent job.
Theo, I have a question for you. In such a lesion,
Yeah.
what kind of stent graft do you prefer? Balloon expandable or self-expandable?
In this case, it's balloon expandable.
Balloon
It was the right decision. The only point is that you were lucky that it was above the branches, because if it was in between, then you would be in a real trouble, because in that case you have to go either with the stent that they are using for the aneurysm of the brain, the flow diverter, or you have to go with a self-expandable through a stent struts and then to use 40 coils in order to close it. My question is, what was the reason? Maybe I didn't catch it. What was the reason for the pseudoaneurysm? Have you find it?
We think that was a chronic pancreatitis.
Chronic pancreatitis, okay.
The patient has a history 2 years ago.
And do you think that maybe, I mean, my problem is now you have a mass in the abdomen that it is getting smaller. Do you think that maybe it can be developed to an infected mass, or would you open it? We have discussed it when you talk, if we would open this and remove now the aneurysm, now where is everything under control. Would you think about it, or you think you will stay and you will look at it?
No, during the procedure,
I mean, afterwards, now in 1 year, or because you still have it inside. It is thrombosed, but you are running the risk that it will be cause maybe, a fistula with the intestine,
we
an
don't
infection.
have any evidence.
Nothing. Okay, good.
Without pain, and
you're
inflammation
observing
is reduced,
it.
yeah.
Okay.
Just observation.
If you allow me 2 comments. In fact, in relation to your question, we probably 1 year ago, we in fact implanted in a bigger. It was even with, in fact, not imminent, but in fact beginning rupture, with a drop of the hemoglobin, the low pressure, and so on. Dramatic situation. In a much more tortuous segment, you know, the splenic artery is not so straight like the superior mesenteric. So we are going to publish, we have with the Papyrus stent, it's a coronary stent, up to 5 millimeter. We have 14 patients of non-coronary application, even dramatic situation like a post-traumatic patient in coma with carotid cavernous fistula and so on. But in this situation, with almost ruptured aneurysm, it was again a patient from gastroenterology. In reality, the risk for infection was much, much bigger. And 1 year after the implantation, the isolation, the patient is doing fine. No fever, no infection. It was unbelievable. We were quite under tension what will happen with this huge mass. Like you mentioned, but it's fine. The other one is a short comment. In fact, in most of the cases, practically in 100% of the cases, after the stent implantation, there is still some feeling of the aneurysm. This is because of the porosity of the stent and because of the very big flow within the aneurysm. So it's the sealing doesn't happen immediately. In such a situation, we are implanting, like you did, overlapping with a second stent, a prolonged inflation, low pressure, 1-to-1 ratio, low pressure ballooning for 3 minutes. In most of the cases, it's a sealing.
Very nice.
Thank you. Thank you.
Last presentation.
The last presentation, Dr. Volchev.
Ivers.
Yes. Please put an end.
Dear colleagues, dear chairman, I have the pleasure to close this congress and this session. Okay, so as you can see, these are 2 meta-analyses from 2 different decades, and we can see that the truth is nothing has really changed regarding major amputation, regarding all-cause mortality. So we're basically still fighting with the same old challenges: residual stenosis, dissection, elastic recoil, restenosis, and device-related complication. And the things hasn't really changed so far. We're still trying to provide maximal luminal gain, and we're doing this by doing precise debulking and 1-to-1 ratio dilatation regarding the vessel diameter. We're always putting safety first. We try to limit overstretching, limit healthy artery wall damage,
and avoid distal embolization at any cost. Because if we push too hard, we might turn a claudicant to a critical limb ischemia patient, which is a disaster, and this is my biggest fear about these procedures. And furthermore, we're trying to provide some durable results for our patient, and by doing so, we must detect and to resolve early failures. This is mostly early recalls, dissection, put some stents inside the arteries, and the literature has always proven that we should use drug-based therapy. So what is in fact IVUS telling us? We can use IVUS either before or during the procedure or even after the treatment to check for size, lesion severity, plaque morphology, plaque extension, wire position is also important. And after the treatment, where I find it most useful is to check for dissection, for luminal gain, and for stent apposition. So according to the literature, strategy, device selection, and post-treatment evaluation is changed in around 70% of the time when we decide to use the IVUS catheter. Because in reality, if we don't have a lot of calcium, what we see on the angio is this white circle here. And the reality might be completely different. And why sizing is very important, because if we put smaller balloon, we expect recoil and poor drug delivery, as we've discussed many times today. And if we oversize, we may cause intimal hyperplasia and dissection, which sometimes are missed and lead to failure of the treatment. And you can see why sizing is so important. According to many studies, you see there's a huge difference regarding the diameters of the vessels. As you can see in the beginning, the proximal superficial femoral artery, when we measure it with the angiography, it's 5.5 centimeters. When we use IVUS, it's 6.4 millimeters, which is a huge difference when we decide how to choose our balloons. This is a very interesting study which offers 3 different strategies how to size our balloons. In the upper corner, you can see this is the best strategy, which offers the best results regarding the restenosis. This is the case where the authors decided to size the balloons regarding to the external elastic lamina. So in this fashion, they can achieve the best results regarding restenosis. When they use IVUS but size the balloons regarding to the luminal size or don't use IVUS at all, the results are much inferior. Professor Petrov has already showed this comparison trial regarding the use of IVUS and the angiography. Regarding the freedom from binary restenosis, you see it's much in favor of using IVUS plus angiography. And what about unhealed wounds? As you can see on the last picture, the use of IVUS has a significant impact on the outcome when we speak about wound healing. This is still, I believe, ongoing trial. It's called Prestige trial. When the design is very, very impressive, the author decided to measure the vessel diameter by using IVUS, then use some debulking to make luminal gain, and of course at the end use DCB for better results. The reason I'm showing this is because he found a significant difference of 1.24 millimeters difference when we check the arteries only with the angiography and when we use IVUS for this purpose. And this can make a difference. I believe Professor Bizas has mentioned that one of the reasons why the trials failed to prove that DCB is useful in the tibials is because the balloon size was highly inappropriate. They used, like, he mentioned 2.5 millimeters. I believe it's 2.2 millimeters for the tibials, which is massively undersized. So we will skip the basic IVUS measurement. We're really looking to find what is the plaque burden and why it is important, because this is a very recent publication from a Japanese authors
who said that, who discovered that if we put the end of the stent into an arterial area where there is more than 60% black burden, we can expect around 60% in-stent occlusion during the first year. And if we find healthier segment and we put the end of the stent there, we can expect less than 3% in-stent occlusion and more than 60% patency rate. And what about dissections? For the peripheral arteries, we don't have any dedicated classification. We are using this, I believe it's taken from the coronary field. And why are dissections important? When we talk about type A and B dissections, we can leave them untreated or with simple balloon angioplasty. But when we see type C to F, the likelihood of restenosis increases up to 200 times the nominal. So Dr. Shamas, I believe, tried to put into our daily practice the eye dissection grading system regarding the depth of the dissection, whether it's only in the intima A, in the media, or adventitia. And another important aspect is the extent of the dissection, which goes from below or above 180 degrees. So we can put all the dissection into a different category, and this is important not so much for the daily practice, but when we want to participate into some trials in order to be correct. So a couple of weeks ago, we had a very difficult 77-year-old male patient, and this was the worst case scenario. The patient is diabetic for many years. Furthermore, he has chronic kidney disease, he's a dialysis patient, massive calcinosis. He's been treated into another institution where they have put a self-expandable stent into the mid-SFA. And in these cases, we always perform CT angio. And on the CT angio, we saw that the stent into the superficial femoral artery was very, very compressed. But we know that CT angio is not always the best imaging modality for these cases, so we decided to do an angio. And in the standard view, there's nothing wrong with the stent. But once we decided to do some angulation, you see on the second slide, the stent is compressed. But can we say how compressed it really is? It doesn't look like a big deal on this image. That's why we decided to perform an IVUS, just to check what's going on inside the stent. You see, this is the end of the stent, widely open, some mild in-stent hyperplasia, which is to be expected in these cases. But when we wait a little bit further, you see that the real in-stent diameter is about 3.5 millimeters, which is severely compressed. So what to do next? We tried to put some balloons inside. First we started with compliant, semi-compliant. We switched to non-compliant balloon, but we didn't achieve any success. That's why we got the idea that maybe if we use shockwave balloon, we might crack the calcium and help with the opening of the stent. We used about 210 impulses, but unfortunately the calcium was so severe that we couldn't open significantly the stent. The end result was about 4.2 millimeters. So we decided to go back and see what's going on. The patient had intervention several weeks ago with DCB on the superficial femoral artery, and this is what we saw at the ostium of the SFA. That's why we had like 90 impulses left for the intravascular lithotripsy. We decided to use them wisely. So we performed 90 more impulses, and you see that the difference in the balloon opening on the second picture, you see the balloon is fully expanded. And what I saw is that we actually managed to crack the calcium as we spoke earlier. You see, this is the result after the intravascular lithotripsy plus DCB. And as you can see on the pictures, we have two cracks of the calcium and a very nice expansion without any signs of dissection. We decided to go further down, and we saw another dissection left untreated after the initial operation. So we performed another balloon angioplasty, but we couldn't heal the dissection, so we decided to put two supera stents into this region. So IVOS is easy to use. Cardiologists have been using IVOS for many years and they have some lovely results. So it gives us a lot of information. It's practically available in every cardiovascular unit. And we know it is irreplaceable in many pathologies like venous stenting, May-Turner, compression syndromes. Why not use it in peripheral arteries? Thank you.
I have a question. Did you open the stent?
No.
Ah, okay.
The sad truth is that we couldn't. We used like most of the intravascular lithotripsy capabilities. We were hoping to crack this calcium, but it was very, very thick. And the truth is that the stent was open to the subintimal space. That's also true. Because I believe the antegrade, the true lumen passage was impossible, so the colleagues went subintimal.
Theo, do you think there is a space for the Pierce technique here?
That is what I'm thinking. So we have some of those cases. This is not the exception. Actually, it's quite the reality, the rule. So Pierce technique has no option here. So we will not disrupt it. What we have started doing is to put very, very short balloon expandable stent as a spot stenting. It is quite, everybody thinks it is risky at that level, but you have no other option. It will close some in the follow-up. Maybe here, due to the fact that the flow is not bad and it would not have a high-grade stenosis, I think it is fine what you have done. But if you see that it does not open, then you have no other option. You have to do something to keep it open. And for example, a very good balloon expandable stent, I don't know if you have available here in Sofia, is the VBX stent for those cases, because it has the flexibility of the Viaband and the radial force of a balloon expandable stent. Otherwise, big graft plus, but very, very short, very spot stenting.
So, Dr. Vacho, do you think as a primary treatment in such a severe calcinosis, they should use the Supera stent? Especially if you told us that this is subintimal.
We're always discussing that Supera stents needs very good vessel preparation.
Yes.
Sometimes we cannot achieve vessel preparation in this so calcified lesion, even though we try to use different balloons, even non-compliant balloons sometimes fail. So unless we have perfect opening of the vessel with the balloon, I don't put Supera inside the vessel. Because the inappropriate use of Supera leads to very disappointing results.
And I think that IVUS makes sense in the peripheral arterial disease after stenting and not before stenting. Because before stenting, the point is you see IVUS means disappointment, because everything looks diseased. You want to start from the carotid to the pedal arch to stenting. So sometimes it is over, it seems that everything has not been treated well, but it is not like this. So I think it makes more sense to see if the stent is nicely open, to see if you have a severe dissection when you think that it is not severe, but not to evaluate where you're gonna treat the artery. This is my personal opinion, however.
I would absolutely agree. But sometimes we see some minor defect in the artery and say, we'll leave it this way.
Exactly.
And the next day the patient has a thrombosis or
I know. It is difficult.
And when we put the IVUS, we see that we have missed a huge flapping dissection.
Yes.
We could have easily fixed with a short use of
Yeah,
stenting.
but we cannot use IVUS in every patient. So.
Yeah, absolutely agree. Yeah.
Okay.
Any questions?
Any other questions? Well, thank you. Thank you, Dr. Vacho. Professor Petrov, some closing.
At last. Thank you. First of all, thank all of you for staying so late. And the problem is that our Congress is head to toe. So it cannot be concentrated in one territory for 2 hours and go home. And because always you want to cover head to toe, this is the result. 3 days, full days, almost full days. So First of all, really I would like to thank all the panelists, faculty members for the fantastic presentations. And definitely I think this was probably a conference, a course that was a step ahead. So I think we have done very well, very good job with the live cases, with the presentations. Not so well with keeping the time, but yeah, next time. Next time we are going to have the clock and the bell. Okay, thank you once again, everybody, online, on-site. Hope next year, without any obstacles like COVID or other obstacles, to meet again, probably around September, October, more or less the same time. And stay safe. Stay safe and have a nice evening in this Sunday. Thank you. Thank you so much.